Hi, Ramama. How are you?
Very well. Can you see me and hear me?
I can see you recovering very well now.
Thank you very much.
Yeah, please. Okay.
Dr. Rama Khoka is a senior scientist and professor in the Department of Medical Biophysics. She began her independent program at the London Regional Cancer Centre, then moved to Princess Margaret Cancer Centre, was the Vice Chair Biology for MBP and Interim Director of PMCC. Her lab studies tissue homeostasis and adult stem cell niches. Her work was recognized by Robert L. Nobel Prize from Canadian Cancer Society in 2014. She is an elected fellow of the Royal Society of Canada and currently holds a Tier 1 Canada Research Chair. We welcome you, ma'am. And Dr.
Thank you.
We already are well known. He is a Deputy Director of MIT Center for Translational Research and is an Organizing Secretary of Global Cancer Consortium 2025. I request them to start with the session and invite our speakers for this session.
Yeah, Dr. Gayatri, Dr. Rama, how should we do? You start the session, or I just follow it up with you, or how do you want me to proceed?
Don't you introduce the first speaker and I can introduce the next one.
Sure. Okay. So welcome all of you for this technical session, which is jointly chaired by me and Ramakoka. So our first speaker is Dr. Celine Gangora. She's from CNRS Research Center, and she's the director and head of the Drug Resistance and New Cancer Therapeutic team at the Montpellier Cancer Research Institute, and she completed her PhD in cellular and molecular biology from the Montpellier Institute. Celine, then she did her postdoc doctoral fellowship in the USA at the prestigious NIH laboratories. And when she came back to France, she worked on the colorectal cancer, she is focusing mainly on chemotherapy resistance, which is very important area. And today her research focus on solid tumor, in particularly digestive cancer, particularly colorectal and pancreatic cancer and urological cancer. So with this short background, I invite Celine Gangora to take over the stage. The stage is yours. But there is a small, advice or something for all the speakers to be in time, because we learned from yesterday that we have to manage. But hopefully today we'll have a smooth day. So over to you, Celine. Yeah.
Thank you very much. Thank you. So hello, everyone. And I wanted first to thank the organizer for the kind invitation. So it has been a pleasure to be here. It is still a pleasure to be here.
It's our two.
It was really a pleasure to meet all of you, and especially during the dinner yesterday. It was a very good time. So now, do I have to do something to put my slides? Okay, it's here.
Rama, there's a small changes. Dr. Hemant Malhotra, who is supposed to be the next speaker, so he is not able to join because of important engagements at his institution. So the next speaker would be Dr. Vijay Patil from the.
Perfect.
Yeah, thank you.
Good.
So thank you very much. Maybe I will. Should be either like this. No. Okay. So today I will present you the efficacy of a new treatment that we found, which is a combination of oxaliplatin ATR inhibitor and anti-PD-1 combination on a colorectal cancer model. So Okay, okay. Thank you very much. Okay, so colorectal cancer is the third. Okay, let me. Okay, the third most common cancer around the world, with almost 2 million of new cases per year, and it presents almost 1 million of deaths. That makes him the second leading cause of cancer all around the world. So colorectal cancer, when it metastasizes, the metastases are located to use. Ah, yes, you see it. Okay. Into the liver, the lungs, the brain, and also the peritoneum. And metastasis in the peritoneum is a subject of my talk. So peritoneal metastasis is the third most common site of metastasis for colorectal cancer, and the 5-year overall survival is 40%. So clinicians face 3 clinical situations. The first one, when the disease is resectable, they perform cytoreduction plus IPEC. And IPEC means hypothermic intraperitoneal chemotherapy. So the patient are treated directly into the peritoneum. The second situation, clinical situation, when the disease is borderline, sorry, the patient have induction chemotherapy, generally with oxaliplatin, and also cytoreduction and IPEC. And when the disease is non-resectable, the patient are treated with chemotherapy and also with a treatment that is called PIPAC, which is pressurized intraperitoneal aerosol chemotherapy. So nobody actually show the real advantage of IPEC plus cytoreduction. So the PRODIGE 7 clinical trial did it, and the idea was to compare surgery, complete surgical resection for people who has peritoneal metastasis from a colorectal origin, and they randomize the patient, and either they treat them with the HIPEC, with oxaliplatin, or without the HIPEC. And it is important to note that all these patients receive some systemic chemotherapy with oxaliplatin before. And as you can see here, it was kind of disappointing that either you use HIPEC or no. There is no difference between the patients that receive the HIPEC or without this. So one of the hypotheses of this lack of efficacy is maybe it's because as patients receive already some chemotherapy and oxaliplatin, maybe it was because of oxaliplatin resistance. So in a lab, we decided to identify new therapeutic target in these oxaliplatin resistant cells. And what we have done is first we have created oxaliplatin resistant cells that we have called HCT116R1. So these cells are colorectal cancer cells. And we perform synthetic lethality screening in order to identify genes whose inhibition will confer sensitivity. So we use, as a library, we use a kinome library, meaning that we use a shRNA library that targets the 500 kinase gene of the genome. And then we infect with our oxaliplatin resistant cell with this kinome library. And what we did is, once the cells were infected, we treat these cells with 3 micromolar of oxaliplatin, and this quantity of oxaliplatin will kill all the sensitive cells, but will have no effect on the resistant one. And at the end of the screening, we came out with this result, and we found that is ATR, the kinase called ATR. So now, as an example, we perform a shRNA against ATR, as you can see here by Western blot, and we treat the cells with oxaliplatin in order to determine the IC50. And as you can see here, the cells where ATR is downregulated, they become much more sensitive to oxaliplatin compared to the control. And we have to say that here we were very impressed by inhibiting only one gene. We make the cells make the resistant cells becoming sensitive again. So here, this work shows that the ATR genetic inhibition is able to overcome oxaliplatin resistance. Then we use ATR inhibitors. So it is important to note that there are at least 3 ATR inhibitors that is already used in clinic and that has been already tested in clinic. So I'm sorry. We decided to treat ourselves with ATR inhibitor that is called VE822, and I will call it during my talk VE. So what we have done is we have treated ourselves with a growing concentration of ATR inhibitor VE and a growing concentration of oxaliplatin. And as you can see here, this is a viability matrix indicating the percentage of viable cells. And you see that the combination is really efficient. And this is a synergy matrix where we can see if the combination of the two drugs are synergistic. And as you can see here, in almost all the combination, we have a synergy between the ATR inhibitor and oxaliplatin. So we confirmed this good effect of synergy in 10 different colorectal cancer cell lines, the murine cell lines, and also human cell lines and cell lines that are resistant to oxaliplatin, like HT116R1 and R2. So this result shows that ATR pharmacological inhibition is also able to overcome oxaliplatin resistance. So then we confirmed those results on peritoneal carcinomatosis sample from clinic. So we recover some tumor from the peritoneal metastasis, and then we perform tumoroid into matrigels. And then we treat this tumoroid either with the ATR inhibitor alone, oxaliplatin alone, or the combination that we call VOX for VE822 plus oxaliplatin. And as you can see here, this is a labeling of survival of surviving cells, surviving tumoroid. And as you can see here, the VOX combination is much more efficient compared to, each drug alone. And we confirmed this with tumoroid from 8 different patients. So just to tell you about the mechanism of action of this VOX combination, so we were able to show that this combination is highly synergistic and is able to induce cell autonomous cell death by inducing DNA damages and replication stress that leads to proliferation, inhibition, and apoptosis. But also this combination is able to induce antitumoral immunity by inducing immunogenic cell death and also by inducing production of interferon type 1. So as this combination is able to induce antitumoral immunity, we decided to combine the VOX with the anti-PD-1. So to do this, we decided to use a mice model of peritoneal metastasis from colorectal cancer. So the idea was first to make an intraperitoneal injection of colon cancer murine cell lines in order to work in immunocompetent cells, mice. Then we start the treatment between 7 and 10 days. During all the treatment, we monitor the tumor development by bioluminescence. And then at the sacrifice, we do is a PCI score. So we count the number and the size of the nodule in 12 different parts of the peritoneum of the mice. And this is what it is done also in clinic. And what we do also is we recover all the nodules from the peritoneum for biochemical analysis and immunophenotyping. So first, what we wanted to see if its VOX is inducing PD-L1 expression, as we want to come with anti-PD-1. And as you can see here in these 2 murine colorectal cancer cell line, CT26 and MC38, you see that PD-L1 is induced by OX and VOX. Then we do our in vivo experiment. And as you can see here in 2 different mice models, mice grafted by NC38 or CT26, we found that the combination of VOX plus anti-PD-1 is highly synergistic because for almost all the mice treated with this, we didn't see any more luciferase activity on those mice. So here, in these two orthotopic model, we show that this VOX plus anti-PD-1 is highly efficient. For instance, for the CT26 model, what we have done also at the end of the treatment is we perform the PCS score, as I showed you before, so counting the number and the size of the nodule. And as you can see here, VOX plus anti-PD-1, we don't have any more nodules, meaning that the mice are totally cured. And this is the same result with a survival curve, Kaplan-Meier survival curve, that the combination VOX plus anti-PD-1 is highly efficient because all the mice were cured. So for these mice that were cured, what we decide is to re-challenge these mice, meaning that we graft 2 times more cells into those mice that were cured, and we didn't treat them. And then we check if a tumor is growing or not. And what we found is that with the VOX plus anti-PD-1 treatment, we have more than 90% of mice that will survive, that survive, meaning that we have a vaccine-like effect of the VOX plus anti-PD-1 combination. So we ask ourselves, what is the contribution of the immune system for this vaccine-like effect? So we took the nodules from the treated mice, and also untreated as a control, obviously. We perform cell dissociation, and we perform immunophenotyping using flow cytometry. What we found, I'm sorry, is into the tumor, into the nodules, we have a decrease of neutrophils and a decrease of macrophage M2, and an increase of cytotoxic CD8 T cells. That may explain the cure. So the fact that all the tumor is eradicated. But when we look carefully at these CD8 T cells, we found that there is a small group of these cells that are expressing PD-1 and Ly6C. And this small group of the cells are really enhanced in the blood and also in the spleen of the VOX plus PD-1 mice, meaning that this enrichment of the CD8 T cells expressing PD-1 and Ly6C, these cells share characteristic of stem-like memory CD8 T cells, and this is a new group of CD8 T cells. And we know that these stem-like CD8 T cells are necessary for long-term maintenance of T cell response and also for the efficacy of the immunotherapy. So here to finish, I just wanted to show you, to resume what I already showed you, the mechanism of action of VOX plus anti-PD-1. So as I show you, it's highly efficient because it's able to lead to a complete tumor regression by inhibiting the infiltration of Treg neutrophils and M2 macrophage, and is able to induce the infiltration of CD8 T cells. Well, I didn't have time to show you, but this combination is able to kill the neutrophil into the bone marrow. And also, we saw that in spleen and in blood, we have the appearance of a new type of CD8 T cells that express Ly6C and PD-1. So this combination, we show that this combination is able to reprogram the tumor immune microenvironment to eradicate tumor and to induce a long-term protection that I show you with a re-challenge. And this combination also is able to induce accumulation of a new class of stem-like CD8 T cells. So I didn't have time to show you, but we obtained exactly the same result in a PDAC model, mice grafted with a KPC pancreatic cancer cells. So now we are trying to obtain some grants, some financing to launch a phase 1 clinical trial in our clinic, combining oxaliplatin plus the anti-PD-1 pembrolizumab plus ATR inhibitor using the PPAC, the one that I show you at the start of the talk. So this work has been done in Institut de Recherche en Cancérologie de Montpellier, in now Cancer Comprehensive Center. And this work has been performed by two talented PhD students, Alexandra Fauvre and Chiara Versino. And just to finish, I wanted to show you, for those who don't know a lot about Montpellier. So I'm going from Montpellier, which is in south of France. And here are all the part of the Montpellier to give you some idea to come and visit us. So thank you very much.
Yeah. So, Rama, I leave it to you. You please open the session for the question.
Okay.
Yeah.
Yes, thank you very much, Dr. Gongora, for a fantastic talk. I've opened the floor for questions.
So we can have 2, 3 quick questions.
It's hard to see the hands up from here.
Excellent talk, Dr. Gangora. I must
Thank you.
congratulate you. I am particularly intrigued by this nodule recovery and immunophenotyping part. So, you did the phenotyping with the nodules. Did you also look at the immunophenotyping, the type of immune cells in the primary tumor? If you
This model, we don't have the primary tumor. As we inject the cell directly into the peritoneum, we have we have kind of metastasis, but we haven't graft primary tumor in a colon, for instance. So it's just a model of metastasis.
okay, and peritoneum metastasis in particular,
Mhm.
not other metastatic sites. So if we were to look at the the immune cell infiltration in the other metastatic sites.
Yes, could be a good idea.
Yeah.
Could be a good idea. We haven't done that. Maybe we could test for liver metastasis. We haven't done this model, but as I told you, in pancreatic cancer, we have the orthotopic graft on primary tumor, so on pancreatic, and we have the same result. So we think that this is not dependent on the disease, but is dependent on the treatment and the effect of the treatment on cancer cells.
Fantastic. Thank you.
Okay.
So just to clarify, actually, was the pancreatic cancer cells also tested in the metastatic setting?
Yes, right.
I see. That's really fantastic result. Are there other questions?
Yeah, here. Excellent talk, and thank you so much for coming on our invite. So I was just wondering, the synthetic lethality we see for ATR inhibitor together with oxaliplatin. So what is the mechanism? Like, is it only the DNA damage, putting too much DNA damage, or any interactions are there?
So we found that obviously there are DNA damage because oxaliplatin is leading to replication stress, and it is not and this replication stress must be repaired with the ATR DNA damage response. So as we put oxaliplatin and ATR, all those damages are not repaired, and then DNA is going out of the nucleus and is going into the cytoplasm, and then it activates this cGAS-STING pathway in order to produce interferon. So we have two different part of this of the effect of the combination.
Because this is single strand break that is being repaired by ATR. So other molecules that are participating in single strand breaks can also have a synthetic lethal effect.
Very good question. We check for CHEK1 and CHEK1 and oxaliplatin. CHEK1 inhibitor and oxaliplatin is also very efficient, but CHEK1 inhibitor into the clinic are not very good. So that's why we decided to stay with the ATR inhibitors.
Right. Thank you so much.
Thank you.
Uh, Maybe can I have a question? Yeah, it's a small question. Let's. It's not a question. It's rather in curiosity to know, since it is a pancreatic cancer model, whether it's irrespective of orthotropic or xenograft or whatever. So macrophage infiltration play a very important role. So to me, it looks like that this inhibitor that you are trying, is it blocking the desmoplastic reaction and thereby controlling the resistance or controlling the tumor growth. So did you look upon this mechanism with regard to the in situ macrophage polarization?
So this is what we are doing now. And we found it more clearly into the pancreatic cancer model. So this is exactly what we are trying to understand now, the polarization of macrophages and the role of macrophages. Because we saw that the M2 macrophages are going outside of the tumor, and maybe there is a switch from the M2 to M1. So this is what we are looking at.
Yeah, because in our previous work on this same PDAC model, if it's not exactly PDAC but neuroendocrine tumor of pancreas, we have seen that if we exchange the macrophage index by doing the adaptive transfer with the M1 prime macrophages, then this tumor become permissible and the whole vasculature become normalized. So that really pushed a strong, CD8 cell stromal vis-a-vis the M1 prime macrophages directly into the tumor, not even in the stroma. And this is governed by IL-9.
Okay, but what we have done also is that we treat the mice with anti-CD8 antibodies just to know if the response is totally dependent on CD8, and the response is no. If we don't have CD8 T cells, we have less effect of our treatment, but still we have an effect. So maybe dependent of macrophages.
Yeah, thank you. Yeah.
Thank you.
Rama, over to you.
Okay, yeah, in the interest of time, so we will move on to the next speaker. I would like to introduce Dr. Vijay Patel. He will be speaking on CAR T cell therapy in CNS tumors, opportunities and challenges. And Dr. Patel comes from Mumbai, Sun Act Cancer Institute Private Limited. Dr. Patel.
Sorry, there's a small update. So we'll facilitate all the speakers after the session to keep the session flow in time. Yeah, thanks.
CNS summit. Thank you, and let me thank Videsh for this invite. Yeah. Uh, I'm not intending to cover all CNS tumors. What I would be covering is glioblastoma multiforme and midline gliomas. I'll start where we are. I'm a clinician and a clinician scientist. I'll start where we are with respect to GBM. What is the work we have done, and how we are looking at cellular therapy to improve this. So there's no conflict with respect to. Now, as I understand, most of the people here are scientists and not clinicians. Glioblastoma multiforme is the commonest brain tumor in adults. Now, when you get this brain tumor, most of the patient, in spite of doing surgery, in spite of doing radiation and a drug called temozolomide, 80 to 90% the disease will come back within 1 year. The average survival which we are looking at in this tumor is between 14 to 16 months in spite of all efforts. The question comes is when this in 90% of the tumors, the tumor is going to come back. And when it comes back, the survivals are dismal. So what you do in such tumors? As clinicians, we always have this question, do we offer any treatment or we don't offer any treatment? And so I'll take you step by step the work which we done at Tata Memorial Hospital to put a frame of how we'll approach these patients. Now, the first work which we did is when these patients come to us back to asking them when they have been explained the prognosis that your lifespan is limited, what is their expectations? And it wasn't a surprise that 75% of the patients, in spite of the minimal increase in survival which comes with further therapies, still wanted to go for further therapies. With this, let's look at the treatment options. Knowing that there is a dismal outcome, patients want to improve their dismal outcome further. What are the treatment options which we have? This is an unpublished data of around 2,000 patients from Tata Memorial Hospital. What it shows is, so dismal is the attitude even of physician towards the disease, that 50% of the patient, when they get a relapse, they're not treated. Surgery and re-radiation forms only 17% of the treatments, and the rest treatment is by systemic therapy. Now, surgery and re-radiation in this situation can only be offered if the relapse happens after a considerable long period of time, let's say after 1 year or 1.5 years. If it occurs early, which happens in 90% of the patients, these options are not there. What is the survival of these patients? Mind you, the Kaplan-Meier time chart is in days, and you could see the survival of this patient is in the range of around 120 days, which means at the most around 4 to 5 months. So we are tackling this kind of a tumor in which the survival in the best of the institutes in India is in the range of around 4 months. So what are the efforts we took to improve this? Now, the drug called bevacizumab, it's an anti-angiogenic inhibitor, and it was touted to be one of the game changer for GBM until we got this randomized study in which bevacizumab was combined to a drug called lomustine versus lomustine. It was a randomized study. Unfortunately, addition of bevacizumab failed to improve any overall survival. It did improve some progression-free survival, which is a bit debatable. That's maybe because of the way bevacizumab acts, and so there's something what is called a pseudo response. But overall, the outcome of this patient remained around 8 to 9 months. This was interpreted differentially across the Atlantic. The Europe removed the approval for bevacizumab. The US continued with its approval, suggesting that as there were no other good agent, this option still remained. This is our own results of what happens when we give bevacizumab in our clinics, and our survivals also are in the range of 6 to 7 months itself. Now, one of the things which was when we give bevacizumab, if the bevacizumab is given in a dose of 10 to 15 milligram per kg. According to Dr. Rakesh Jain's hypothesis, this is a very high dose of bevacizumab, which actually does not cause normalization of the vessels, but it actually causes blockage of the vessels. So there was a concept and hypothesis given, can we give lower doses of bevacizumab and it might be worthwhile? And we tested that in the clinic to look at an optimal dose of bevacizumab, in which the standard dose of bevacizumab was compared against a low dose of bevacizumab. And we saw that, okay, even if we give low doses of bevacizumab, the outcome still remained same. But yes, it led to a decrement in side effects of these patients. We further went ahead and actually did a study to see how much low we could go, and we took the help of our colleague from ATRAC, Dr. Manoj Mainkar, who titrated the circulating endothelial cells levels for us, along with different doses of bevacizumab, for us to understand what will be the optimal dose of bevacizumab and which dose we should be using in clinic. We came to a dose of around 1 milligram per kg, which would be the most optimal dose of bevacizumab to be used in the clinic. What I'm going to show is the clinical results of that dose, in which we combined this 1 milligram per kg dose with CCNU and wanted to see whether it would improve outcome or not. This was a prospective randomized trial, and we presented this in ASCO last year. And what we saw is in this trial was, yes, use of this lower dose of bevacizumab also led to a similar improvement in outcomes what you get with higher dose of bevacizumab. Now, yes, when you decrease the dose of bevacizumab, toxicity decreases. But in a country like India, where the cost of bevacizumab is huge, the dose when comes down from 10 milligram per kg to 1 milligram per kg, it actually saves around 50,000 to 1 lakh rupees of the patient per single dosing, and this dosing needs to continue for around a year every 2 weekly. So you can understand the amount of cost saving which can be done by coming down on the dose. And when it is scientifically also suggested that this dose also is equally efficient, it becomes more important. Another thing which happened in this period was Roche lost its patent for bevacizumab, and we got a lot more biosimilars which started coming into picture. Now, the biosimilar studies in India were actually done for colon cancers and not for GBM. So this gives again a unique opportunity for us to compare the generic versus the original and see whether the results were the same or not. And what we saw was, and in this again in this publication, yes, the outcomes were similar whether you use an innovator brand or a generic brand. So yes, bevacizumab is not the best of the drugs, but in whatever products we have, it seems to be the one of the hero drugs with limited benefit. Low dose bevacizumab can be given, and whether you use an innovator or you use a generic is is inconsequential with respect to outcomes clinically. We also wanted to see, at this was the time in 2016, we had done some cell line studies with a scientist, which suggests that anti-helminthics can be of use in glioblastoma. And with that, what we worked upon was one of the first phase 1 studies to see whether we can combine an anti-emetic. It was specifically mebendazole, and it was isoform C of mebendazole, which has a very good plasma to CSF penetration. Which means that if you have 1 unit in the plasma, the CSF amount is around 0.67, which is as good as temozolomide. So what we did is we actually did a phase 1 study to see whether we can combine mebendazole with temozolomide and RT, combine mebendazole with CCNU, and combine mebendazole with temozolomide. And this phase 1, once we got a dose, we went ahead with to do a phase 2 to see whether it led to an improvement in outcomes or not. So phase 1 was successful, and we could get a maximum tolerable dose for mebendazole. And subsequently, we actually went ahead with the phase 2, and we saw that for CCNU mebendazole combination, it actually overcome the threshold boundary for this. This combination now of combination of CCNU versus CCNU plus mebendazole, at present we are testing in a phase 3 randomized study across 7 centers in India. Now, immunotherapy in all other tumors has been great, but unfortunately, the results in glioblastoma multiforme have not been very exciting about. We do NGS to look for certain markers, and if we get certain markers, we can treat the patient. But in an adult glioblastoma, in according to our databases, the incidence of these markers is below 10%. To be exact, it's between 5 to 7%, which means this is not applicable for 93% of the patients. Now, you might be worrying that Dr. Patil has been going in all direction, looking at bevacizumab, looking at mebendazole. But as clinicians, this is the way we are. Whichever hint of hope we see for our patients, we start investigating that to look at whether that benefits our patients or not. With that, the last 10 minutes, I'll talk about cellular therapies. Now, understand we are talking about a tumor in which the survival was 4 months or below in most of our patients. Now, when we look about CAR T or a TCR therapy, in this situation, the brain is an immune privileged organ. There's a lot of immune suppressive tumor microenvironment in these situations. Now, there are 4 CAR Ts which I would be discussing today, and I'll tell you which we have selected further for our research. EGFR variant 3, interleukin 13R alpha 2, HER2, new, and PSMA. We got these results for EGFR variant 3 from Dr. Donald Rupp's lab, in which we did saw that there were some exciting results, and also from the Mass General Hospital. But what we saw with EGFR variant 3 CAR T is that there was a good response in the limited number of patients which was studied, but the response duration, which means the tumor might shrink, but for how much time this response maintained was dismal. It was below 6 months in both of the patients. So we did not think about investigating this further. Interleukin 13R alpha 2. Now, this was an interesting markup. Now, to do any cellular therapy like CAR T or TCR, you need to check for immunohistochemistry or at least genomically whether the marker is present or not. In India, when the patient has a relapsed GBM, because the dismal outcomes associated with it, very few neurosurgeons are ready to take a biopsy of the patient so that we can do these markers. The good thing about interleukin 13R alpha 2, it is expressed in more than 90% of the GBM. So this is one of the markers you may assume that the GBM is positive for. Dr. Christine Brown had presented 2 papers, one in 2018 and subsequently in 2024. And these are one of the most exciting results of interleukin 13R alpha 2 CAR T, which we have seen till date, where 20% of the patients are going beyond 3 years. Now, this is, for me as a clinician, becomes a very successful results where we were not seeing even 10% of the patients going beyond 1 year, but 30% of them are going beyond uh, uh, 3 years. Now, obviously, as scientists, we get a bit hungry. EGFR gives very good response. Interleukin 13 gives very good durational response. Let's try to combine them and see. Unfortunately, the combination actually did fail. It actually led to more side effects and did not have a much benefit. Now, HER2 new is a marker which is there in 17% of GBM. It's expressed percent of the patients in the higher form. And its expression In Indian patient, is around 15.44% in from our database. There is a study where HER2/neu was given around 1 into the power 10 is to 6 and was infused. Interestingly, around 20% of the patients went ahead of 2 years. We have a CAR-T results for B7H3, but it was a single study. We have results for EPA-E2, but again in a 3 to 4 patients. And we have results from GD2 CAR-T, which again in 8 patients did show promising results. Now looking at these results, we decided, and I'll show you the slide, to investigate interleukin 13R alpha 2. We have already put a phase 1 study to that matter to look whether in Indian patient interleukin 13R alpha 2, which seems to be the most promising amongst all the CAR-Ts which are there, whether it can improve survival or not. Last 2-3 minutes, I'll talk about midline glioma. Now, a diagnosis of midline glioma happens in early childhood between the age of 7 years to 15 years, and it's like a death sentence to the child. In spite of doing biopsy and radiation, the average survival is only 8 to 10 months. Hardly any patient survives beyond 2 years. It's a dismal disease and has great impact on the family because the child been in the very young age. We got the results for GD2 CAR-T in this, in which for the first time we started seeing that the results for GD2 CAR-T are going beyond 21 months as a median survival in these patients, which is very exciting when the previous results were in the range of around 8 to 10 months. I won't go out the graph where you could see that the response is continuous for a long period of time. Now, TCR is another agent, but it is very difficult to get biopsies in glioblastomas in this situation. We are trying to working on development of gamma delta T cells and CAR-T as an allogenic protocol for in glioblastoma patients. So at present for glioblastoma, we are actively working on CCNU combination with mebendazole and combination of gamma delta T cells for glioblastoma. Along with that, we are waiting for regulatory approvals to come for starting a phase 1 for interleukin 13R alpha 2 in glioblastoma cells and GD2 CAR-T for midline glioma, as these are the things which are showing interesting results. Now, as clinician, it would not be my, I wouldn't do justice that whenever you get a glioblastoma, along with the treatment, you also has to look at the distress management of this patient, counseling of the parents of these patients, and giving emotional support, because most of the patients are not going to do well in this. And this is a data which suggests that a high amount of distress, around 62%, is seen in these patients. Now, I've shown a lot of clinical work, and this won't have been possible without the help of Dr. Kumar Prabhash, who was my teacher and further my colleague, Dr. Jalali, who mentored me in neuro, Dr. Nandini, who is my colleague, and a lot of team from Attract and Tata Memorial Hospital and my current institute from Hinduja Hospital. With that, I'll stop here, and if anyone has a question, I'll take them. Thank you.
Thank you, Dr. Patel, for a fantastic summary. You covered so much ground so quickly and clearly. I open the session for questions.
Thank you, Dr. Patel. Excellent talk, actually. I'm just curious. What was, as a clinician, what was your perspective to repurpose mebendazole for GBM?
So this is the date. This goes back to 2016. We had a conference in Mumbai, just like this, called Metronomics in Mumbai. And that time I had a discussion with one of the scientists, Dr. Eddie Pascal, and he had shown me that time he had presented a data of lot of drugs which could be repurposed for cancers.
Right.
And along with, I'm forgetting one more guy, he works on a redo project in which they had also shared a lot of data for which drugs could be repurposed in different types of cancers. My and my colleagues' motto is very clear. If you're going to develop a drug, it should be such that it is affordable.
Of course.
It has lost its patent so that it can be immediately be useful for the patients. And among those drugs which we look for GBM, hydroxychloroquine and mebendazole seem to have the most promising cell line data. And being clinician, so I knew that chloroquine has its set of toxicities. Mebendazole being an antihelminth in lung fluke has been used in very high doses. There was WHO data for that, and there was no associated toxicity. And that's why, after a joint discussion in our neuro disease management group, we decided that we would focus on the work on mebendazole.
Thank you. Thank you so much.
Other questions?
PG.
Yes.
Is there any hope for these patients? Vivek, you just put the mic on. Yeah.
Sir,
Can you repeat the question?
So the question is whether there is any hope for DIPG patients. So DIPG is like a death sentence. That's what I keep telling to my students. And whenever the diagnosis comes, hardly anyone goes beyond 1 year. But the data of GD2 CAR-T and what I've not shown is B7H3 CAR-T given intraventrically. In these patients who have relapsed and the expected life expectancy is below 6 months, we have now started seeing survivals of ranging in these two studies. In one study, it was 18 months, and in the other study, it was 22 months. So that is the reason why we decided to investigate. We have just finished writing a phase 1 protocol and submitted to the ethics, investigating this CAR-Ts in this midline glioma patients. I could be able to, in a better situation, to answer the question after 1.5 years, once at least we get the results of the phase 1 of how the Indian patients are doing with this drug. Drug was cellular therapy.
Vijay, here I have a question. In your clinical trials, so do you correlate with the microbiome, aspect? Because you're repurposing memendazole for the GBM seems to me a direct correlate of dysbiosis. I mean, at least to me, it looks like that. If you're repurposing the memendazole, you are also enhancing the TLR agonist in the system, which has probably helped to the immune system to eradicate the tumor. So
good question, Dr. Lidesh. But the practical things is, and my colleagues are sitting here, most of the time we are short of funds to do the clinical trials. And in that, we then focus on the clinical part. For example, for this trial, we could do circulating endothelial cells, but we have the biopsies collected. I'm still awaiting funds in spite of the trial getting published 2 years to look for the other genomic data if we can correlate that with the outcomes. So, unfortunately, what happens is whenever we plan a trial, more or less our translational work is dictated by the collaborators from our ITRAC side. So if the collaborators from ITRAC side are working on microbiome, we would be working on microbiome. As I told, I am a clinician, so I take care of the clinical part. I leave the translational part to them.
no, because this is a very important aspect which one should take, because there's many microbiome, particularly bacteria.
Correct.
They use calf. They sit in the calf, changes as a parasite or endothelium cell, provides support to the tumor cell for shutting the gate. So from that aspect, if we can denail or resect the dysbiosis, we will get enhance the particular cohort of microbiome as a TLR source, TLR agonist. I think that's a way forward.
I'll actually contact you because our phase 3 is going on. We have recruited 70 patients and 100 patients are yet to be recruited. Then we can amend the protocol for this translation.
Sure. Yeah.
Thank you.
I agree with you, Dr. Prakash. I think you have mentioned a very, very relevant point. Yeah, thank you.
Okay, Ramakoka.
Thank you. Yes, so Dr. Prakash, why don't I pass the microphone to you to introduce the next speaker?
Sure. So it's my job now. Okay. So I'm happy to introduce our next speaker, Dr. Ganeshan, who is the director of Center for Molecular Oncology, and he's a professor of medicine at NYU Permuter Cancer Center. Dr. Ganeshan received his PhD, MD and PhD in cell biology at Yale University before taking this assignment, and he was there in the Brigham and Women's Hospital at Dana-Farber Cancer Institute, followed by his postdoctoral training in the laboratory of Dr. Davids. Later, he had a lot of academic titles at several institutions, and so the biography is pretty long. So to cut the time short, I invite Dr. Sridhar to take over the floor. The floor is all yours. Yeah.
While we're setting up, I'd like to thank the organizers for the opportunity to participate in this excellent conference. I had a great time here meeting a lot of students and investigators here. So I'm a medical oncologist, so I treat patients with breast cancer and rare cancers, but I also run a basic and translational laboratory focused on DNA repair and cancer genomics. And over the past 10 years, we've been focusing a lot on understanding the dynamics of clonal evolution of tumors in patients. And today, I'm not going to discuss any of my basic or translational work in models, but talk to you about a few stories in patients that have been very informative to us in understanding some of basic aspects of tumor biology and how tumors evolve under selection from now effective treatments. So, yeah, that's it. So I think, one of the disclosures, I consult for both startups and big pharma, and my wife is a employee at Merck. So really the main exciting things that's going on in oncology over the past decade is that we're really shifting classification of tumors from just anatomy and histology, like where the lump is and what it looks like under the microscope, to really now incorporating elements of the molecular etiology into tumor classification. For example, in lung cancer, you have a lump in the lung, you get a biopsy, pathologist looks at it and says, it's not right. They say it's cancer. And then based on morphologic features, you could get squamous or adenocarcinoma. And that's our current modern classification. But within, for example, non-small cell, adenocarcinoma, if you look at the underlying drivers, there's an enormous heterogeneity of the molecular events that drive the cancer. And those are integral to both understanding natural history and response to therapy. For example, 4% will have rearrangements in ALK, and those and only those respond well to now second, third generation inhibitors of that tyrosine kinase. And so the question is, are ALK inhibitors lung cancer drugs? Well, they only work in 4% of lung cancer. All right, but they're a drug that target disease states that are dependent on ALK signaling. All right, so in many ways, my wife is an ID doctor, and so saying lung cancer is like saying pneumonia. All right, it's a organ-based classification of a set of diseases that have very distinct etiologies, natural histories. All right, and we're moving away from pneumonia, all right, to streptococcal pneumonia. All right, in many ways. All right, and the great thing is that because the molecular classification of cancer is now kind of integral to our upfront classification of disease. All right, the great thing is that next-gen sequencing has really allowed both the price and turnaround time for sequencing of clinical specimens has dramatically changed over the past decade. And now this is essentially solved. You can pick your favorite megabase of the genome and get high-depth sequencing back in about 7 to 10 days. All right. In fact, the challenges to sequencing now are no longer sequencing itself, but logistics, getting the tumor to the lab, and computational time, And when I was at Rutgers, and now we've been starting a protocol in which we are doing upfront sequencing of tumors and doing serial sequencing of patients with advanced cancer that came to our institute and presenting the data at the molecular tumor board that actually we started in 2012. And so we've seen about 4,000 patients through this protocol, and I followed them for a while. And from this, we really had gotten a lot of experience in both understanding the genomics of rare cancers. We experience in understanding exceptional responders to immunotherapy and targeted therapy. And what I'm going to talk to you today is now with new technology, we can actually monitor clonal dynamics of cancer within patients by serial monitoring. All right. And I'm going to put this around a case that we actually treated back in almost 10 years ago now, is a 15-year-old girl who was diagnosed, unfortunately, with metastatic colon cancer. So I attend on the adult service, and it's very bad when the adult oncologist is consulted by the pediatric service. And there's a girl presented with abdominal pain, found to a large mass in the colon, multiple liver lesions. The biopsy showed colon adenocarcinoma. She was treated with a diverting ileostomy, and she was started on our tumor sequencing protocol. And we noticed that this tumor had a BRAF V600E mutation, P10 loss, P3 mutation, and a SMAD alteration. And this tumor was microsatellite stable by multiple assays. And there was no reason why there's no genetic, you can't think of a genetic syndrome that causes colon cancer in 16-year-olds. She was started on standard therapy with FOLFOX chemotherapy. And she actually had an initial good response. So she had an informative tumor marker. And so plotted here is this level tumor marker called CA19-9. And this is time on the x-axis. And so when she started FOLFOX therapy, she had elevated tumor markers and just decreased very nicely. But unfortunately, as we know, this therapy lasts about 3 months, and then she started to progress. The standard therapy next is usually second-line chemotherapy, or FOLFIRI, and that usually lasts about half as long as the first-line therapy. And there is no further really good effective therapy after. And so we said, hey, can we target, this is back in 2015, can we target the BRAF V600E mutation that we found? It was well known that BRAF V600E is a driver seen in melanoma, and you have excellent responses to BRAF and MEK inhibitor therapy. But intriguingly, in colon cancer, even though they had the exact alteration, there was less than a 5% response to the same drugs that had a 60 to 70% response in melanoma. So same driver, why the different response rates in melanoma versus colon cancer, right? And actually, a beautiful basic science work done by Renee Bernard's lab at the NKI and also Engelman's lab at MGH figured out why colon cells versus melanoma cells with the same mutation were resistant to single agent therapy. And this is the idea of, adaptive resistance. And so here, activation of BRAF signaling and ERK signaling led to feedback inhibition of upstream EGFR signaling. When now you inhibit BRAF signaling with a RAF inhibitor, this inhibition is unleashed, and now EGFR signaling is turned back on through PI3 kinase, and that allows proliferation. So what we learned from that basic science study is that in order for this therapy to work in colon cancer, you have to combine BRAF and MEK inhibition with an EGFR inhibitor. All right, and interestingly, that combination had work. And so at that time, we were seeing this patient. There were phase 1 trials, which we were doing actually at our institute, which showed the combination of BRAF inhibitor, MEK inhibitor, and EGFR therapy was actually quite active. But there was no data in pediatric patients. All right, and we couldn't enroll this patient. And then we realized from this patient that, hey, we need to reduce our age of entry to 12 for our clinical trials because at 12, they're physiologically adult, not otherwise, in terms of drug clearance. All right, and right now, of course, double and triple target therapy is now approved FDA for this, but at that time it wasn't. So given the natural history of disease, and speaking with the phase 1 investigators that we had seen, we actually initiated pure targeted therapy on her with a BRAF inhibitor, MEK inhibitor, and EGFR antibody, because knowing the natural history. So with her assent and her parents' consent, we initiated therapy with triple targeted therapy. And interestingly, she had a very nice response by tumor markers and radiographically and clinically. Unfortunately, this did not persist. All right, so this is the tumor markers again. After about 4 months or so, she started to have increase in her tumor markers and clinical and radiographic progression. At this time, we started to serially monitor her with cell-free DNA analyses as well. And so this is a time when cell-free DNA analysis, remember that cells upon dying in our body release DNA into circulation. Cells die by apoptosis and necrosis. Apoptosis causes small uniformly sized DNA fragments. Necrosis, you have a larger set of DNA fragments. If you do a sizing column on cell-free DNA, you'll see a biphasic distribution. All right, and these can actually be encircling cell-free DNA has come to a lot of prominence lately because it has a very short half-life, 10 minutes to a few hours. It's mostly enzymatic degradation and hepatic degradation. There might be renal clearance, which is intriguing because you could actually monitor this in urine. And the idea is that, hey, there's cells, normal cells in our body dying and tumor cells that are dying. They're both releasing DNA into our plasma. And that by sequencing plasma cell-free DNA, you get both the tumor mutations that are present that can tell the presence of cancer, and a proportion of DNA that's mutant can tell you something about total cancer burden. All right, so you kind of get two features from this. And so we started doing this. And so this is the data as, so these are correlated with the time points below. And the data are shown here as this fish plot, where each of these colors represents a different mutation. The dark blue is the BRAF, light blue is P53, green is the SMAD mutation. And so you can see that when she was responding, there was, and the width of each is the relative allele frequency in plasma. You can see that when she was responding, the allele frequencies were low. At the nadir of her term serum marker, it was undetectable plasma. And then when she was progressing, we can see that there was now again detectable cell-free DNA. And the interesting thing is you can always see here, theoretically, if the cell is releasing DNA, if this is BRAF, it's not the dark blue is BRAF, and that's the allele frequency. Theoretically, BRAF should be 1 to 1 to 1 to the other markers. You can see there's broader, there's a higher allele frequency there. And suggests that there's more DNA and actually amplification of BRAF. And in fact, without going into the details, the cell-free DNA analysis showed there was amplification of MET and BRAF, which is a known mechanisms of acquired resistance. These are the early days of cell-free DNA, so we didn't believe it. And so we biopsied one of the liver lesions that was progressing and compared it to the biopsy diagnosis. And you can see that compared to the biopsy diagnosis, there was evidence of BRAF and MET amplification. So this was concordant with the plasma DNA results. And so what can we do about this? Well, there's data from the Italian group that you can see MET-driven resistance to this, and that actually MET inhibitors may be effective in this setting. But this patient was actually getting sick, and even in the States at that time, to get a MET inhibitor for a pediatric patient for no indication, it would take us like a month or so. And so because she was getting sick, we said, it's an unusual situation in which here's a patient with colon cancer who hasn't received chemotherapy for almost 6 months. So let's give second-line therapy with FOLFIRI while waiting for the target therapy. And so we treated her, and you can see that she actually had a nice response to second-line chemotherapy with a decrease in both her serum markers as well as the cell-free DNA analysis, went down to near undetectable. But of course, this didn't last, right? So at about 4 or 5 months of therapy, now the tumor markers started to rise. But then something interesting happened in the cell-free DNA analysis. So clearly she's relapsing, but here's her cell-free DNA now coming back up positive. You can see that here it looks different than here, right? All of a sudden here, there's no longer this skew towards BRAF. You can see whereas here blue is more, dark blue is more. Here it's 1 to 1 to 1 again. All right. And in fact, by cell-free DNA analysis, there was no longer evidence of MET amplification or BRAF amplification. Right. So the dynamic markers of resistance to pure targeted therapy were no longer present in the clone that arose on second-line chemotherapy. All right. And this is kind of wild because normally we think the resistance is kind of cumulative and irreversible. All right. But here, this suggests that the clone that was selected for under pure targeted therapy for resistance is different than the clone that was selected under chemotherapy. If this is true, we should be able to re-challenge with the same therapy, which is something we never do. We go from regimen A to B to C, we never go back to A. All right, in cancer. So this is back in, and so we decided to, again, based on phase 1 data, that we could combine irinotecan with a BRAF inhibitor and the EGFR inhibitor. We decided to switch that. And the reason we did this is because there was a mixed response. Some of the liver lesions went away, and so we thought, let's keep the irinotecan of FOLFIRI and just add back on a BRAF inhibitor and the EGFR inhibitor. When we did this, there was a dramatic response. All right, in both radiographically, serologically, and by cell-free DNA analysis. All right, and so this is the data again on the serial monitoring of plasma dynamics. Again, this is not something we would have done just by following the serum tumor marker, but by understanding the genomics, we said, let's reinitiate therapy. And without going into great detail, we did this a couple of times. All right, ultimately, so this is a disease which actually has relatively poor prognosis, and we were able to treat it for almost 2 years by kind of this alternating the cell-free DNA analysis. And in some ways we treated her the worst possible way because we waited for gross progression on one before switching therapy. Imagine that if we'd been smart, we would have changed therapy at the time when the slope changed. All right, and try and really bring this down or combine. This really shows this is truly non-cross resistant. The pure chemotherapy, pure targeted therapy are truly non-cross resistant in this setting. And the other thing we also learned from her is that we had multiple serial images on her, and we noticed that not all metastatic deposits appear to have all clones of resistance. All right, we often think that as you get resistant, the tumor becomes resistant. But there are some clones that she had early on. There was a liver lesion that was present here at diagnosis. It went away with initial therapy and never came back. There was another one that actually popped up during resistance to FOLFOX. And then it kind of went away with PDT and then came back. So it kind of, shrank and grew with every therapy. So that lesion actually had a mixture of all clones, all right, all the resistant clones. And even clones that appeared late. So here's a liver lesion that popped up, on resistance to FOLFIRI. It went away with when we switched to targeted therapy and actually never came back again. So it was not, that metastasis which appeared late was not actually a mixture of all the resistant clones. All right, and this suggests that there's also a role for local focal ablative therapy, in some ways in the right setting, which we don't think about. And so, this is an anecdote. We don't know whether we help this patient. So the idea is how do we take this and transform this into science to help other patients as well? And so, with our colleagues at Mike Verzi's lab, he just made a mouse model of BRAF of colon cancer, or intestinal cancer, I should say. So interestingly, if you overexpress BRAF intestinal stem cells, nothing happens, unlike KRAS. They realized it just induces differentiation. And so he then said, it must be differentiation. Let's knock out SMAD as well as turning on BRAF, like our patient also had that same mutation. And when he does that, all of a sudden you get serrated tumors that look a lot like the BRAF tumor that our patient had. Again, this is a model of BRAF microsatellite stable colon cancer they developed. So we said, hey, we have this. Does this behave like the patient? And so we made organoid models. This is Kevin Tong, who did the work with the organoids, and he's now has his own lab at Hackensack. And what's nice is that the organoids from this mouse model behaved like the humans. It did not respond to single agent EGFR or single agent BRAF inhibitor, but responded to the combination. And what we did was, hey, can we now model our patient? We overexpress MET in some of these organoids versus not. And we could show that the MET overexpressed tumors, shown with the blue bars, unlike the parentals shown in red, are now resistant to combination targeted therapy. All right, so amplification, MET overexpression induces relative resistance. But if we challenge them with now SN38, which is the activating ingredient in irinotecan, so second-line chemotherapy, induction of resistance to targeted therapy does not induce resistance to chemotherapy. All right, and so right now what we're doing is using these kind of models to make mixtures and say, hey, can we figure out regimens for future to really try and ablate these clones up front, because these really truly cross-resistant. And this kind of thing is, this kind of feature that we see is not limited just to colon cancer. We see this over and over again, this kind of theme that the resistant clones are only more fit during therapy. All right, and that when we have good effective target therapy, the resistant clone pops up, and then when we remove the target therapy, it's no longer more fit, and that the wild type clones actually overcome this. This is well known in antibiotic resistance. All right, the multi-drug resistant, E. coli is actually less fit than the parental E. coli. They're only more fit when antibiotics are on board. And in some ways, we're seeing that again in the dynamics when we have effective target therapy that's here. And we see this over and over again. I'm going to give you one more case, which is an EGFR mutant lung cancer case, which we, again, this is early days, so it's 2013, had EGFR L858R as well as p3 mutation. We know these don't respond as well to the target therapeutics. It was treated with first-line erlotinib, did well for about a year, and on progression, we biopsied. And now what happened was there was on resistance, there was now EGFR amplification, and now MET amplification. Again, similar theme, right? It's different disease, MET amplified came as a mechanism of resistance. All right. So then in these early days, back in 2013, we actually added crizotinib on based on recommendations from Molecular Trimble. She did well for about 2 years. And on progression, we biopsied, and we found now, hey, EGFR L858R is still there. Now there's a resistance mutation, T790M, which causes resistance to erlotinib. MET amplification was lost. And this is a different clone, because now this tumor had CDKN2A loss and no p53 mutation. We know this is not a false negative because this is high depth sequencing. So that locus at p53 was analyzed at over 500x depth. And so if it was present in one in a few hundred cells, we should be able to see that. All right. So this is a clone that is related to this clone that is ancestral. All right. So at that time, this is 2016. So osimertinib came around. So we treated with osimertinib. And she did well for about a year again. And then on progression, what happened? This clone popped back up. All right. The MET amplified clone came back. All right, under osimertinib treatment. She actually developed brain mets at that time, so we radiated her brain, and we put her on osimertinib and added crizotinib at that time. And interestingly, she did well till 2021 on that combination. All right, and then had pure CNS relapse. And when we biopsied the tumor in the brain, it was the same clone because crizotinib doesn't cross into the brain. All right, and unfortunately we could not get alectinib with the CNS penetrant next generation MET inhibitors for her. But this is someone who we never reached for chemotherapy. We never wanted it. All right. What we were able to kind of change instead of going to chemoimmunotherapy by just following the clonal dynamics, we were able to switch targeted therapy and really keep her, without that kind of therapy for 8 years or so. This kind of thing is done. I just gave a couple of examples, but there's not all things. We do this all the time now with our approaches, and it's very interesting. For each case, we learn something. And we also need to then model it and figure out how to then turn these anecdotes into real science and clinical trials for our patients. With that, I'll stop. It's really important that, I think we see that rapid clonal damage can occur in response to effective target therapy. When we give ineffective target therapy, the clones stay just the same. We get chemo and it progresses. We biopsy again, nothing happens. Shows there's no selection pressure. When there's effective therapy and you lose it and get these dramatic responses, then you see these clonal things. The other thing is that learning from ID, we're only always 50 to 100 years behind infectious disease in our understanding of our disease. Just like in ID, there is a fitness cost for resistance mutation. These mutations are probably pre-existent and we're selecting. If they were more fit, they would have dominated up front. All right, they're actually less fit. And they're only more fit under the selection pressure of our therapy. All right, and serial genomic profiling can develop actionable mechanisms for response. We follow them, even though we are kind of whacking, we're one step behind. But if you undefine mechanism of resistance, maybe you can figure out, the tumor could only have 4 or 5 ways of escape. Can we actually then put those therapies like HIV, combine them up front, non-cross resistant, and get long responses? We try to find, again, the old drill is to find non-cross resistant, not synergistic treatments, but non-cross resistant treatments for our diseases. With that, I'll stop. These are collaborators that work here with mostly by Srilathis and Hadri and Kevin Tong. I'm happy to take questions.
Yeah, thanks, Sridhar, for the illuminating talk. And I'm very much impressed by your talk. So now the floor is open for the questions. Yeah. Okay.
Maybe a quick question. So thank you for a nice presentation. So I was just wondering that you showed in the last slide that, where you have EGFR P53, and there was a sort of amplification later on over the years. So yes, yeah. So I'm just wondering, how did you decided that, patients to put on erlotinib and followed by crizotinib,
Right, because MET amplification is a known mechanism of resistance, and in vitro data, which I don't go into there, we know that that combination actually is quite effective, and now it actually is used clinically. Back then, it wasn't known, so we were able to, because of our tumor board, we get recommendations that
and were these patients put on any other than these neoadjuvant therapies before and after,
So this patient had primary metastatic disease, and so this is all treatment of advanced EGFR mutant cancer. So she had metastatic lung cancer. So these are all controlled. All right. So this is primary metastatic EGFR mutant lung cancer.
And how long the patients had a survival? Was there any 2021?
So normally with this, current data,
because I could see a good, sort of, what was a progression free or what was the overall survival of a patient's, diagnosed?
So these are individual patients that were treated
okay.
in real life, right? Because there's two challenges. One is how do we do a clinical trial to look at this?
Yes.
All right. It's really hard, right? But at the same time, we can't ignore our individual patients in front of us. All right. The algorithm is erlotinib or OSI chemoimmunotherapy death. All right. All right. That's the usual. That's our algorithm. We can see mechanisms of resistance, and if we follow that, and we are lucky enough, like in this patient, where we have appropriate therapeutics we can give. None of these were approved at the time we gave it to. All right, but we got approval from the drug companies. All right, to do this. We can actually, figure this out. And the other thing is really from understanding this, we're trying to design, hey, should we be putting these up front? So right now, for example, amivantamab, which is a MET EGFR inhibitor together with lastinumab, which kind of probably get rid of the MET inhibitions and mechanism, is now a frontline, even though it's toxic, is better than single agent OSI, based on the recent clinical trials. I think, I don't think those are the best drugs right now, but I think there are treatment strategies like that. And I think we have to learn from HIV. HIV, each single agent caused rapid resistance, all right? And they combined drugs that hit the same target, but that were non-cross resistant. They weren't synergistic, right? All right, because each drug is really good by itself, all right? They were non-cross resistant, all right? And I think that's another lesson we haven't learned. We don't combine, like, for example, it'd be great to combine erlotinib with OSI, because they're non-cross resistant, right? Some mechanisms of resistance to OC actually are sensitive.
So was there any, you showed that one of the slides that there was a loss of CDNK2 using that cell-free DNA. So in that tumor heterogeneity, because there are stromal cells as well. So can you? So
when we do high-depth sequencing, tumor heterogeneity goes away. The thing you have to remember is that low-depth sequencing, even exome sequencing at 100x, 200x, you take the same DNA and sequencing twice, you'll get different reads because of the vagaries of depth. I'm an optics guy, so I look at the primary data. So actually, a lot of that is actually when we look at heterogeneity, you have to make sure how much noise is there in your assay, and there's quite a lot in sequencing at low depth. All right, by low depth I mean less than 500 to 1,000x. All right, because tumor purity also varies a lot. So, for example, a lot of the changes in allele frequency from two different samples is due to differences in tumor purity, as opposed to differences in, how many cells how many cancer cells have mutations, how many cancer cells are in the specimen. All right, so if you do high-depth sequencing, you get rid of a lot of that. And now primary and tumor, multiple samples all look identical. All right, so we can talk about that.
oh, thank you so much.
Very interesting talk. So at each and every stage of this cancer development, you also try to develop the PDX or organoid models and then test these drugs.
So absolutely. So what we're doing here is now we are trying to develop, and this is what we need. We need models of resistance. All right. And so we are trying to develop organoid, either PDX or organoid models at time of resistance to develop models of both primary and resistant disease. But to keep the resistant models, we have to keep the drugs on. All right, because they're always mixtures, and we notice it all the time. And I think this is a lot of times. So often what happens is even when someone progresses on a treatment, often we take them off treatment and then biopsy them a month later. If we do that, we'll miss the mechanism of resistance. All right, we've seen this several times when we do this serially. Okay, and so it's really important to be on treatment to get the biopsy. All right, because I think a lot of times when we don't see a mechanism of resistance is because we waited. If they're off treatment, the normal clone will just overgrow. All right, and so so we need to get the biopsies, and then on resistance we maintain the drugs in the culture as well.
Thank you.
Yeah, Sridhar. Rama, do you have any question?
No, I just wanted to say this is how a personalized, tailored therapy looks like, to be able to monitor it closely and then toggle the different drugs and combinations. It's really fantastic.
Yeah. So Sridhar, I think we are running out of time, but I would ask one quick question because your change of the treatment schedule. An idea about immune correlates. So, do you have any the biobank which can educate us on the immune correlate and immune signature stage wise? And because the if you change all these treatment, you're not only disturbing the DNA of the tumor cell but also the host cells. So there's always a bystander off track impact on the immune signature.
Absolutely. So I'm looking here purely at the tumor, right, and not the host. The host interactions are also, incredibly important. It's something we're missing with these just the self-limited DNA approaches. We did self-limited DNA because it's easy to do.
Yeah.
And it's informative. Like this patient had high allele frequencies because she had a lot of liver tumors. It's helpful. But absolutely, imagine that the hard part and the expensive part is to get biopsies and also have patients accept that and then actually develop the models. Because that takes effort, time, and chemical quantitation. And ultimately, every patient is a little bit unique, but that is actual life.
Sure.
I agree. And so you have to start really categorizing them and understanding.
Now, it's not working. Okay, anyway, I can, yeah. Yeah. So thanks, Rama, for sharing this stage with me and handling the sessions with me. So now with this,
Thank you.
First session.
Sir, we would like to thank all the speakers.
Yeah.
And I would request Dr. Vijay Patil and Dr. Selina also to come on the stage. We would like to thank you and felicitate first before we disperse for the tea break. Thanks a lot.
Yeah. So what I wanted to say that, we are running in time. So now we have a tea break of 5 minutes. and then we will quickly assemble. But to maintain the time flow, I would advise guys to have tea in parallel, and we start the next session right away. And since there is always there's a little change in the session planning for the Dr. Sahu at Ames is stuck in the OPD, and Dr. Jyoti is in Paris. So I would hand over the stage to Shaukat Hussain, who will handle the next session. And we have 5, 6 talks here. So over to you, Shaukat. Yeah.
First of all, we would like to felicitate, and I would request Dr. Prakash and even Dr. Tandon to please come on the stage and felicitate our speakers. Thanks a lot.
This way.
No, I will also request Dr. Tandon to please give a small token of appreciation to Dr. Hitesh Prakash, who has also been chairperson of this session. Thank you. It's okay. We want to thank you, sir. Thanks a lot to all our esteemed speakers. Now, as Sir said that we will have a tea break, small tea break, and we will assemble again for a short talks. And it should be very quick. So thanks a lot. We will assemble again within 5 minutes for the next session.
So today we'll make sure that we run in the time. We don't go out of the time. Yes, yes, yes. Here, here. You have to be here. Yes, 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 yes.
Dr. Kaushik Mandal is here. Speakers. Dr. Kaushik Mandal. Arun. Arun, is Arun here? So just wait. We are starting with our next session, which is of the oral presentation. And this session is being judged and even chaired by our chief guest, Dr. Danny Welch. I will request Dr. Danny Welch to come to grace the dais, please. Dr. Danny Welch is earned a BS Biology from University of California, Irvine, and a PhD in Biomedical Sciences from the University of Texas, Houston. He began his career in pharmaceutical industry, focusing on cancer biology and virology. Before transitioning to academia in Pennsylvania State University College of Medicine, in 2002, his laboratory relocated to the University of Alabama, Birmingham. And in 2011, he founded the Department of Cancer Biology at the University of Kansas Cancer Center, USA. Dr. Welch's career highlights include significant contributions to cancer research and departmental leadership in advancing oncology studies. Our next judge and the chairperson is Dr. Jayanta Bhattacharya and Shushanta Rai Chaudhary. Dr. Jayanta Bhattacharya is an associate professor at the Center for Biomedical Engineering, Indian Institute of Technology, New Delhi. He earned his PhD from IIST Hyderabad, India, where he worked on liposomal gene and drug delivery under the guidance of Dr. Arvinda Chaudhary. Dr. Bhattacharya completed his postdoctoral studies in biomedical engineering at Duke University, USA, with Professor Ashutosh. His research focuses on the development of bio-inspired and bio-derived materials aimed at treating and diagnosing diseases. He applies chemistry and engineering approaches to design, synthesize, and evaluate next-generation biomaterials with a translational impact on human health. Our next judge, which I would like to introduce, is Dr. Shushanta R. Chaudhary. He is the Chief of Basic Research at Saroj Gupta Cancer Center and Research Institute, Calcutta. Position he has held since 2015. He is a Jagdish Chandra Bose National Fellow and was previously the Chief Scientist at CSIR Indian Institute of Chemical Biology, Calcutta from 1991 to 2015. Dr. Rai Chaudhary has also served as a professor at the Academy of Scientific and Innovative Research from 2012 to 2015. He holds a PhD in biochemistry from the University of Calcutta, an MSc in biochemistry and BSc in biochemistry. His research focuses on cancer genetics, genomics, and cancer cell biology. Dr. Roy Chaudhary has published around 150 research papers, 19 reviews, and book chapters, and holds 2 patents. I would like you to welcome our both the 2 well distinguished judges. I would like to invite our first speaker, he is PhD scholar Arun B, and he is going to speak on STAT3 modulation in obesity-driven pancreatic cancer, implications for T-cell mediated immunity and tumor progression. He is a PhD scholar from Rajiv Gandhi Cancer Center for Biotechnology. Sorry, I did a very wrong mistake. It's Rajiv Gandhi Center for Biotechnology. Over to you, Mr. Arun.
Hello. Yeah. Good morning to all of you. Uh, I I hope and I think that we are going to have a very exciting session. These short talks by young scientists. So for the speakers, it is 8 minutes plus 2 minutes discussions. Okay. So the time will be maintained very strictly. Hello everyone, I'm Arun. I'm a PhD student working under guidance of Dr. K.B. Harikumar, Rajiv Gandhi Center for Biotechnology, Trivandrum. My topic is STAT3 modulation in obesity-driven pancreatic cancer, implication for T-cell immunity and tumor progression. It is the 7th most common cause of cancer-related death, and the death is expected to be doubled by 2040. And obesity is one of the risk factors in pancreatic cancer. BMI higher than 35 is associated with node-positive pancreatic cancer, cancer recurrence rates, and decreased overall survival. There are several molecular evidence which shows that high fat induces pancreatic inflammation, enhances fibrosis, changes metabolism, increase KRAS activity, also pro-inflammatory cytokines like interleukin-6, which is of my interest because it activates STAT3. It has been also shown that in obese models, STAT3 is highly expressed. So in our lab, we have already worked with STAT3. We have inhibited S1PR1, STAT3 loop, which leads to decreased dysplasia and increased accessibility of chemotherapeutic drugs like gemcitabine. So what we did is we looked at CPTAC data initially. So we found that STAT3 expression is higher in pancreatic patient compared to that of the normal. And we looked at the median survival rate. The median survival rate of pancreatic cancer with higher and lower STAT3 expression doesn't change much. But the interesting fact here is when CD8 T cell is enriched, obviously the survival rate increases. But in high STAT3 expressing patient, this prognostic privilege that is offered by the CD8 T cell is completely diminished. So we thought there must be some kind of link here because obesity is always activating STAT3 by interleukin 6. So we thought there must be obesity that leads to inflammation, that leads to STAT3 activation, which leads to immune changes, possibly in CD8 T cells, and can lead to cancer progression. So to investigate this obesity STAT3 PDAC link, we did this study. And our main idea was to understand obesity's role in pancreatic cancer progression, and particularly regarding immune dysfunction, and where does the STAT3 fall into this equation? And is BMI is associated with any kind of dysfunction in pancreatic cancer, immune dysfunction? And also can STAT3 can be targeted to change this immune dysfunction? So initially we looked into CPTAC data, which is a part of TCGA. And in CPTAC data, we did a transcriptomic analysis, and we found that these T cell receptor complexes and immunoglobulin complexes are highly expressed in high BMI patients compared to that of the normal BMI. To understand the pathways, the transcriptional pathways behind this, we just did a progeny analysis, which have an inbuilt set of transcription activators. In that also, we found that JAK and STAT pathway is significantly higher expressed in high BMI patient compared to that of the normal BMI. We also did a TIMI-GP analysis to understand the T cell exhaustion signatures and with respect to the survival rate of the patients. So we found that in normal BMI, obviously there are several text-related signatures in normal BMI in pancreatic cancer, but when you compare with that of the overweight, the signature increases drastically. Also, the favorability score that is negative, meaning it is negative with respect to the survival. Now, what we did next is we did a correlation analysis of BMI versus RNA-seq data. And we found that several genes in this correlation is associated with primary immunodeficiency, as well as electron transfer activity, possibly indicating a metabolic change or a change in the immunity. So from these BMI-associated genes, we selected T cell exhaustion, text-related genes, and we superimposed and we constructed a network, and we superimposed the network with RNA-seq TCGA data, and we found that several text-related genes that is positively correlated with BMI actually directly interacts with STAT3 or indirectly via JAK2. To understand STAT3's effect in CD8-mediated killing, we did a co-culture analysis in which we used TTI-101, which is a STAT3 inhibitor. We inhibited STAT3 in KPCFC1242, a murine pancreatic cancer cell line, and then we co-culture with activated CD8 cells. The catch here is there is no drug in the co-culture, only pretreatment. And after that, we did a FACS analysis, and we found dose-dependent increase in cell death in KPCFC1242. And also in the co-culture, obviously there is a phospho-STAT3 reduction, which is also dose-dependent. Then we did a STAT3 knockdown in cancer, that is KPCFC1242, and we found that in KPCFC1242 STAT3 knockdown, there is a considerable increase in cell death compared to that of the normal one. Now we went forward with the animal experiment, so we use KRAS PDX3 pancreatic cancer model. We developed one control group and two test group. One is partial STAT3 knockdown, meaning one allele is present, one allele is absent. Another one is complete knockdown. Then these are the weight differences, initial and final, of all the three groups. Then what we did is simple HND as well as mass trichrome staining. As you can see, KP shows almost full-blown pancreatic cancer with collagen deposition. The middle one is the partial STAT3 knockdown, which shows an intermediate phenotype. And the last panel is complete knockdown, which shows near normal pancreatic physiology. We also did an expression analysis related to gene expression. So we found that the BMI correlated text markers, which we got from the CPTAC analysis, that is SLAMF6, CCR6, and TOX. TOX is specifically important because it is the master regulator of T cell exhaustion. So all those markers were downregulated. Obviously, immune checkpoints like PD1, PD-L1 is downregulated because we are knocking down STAT3. Interestingly, CPT1 alpha is also downregulated, and several immune markers were downregulated. We did a proteomics analysis, and we found that Reg3B, 3A, and Reg2, which is associated with acinodectal metaplasia, is also reduced, and LDHA is reduced, as well as ACADS and PDHA is increased, possibly indicating an oxidative phosphorylation with fatty acid oxidation. So the conclusion is the CPTAC analysis of patients revealed that the STAT3 expression is enhanced in pancreatic cancer patient, and JAK and STAT pathway activity is high in high BMI tumors, and BMI positively correlated with T cell exhaustion genes linking obesity to impaired anti-tumor immunity in pancreatic cancer. STAT3 inhibition as well as dendritic knockdown improves T cell mediated killing in vitro. And STAT3 knockdown in obese PDAC mice model reduced panel lesions, fibrosis, immune checkpoints, inflammatory markers, and also reduced ADM, altered the metabolism, and improved the tissue architecture. The clinical significance of the study is the first of its kind that links STAT3 mediated immune dysfunction to obesity-driven pancreatic cancer, and also identifies STAT3 as a therapeutic agent. Finding also supports a BMI-based patient stratification and in personalized PDAC treatments. Thank you.
Thank you, Dr. Arun. So we have a couple of times for a couple of questions. Yeah. Can you give microphone there?
Yeah, sorry, I may have missed part of your talk in the beginning, but I was wondering regarding BMI. Are you measuring BMI at the beginning when you first see the patients, or during the course of the treatment also you're measuring BMI? And is there any shift in the BMI during treatment or as the disease progresses?
So basically, we used already published database, that is CPTAC database. So part of TCGA. Why we choose that is because that's the only database which gives you BMI as such in the clinical data. So that's why we choose. So we didn't actually measure it. We choose a database which has BMI in it.
Yeah, because the patients lose weight.
Yes.
As the tumor
Yes,
progresses.
actually in pancreatic cancer, it means that like while development of pancreatic cancer, if BMI is high, it will actually affect the cancer, meaning induce the cancer. At the same time, if it is after the cancer, it might leverage to a better survival. So there are two sides of it.
So the paradox also applies
Yes, applies here.
Pancreatic cancer. Thank you.
Any more question? Okay, I think there is no further question. So thank you, Dr. Arun.
Thanks a lot, Mr. Arun. Now we will invite our next speaker, Dr. Kaushik Mondal. Dr. Kaushik Mondal is Senior Scientist at Saroj Gupta Cancer Center and Research Institute. And he is going to speak on the CCR receptor axis could influence the immunosuppression of rectal adenoma carcinoma.
Thanks. At first, I convey my sincere thanks to the organizing committee for giving me the opportunity to present one of our study, what we are currently pursuing in our research laboratory. And the present topic is on CCR. The CCR8, CCL18 chemokine receptor axis could influence the immunosuppression of rectal adenocarcinoma. As we know, in the tumor microenvironment, it is a disease. There are lots of different type of cells, including immune cells. Some are protective, some are pro-tumorigenic. In protective immune cell, we have the CD8 and also the M1 TAM. And for immune suppressive, there are FOXP3 Treg and M2 TAM. Now, though there are lots of different type of immune cells, now the question will arise how those factors, immune cells, could be implemented in the clinical management. And when I am mentioning about the clinical management means whether presence or absence of those factors could influence the prognosis or any therapeutic management. In this aspect, the promising factor is tumor infiltrating lymphocytes, that is TIL. So regularly in our pathology, the clinicians used to check the presence of TIL at the core of the tumor and at the invasive margin. And when we used to speak about TIL, it used to come more about the CD3, CD8, mainly the T cell factors. And when there is increased level of CD3, CD8 at the core of the tumor and invasive margin, those patients having this type of tumor, they have the better survival. Now, though it is showing the better survival, the presence of TIL, but there are certain limitations. What are those? So the risk stratification cannot be dependent on the TIL. We need other immune biomarkers. As well as at the preoperative setting, the TIL is not the best marker. To make it a better prognostic or predictive markers, we should increase the power of validation. So as we mentioned about inclusion of other immune biomarkers, they always come into our mind, those immune checkpoint factors. Immune factors, that they play a significant role. Here comes the chemokine receptors and their ligands. And the chemokine receptors and their ligands used to play a role in various functions, but from the involved in Treg recruitment to other factors, here I am mainly focusing on the CCR4 and CCR8. Why? Because in the solid tumor, there is the significant presence of CCR4 and CCR8. They play a role in the trafficking of recruitment of FOXP3 Treg cells. And CCR4 has CCL17 and 22 ligands, whereas CCR8 has 4 ligands, CCL1, CCL8, CCL16, and CCL18. Now, let's see how we can integrate this. So before proceeding for our study, at first we want to know, means what we are trying to check in our lab, that how we could best stratify our rectal adenocarcinoma patients. So to find out that solution, before we proceeded with the TCGA data and try to understand how this FOXP3 and CCR4, CCR8 axis are the play a role in immune response of rectal adenocarcinoma. So we analyze and study the TCH data by Ulkan data analysis portal, then by C-Bio portal, and also we have included that locally advanced rectal carcinoma tumor samples in our study and want to check how these FOXP3, CCR4, and CCR8, their ligands plays role. And we are trying to correlate with this information with the clinico-pathological study of the LARC patients of Indian cohorts. Now, let us see at first how, what is the observation of TCGA. And what we observed that both FOXP3 and CCR8 were increased significantly in the primary tumor compared to the normal control samples. Also, there is a significant association between FOXP3 and CCR4 and CCR8 as well. Then we wanted to check whether CCR4 is associated with CCL17 and 22. The result was that the significant high level of correlation between CCR4 and CCL2. Then we asked that whether our Indian cohorts also present this TCAG data? But the answer is no. So then we wanted to check that and recruit that locally advanced rectal carcinoma in our study to identify or to better stratify those rectal adenocarcinoma patients. And this is the TNM staging of locally advanced rectal carcinoma. And I am not going too much on this therapeutic aspect because our first speaker of the day, she nicely presented this treatment management. What we did for our study, we recruited LARC patients from our hospital. And for this study, we want to recruit the treatment naive patients, and also we will follow them with neoadjuvant chemoradiation therapy, and then take the surgical samples. So this information is only for the 10 patients, what we collected still now. We are continuously recruiting our patients, and what we observe among them, the 50% contains the high FOXP3 median, high FOXP3 level, and 50% with low. Now, among these high FOXP3 and low FOXP3, what we observe among these high FOXP3 patients, they have the lymph node invasion T24N2, whereas the low FOXP3, they have the T4N0. Next, we studied this CCR4 expression, and for these expression studies, we use the housekeeping gene GAPDH and beta-actin and studied their expression. So, like FOXP3, CCR4 and CCR8 also has the 50% with high expression level and 50% with low expression level. Then we studied the ratio of this CCR4 and CCR8. Interestingly, the 40% having this CCR4 CCR8 ratio 0.5. That means the CCR8 level is higher than the CCR4, whereas the 50% having the similar level of expression. Now let us see what are the TNM staging of those patients. Here, in this case, T4N0 covering about 75% patient, and here about 75% patient having T24N2. That's what we observed in the FOXP3 high. Let us see what's happened in FOXP3 high also. So in FOXP3 high, we can see that CCR4 and CCR8 ratio is equal. So now makes things more complicated. Okay, now let us see what is the expression level of CCL17 and 22. This heat map is showing variable level of expression among those patients. Then we again integrate this FOXP3 and FOXP3 low with this ratio of CCL17 and 22. And what we observe that FOXP3 high, the ratio is pretty less compared to the FOXP3 low. Now, why it is less? That could be because of that CCL2 level is much higher. Then we categorize to those patients and studied the. And there we saw that FOXP3 has in the CCL17 and 22 low. And then again, for CCL8, we studied the ratio of CCL18 and 8. And there we observed that CCL8 level is higher in FOXP3 high. And there were the T24N12, and this one is for T34N0. So there is differential level of expression among this FOXP3 and high. Next, we studied the TCGA. In TCGA data, we observed that CCR8 and CCL18 showing the strong expression. In our study, we did not observe any CCL1 and 16.
Please wrap up.
Yes, sir. So this CCL18 in TCGA data, we observed that the higher level of CCL18, there is survivability is less. So in conclusion, we can draw that for TCGA, it is showing that CCL18 is playing role. For our case, for Indian cohorts, it could be mediated to FOXP3, CCR4, CCL2, 22, or could be FOXP3, CCR8, and CCL8. So that needs much recruitment of more number of patients, which we are trying to integrate in the immunoscore analysis that we are currently proceeding. So my acknowledgement to Global Cancer Consortium, and this is our team of scientists and the clinicians that we are working in SGCCRI. Thank you for your kind patience and hearing.
So yeah, now it's open for discussion. Yes, please.
Nice analysis. So in rectal carcinoma, a subset are mismatch repair mutant, and we'll have a very different immune microenvironment. Did you adjust for those, or did you separate out the mismatch repair mutant versus the mismatch repair stable rectal adenocarcinomas? So a subset of rectal cancer, colon cancers and rectal adenomas have underlying mutations in mismatch repair. They have high mutation burden and have a very dense lymphocytic infiltration.
Right now we are correlating with this immunoscore, and later on we will go for this mismatch repair or other different type of mutations like KRAS, TP53,
Right.
and all those.
Right.
Later on we will connect and study how they are integrating with this data. But before that, we are trying to stratify based on basically on this immune factor.
Yeah. You may want to make sure separate out the mismatch because they're probably different. They're a different cancer than the mismatch stable cancers.
Okay. Yeah, thank you.
Okay, so any further questions? Yes.
Presentation. So I am just one technical question. While measuring FOXP3, did you isolate CD4 T cells or you take it in the whole tissue?
Using these biopsy samples, now these are expression study, we will do immunohistochemistry. Yes, that is the good question. Why it is only FOXP3? In our plan, we will also integrate the TAM and MDSC because they are also playing role in these suppression.
My question is not for TAM or other things because FOXP3 is restricted on CD4 only.
Yes.
And the amount of FOXP3 could be relied on two factors, number of CD4 T cells or the FOXP3 expressing population of the CD4 T cells. So can you distinguish between that?
Yeah.
Because all other things are tissue mediated. Several cell population can produce those things.
Integrate with CD8 also. Right now we have
But CD8 don't express FOXP3.
No, CD8 don't express FOXP3. Means we will correlate with CD8 and FOXP3, their level and integrate it here.
Yeah. So do you think if you can do cell subset specific FOXP3 versus CCL2, that will be more specific for the things?
Yeah, that could be a good approach. Thanks for your suggestions.
Yeah, thank you.
Thank you.
Thank you, Dr. Mondal. So we move to the next.
Our next speaker is online, Dr. Vaibhav Jain. Dr. Vaibhav Jain is Research Associate in University of Pennsylvania. He will be talking about targeting UGCG dependent lipid remodeling overcomes resistance to lysosomal autophagy inhibition in cancer. Over to you, Dr. Vaibhav Jain.
Thank you very much and for the introduction.
Vaibhav, sorry to interrupt you. You have only 8 minute time. Oh, sorry, 10 minutes time.
Yeah.
You to wrap up.
Yeah. Sure. Yeah. So I would be sharing the work which we recently published in Cancer Discovery, and the title of the talk is Targeting an Enzyme which is important for glucosylceramide pathway overcomes resistance to lysosomal autophagy inhibition. And not taking too much time in introducing the autophagy, it's a cellular survival mechanism, and various anti-cancer therapy, immunotherapy, radiotherapy are known to induce metabolic stress and induce autophagy. And this autophagy induction gives a energy reserve and cancer cell survival, which leads to the resistance to various cancer therapy. However, and this makes autophagy an interesting target in cancer. However, clinically used lysosomal autophagy inhibitors like hydroxychloroquine rarely show single-agent anti-tumor activity in various clinical trials, including the one which we did in our lab, and that led to the invention of more potent dimeric chloroquine synthesized by our collaborator at Penn that showed single-agent anti-tumor activity in preclinical model. But in either in preclinical studies of these more potent dimeric chloroquine or in the clinical trials conducted with hydroxychloroquine, tumor regrowth has been shown to continue. indicating that resistance to autophagy inhibition exists. So to study the autophagy resistance, we took melanoma as a model, and we thrown these two autophagy inhibitor, more potent dimeric chloroquine and hydroxychloroquine, and we did unbiased proteomics, and this is the heat map which showed the 22 lipid proteins. So our IP analysis showed that out of all proteins we studied, lipid metabolism pathway was significantly most upregulated. So we fetched a list of lipid metabolism protein from these list from the 375T cells that were treated with DC661 or hydroxychloroquine. And this is the list of 22 lipid metabolism proteins that were significantly upregulated by more potent DC or hydroxychloroquine. And the names in the bold are the 12 proteins that was significantly upregulated by both DC and hydroxychloroquine. And the top hit was found in ApoB, which was the source of this protein was serum. And the next hit was UGCG, which is an enzyme UTP glucose ceramide glucose transferase that plays an important role in sphingolipid metabolism. That poised us to do the lipidomics analysis. And in lipidomics, we found a massive remodeling followed by treatment with hydroxychloroquine in magenta and in the red in DC661. And the most prominent changes we saw in hexosyl ceramide, that is synthesized by UGCG, followed by sphingomyelin and ceramide. So to investigate the cholesterol in lipids, we use Philippine staining, and these images are showing cholesterol in green, and we used a lysosomal marker, LAMP1, and we found that DC661 or hydroxychloroquine significantly increase accumulation of cholesterol within lysosomes and also on the cell membrane. So this cholesterol and sphingolipids are important for lipid rafts, which are known to in membrane repair and also cellular signaling that is important for immune signaling and cancer cell survival or death. So we use a lipid raft marker, choletoxin B, which predominantly binds to GM1, which is a lipid, and we use another marker, protein marker, flotilin-1, and we use antibody to antiflotilin. And these images on the right shows that when these A375P cells were treated with DC661, we found induction of lipid raft, which are on the membrane, which you can see here in the green color on the magenta, are like the nanodomain shaped structures, not the spreaded form. And this flotilin staining is also showing that choletoxin B and flotilin 2, both markers were present on the cell membrane. To look into the lysosomes, which is the target of these hydroxychloroquine and DC661, this is the super resolution image and taken by STUD imaging. And this is the single lysosome. And this, you would appreciate that these in the green, this is the choletoxin B, the GM1. This lipid raft increase induced by DC661 was found on lysosomal membrane. So these were not just the accumulation, but they were formed on the lysosomal membrane. So so far I have convinced you that hydroxychloroquine or DC661, they increase lipid raft from the plasma membrane and lysosomes. So next question was to see, to answer whether this increase in glycosphingolipid and other lipids was a part of resistance mechanism or providing sensitivity to these lysosomal inhibitor. So we inhibited sphingolipid different steps and also the cholesterol pathway. In sphingolipids, sphingolipid pathway is a very complex pathway comprised of de novo synthesis, salvage, and sphingomyelin hydrolysis. We inhibited each enzyme of the de novo pathway using myrosin, which inhibits the rate-limiting enzyme serine palmitoyl transferase. And this is an MTT assay that shows that inhibiting either de novo pathway or sphingomyelin hydrolysis by ceramycin did not had any effect on the IC50 of DC661. That did not augment, that did not change the toxicity of these lysosomal inhibitors. But when we combined this DC661 with UGCG enzyme inhibitor Gen Z, we saw a significant drop in IC50, showing the augmentation of cytotoxicity of this lysosomal inhibitor, including.
Have to wrap up.
Yes. So yeah, so next we connected this to lysosomal injury, and we found we specifically knocked down this UGCG that was the most promising target, and we genetically modulated this enzyme that shows by knocking down led to more sensitivity and lysosomal damage that we showed by galectin-3 imaging, and overexpression led to the resistance induced by this lysosomal inhibitor. And this is the patient data that showed in TCGA. Indeed, the UGCG itself is a marker for melanoma patients. 130 patients we took in TCG analysis. And to see the in vivo activity of this combination, and we use WM4552 from the patient. These were derived from a patient that did not respond in clinical trial to this hydroxychloroquine and BRAF and trametinib, and that showed excellent in vivo activity in this blue line in compared to their either treatment alone, and also prolong the survival of tumor-bearing animal. And this is important to note that aliglutide is already FDA-approved drug for Gaucher disease. So far, I have convinced that targeting this UGCG-mediated lipid raft enhances the toxicity of these lysosomal inhibitors. And we are further investigating this pathway in anti-tumor response in our lab to combine this aliglutide and autophagy inhibitors. And these are my acknowledgements. I would like to thank my supervisor, Professor Ravi Amravati, Monica Bhardwaj, who was in our lab, and now she has joined MIT and Vistar Institute and other lab members. Thank you very much.
Thank you, Dr. Jain. So, paper is now open for discussion. Yes.
As you know, hydroxychloroquine or even chloroquine in cell culture, but hydroxychloroquine in some of the clinical trials that Ravi and you all have done has been shown to actually work in some of the patients.
Yes.
Is there a difference in the lipid raft expression in the patients where it works versus in the patients where it does not work?
Yeah, it's a very good question. So I try to get the samples from patients, but unfortunately, the samples were not available. But we are in the process. In future, I think this lipid raft could serve as a pharmacodynamic markers, like the patient who could be resistant. These lipid raft can be measured in those patients. But yeah, it's a good question, but we could not get the samples. And in the long-term treatment with hydroxychloroquine, the patient progress on the treatment.
Is any further question? Thank you, Dr. Jain.
Thank you.
Move up to the next speaker.
Now I will invite Dr. Anjali Bhatt. Dr. Anjali Bhatt is research scientist at IIT Delhi, and she will be speaking on investigating therapeutic implications of intratumoral heterogeneity in triple-negative breast cancer, spatial transcriptomics, and organoid models.
Good morning, all. Very warm welcome to all of you. I'm Dr. Anjali. I'm working as a project research scientist at Kusuma School of Biological Sciences, IIT Delhi. Today, I'll be giving you some insights on our current project, and I'll be grateful to you for your comments. And the project is based on investigating the intratumoral heterogeneity in the triple negative breast cancer, and we are trying to use organoid models and spatial omics to decipher this intratumoral heterogeneity. A brief about my academic background. So I have done my PhD from University of Delhi, Molecular Oncology Lab, and my postdoc from University of Nebraska Medical Center. Thereafter, I have been associated as a research scientist in IIT Delhi. So I'll straight come to the rationale of our project. What makes TNBC very difficult to treat? It's because of three primary reasons. So one is the lack of the receptor expression on TNBC cells. Second is that TNBC is a very heterogeneous TNBC subtype of breast cancer, which is characterized by different molecular subtypes. And thirdly, because of the complex tumor microenvironment. So, despite of all the current therapy regimes, whichever we are actively developing, TNBC, we are not still sure that which patients are going to respond towards a particular kind of therapy and which patients will not show any kind of response. So, considering this, there are a number of options which leads to more complexity and more cost of these in synthesizing the drugs, doing oncology-based trials. But there is a need of some cost-effective and a more physiologically relevant platform with a shorter capture time for testing the response to these newer therapies. This brings us close to the concept of precision medicine and personalized therapies. So the thought that which was traditional, that one treatment fits in all, no longer exists now. Now people and world is moving more towards the concept of precision medicine. Now, to develop precision medicine, following the route of doing in vitro screens and in vivo animal testing, it's a very long process and very cumbersome. So, to develop patient-specific therapies, we need to develop a very cost-effective method which can actually reduce the decision-making time of clinicians and could guide them with immediate course of treatment for patients. So, considering this, we are using a dual approach. One approach is the use of organoids, which are basically complex 3D ex vivo tissue cultures, and they are known to reflect the genotype and phenotype of the original tissue with preserved cellular heterogeneity. So the best thing with these organoids is that you can easily collect it from the patient tissue samples, isolate it from the patient tissue samples, do disease modeling, develop some kind of personalized therapy which suits to that particular patient. We can also do single cell high throughput analysis, analyze the genetic modifications, stability, and at the same time, we can also create the living biobank of these organoids, which are specific to that particular patient. So in the context of TNBC, analyzing different kind of chemotherapeutic or immunotherapeutic responses in a particular organoid setup first would be a better approach to understand that is that patient going to be actually responsive to that particular kind of therapy or not. In this direction, we are actively working in collaboration with AIMS New Delhi. We are collecting our samples from TNBC patients before treatment, after treatment, and recurrent patients. And we were actually successfully able to do the growth assessment of these TNBC organoids in our lab culture setup. And we were successfully able to grow them after a period of 12 days. Apart from that, we could also see that these organoids, they were effectively able to recapitulate different kind of morphologies, which TNBC subtypes, they are actually reported to show. So it could be the lumen type, which is shown by the luminal progenitor cells, or it could be the bunch of cells clustered together, which are shown by the basal stem cell population, which is prevalent in TNBC. So we are also having our hands-on on doing immunostaining of organoids, wherein we are trying to do some in-depth characterization of these organoids, and which we are also trying to work on the development of organoid biobanks. And later on down the lane, we plan to do the organoid drug response studies. Now, this is one aspect, studying organoids is one aspect of understanding the tumor heterogeneity. So the second aspect is that where we still lag behind is how do we analyze the gene expression data basically? Either it's in the patient tumor tissue or it could be in the organoid model itself. So that is where the role of spatial transcriptomics comes in. So the spatial transcriptomics analyzes the gene expression within the tissue samples while preserving the spatial context of those genes. Basically, it will help us to analyze gene expression in situ, and we will be able to see that which genes are being expressed within the tissue's original structure. And it allows for allows for a high resolution mapping of gene expression. So for this objective, our workflow starts with, so we either create these TNBC tissue-derived formalin fixed paraffin blocks, or it could be the organoids also, and then followed by the TNBC tumor tissue characterization. And herein I have shown the TNBC heterogeneity in terms of the hypoxic regions, which are marked by the enhanced GLUT1 staining in these post-treatment TNBC tissues. So this is followed by, so actually this work has been outsourced to one of our companies with one of the associated companies. So that is working in close, we are working in close collaboration with that company for getting our samples analyzed. So what kind of response are we expecting out of this spatial transcriptomics? So this could help us in identifying the distinct spatial immune micro landscapes. It could also help us in identifying the actual gene expression patterns without disturbing the tissue integrity, and which could down the lane help us in identifying that what kind of therapeutic response that patient actually needs to have. So I would like to conclude my presentation here with this thought that combining the use of organoid models and spatial omics would definitely be a better approach down the lane for studying the tumor heterogeneity in general. Thank you.
Thank you for finishing on time. So now it's open for discussion. Yeah. Question? Oh, back there. Yeah, please go ahead. Just a second.
This is very nice work. This is very nice work. I'm really glad you're making these models of triple negative breast cancer. It's very highly heterogeneous disease. Again, I would say, are you also doing genomic profiling of these tumors, separating the BRCA1 mutants from the others, which probably have distinct biology?
Sorry, I couldn't get it.
Are you also doing genomic like bulk genomic analysis to identify underlying the mutational spectra of each of these organoids? Samples you're doing?
We are actually trying to do spatial transcriptomics and trying to analyze the gene expression in that context.
But that doesn't, those are probably in part determined by the underlying genomic alterations present in the tumor, including, for example, like
down the lane, we also plan to have the full in-depth genomic characterization of these organoids also.
I think that will be helpful in classifying.
Yes, true, exactly.
Okay, thank you. Yeah.
Thank you so much, ma'am, for a very insightful presentation. Ma'am, I just had a question.
Can you take close?
Okay. So just one question regarding the organoids, like while using organoids to study gene expression or epigenetic makeup or maybe effect on various chemotherapeutic agents, there is always a lack of control which is there because we'll be testing on the tumor organoids. So, ma'am, can you please elaborate on that, how to overcome these particular limitations?
Actually, that's a very good point because in organoid studies, we actually face this difficulty of having the control set. But yes, organoids can also be synthesized from the normal tissues as well, apart from the tumor organoids. So that could be taken as control. But yes, if we are talking about tumor organoids and tumor resections, at that point of time, we face difficulty in having the control cells. So yes, that is actually, but we can take some control cells as like control tissue cells for the for our experiments also.
Thank you so much, ma'am.
Yeah.
Is there any more? Okay, thank you, Ranjali.
Now I will invite our next speaker, Dr. Vimal Prasad Jeet. He is a postdoctoral fellow from All India Institute of Medical Sciences, New Delhi. He will be speaking on POT-E Notch1 signaling Crosstalk, a potential regulator of signaling pathway and governs oncogenic phenotype in epithelial ovarian cancer.
Respected dignitaries, so our laboratory basically works on gynecological oncology, especially breast and ovarian cancer. So my work is a part of postdoc that is 14 of signaling crosstalk plays an important role in regulating ovarian cancer phenotype. So ovarian cancer is the major cause of morbidity and mortality and prominent gynecological malignancy, and there are many causes like BRCA mutation loss of autozygosity and P53 mutation signatures. So there are different theories put forward to explain the origin of ovarian cancer. Still, it is poorly understood, and so till now, ovarian cancer is accompanied by chemotherapy and surgery are the major therapeutic implication. However, overexpression of cancer testis antigen, especially in tumor with respect to normal tissue, plays an attracting role to the scientist. And these cancer testis antigen accompanied hundreds in families, which are mostly CTCG genes, and the cancer testis antigen, especially port family, what we are working on is basically localized to the autosome, basically non-HCT antigens. So these port genes are basically 14 different closely parallels, and they are mostly confined to the 8 different chromosomes. And that is discovered by Ira Pastan group at NCIE. And this port gene family, the structure and functional basis are poorly understood. And our group is trying to elucidate it better. So recently we have a publication in Cell Press that this port parallels plays a prominent role in regulating the cancer phenotype. So last decades, couple of publications have been published in Nature and other journals that shows that port different port parallels like port E and port G, they are regulating cancer phenotype, and they are elevated in tumor, overexpressed in tumor condition with respect to the normal tissues. So our evidence, previous evidence shows that this pan port, which are common region of the port family, they are mostly overexpressed in different stages and grades of the ovarian cancer with respect to the normal tissues. So to prove that, I am working on a particular protein port E that is confined to the chromosome number 2. So the role of port E in cancer, basically ovarian cancer and other cancer, it is poorly understood. And this is the first group of primary proof of concept we have generated. And the figure A, you can see that port E gene expression has been overexpressed in ovarian cancer, and accompanied by ovarian in tumor condition also port E is overexpressed. In different stages, there is no significant difference, and it is associated with overall and disease-free survival. So comparison to the D and E and F figure, you can see that cancer antigen 125 CEA and CA19.9, these are the potential biomarker which are present in the clinical setting. So we have compared figure D comparison as benign patients and E is the malignant patients, where we observe that port E is relatively overexpressed with respect to benign and control. And with respect to CA125 and CEA, there is a possible comparison of port E overexpression in ovarian. Serum ELISA, by serum ELISA, we have observed port E. So in different cancer conditions also port E associated with overall survival and disease-free survival. So TCG analysis indicates there is overexpression of port E in different conditions, and it is associated with stages, grades, age, and patient race. So to elucidate the localization and expression of port E, we have screened port E in different ovarian cancer cell lines and shows the localization of port E in different ovarian cancer cells, and we observe that mostly it is compartmentalized to the nucleus and cytoplasm compartments. To gain a better insight, the cell line which have better expressed port E, we observe they are characterized by higher oncogenic phenotype aggressiveness in comparison to the cell line having less slow growing. They have less port E, so the cell lines have less slow growing and in terms of oncogenic phenotype. So to elucidate that, we developed knockout and overexpress model, and we observed by CRISPR-Cas9 A2780 and OPCAR8, we knock out port E, you can see, and we develop 3 different stable clones. And in OCAR4, port E is less expressed, so we overexpress port E. So we observe that overexpression of port E is associated with increase in cell proliferation, colony formation, and less apoptosis in comparison to the port E knockout. So to better elucidate, we again in 40 overexpressed clones, we carried out transcriptomics, especially RNA sequencing, and we observed that possibly notch signaling claudin 3, aurora kinase B, and these are the mostly genes which are significantly enriched in 40 overexpressed condition. And figure F has indicated in TCGA data analysis, these genes are also preferentially overexpressed in ovarian tumor with respect to the normal. Then we carried out proteomics, and we observed that this possibly the survival signaling pathways are mostly increased, overexpressed in 40 overexpressed proteomic cells, especially OCAR4. And they are associated like hedgehog signaling, node-like signaling, JAK-STAT signaling, NRF2 signaling. These are the mostly enriched pathways which are overexpressed under 40 overexpressed. So in other cellular signaling, our laboratory is also working. So I am basically working on the notch signaling aspect. So owing to the presence of the anchoring domain between this port and the notch, we hypothesized, our in silico data also elucidated that there is potential interaction between port and notch. So we further put forwarded and we screened all the notch pathways, genes and proteins by Western blotting and PCR and qPCR. And again, we developed notch stable clones and overexpress and knockout clones. So our enricher figure A, you can see pathway analysis. So port E is possibly enriched in notch signaling, P53 transcriptional network, and GPCR signaling. So notch gene is also overexpressed, as figure B indicates. There is overexpression of notch NACD1, notch1 in ovarian tumors. And notch1 overexpression also associated with overall and disease-free survival. And figure F indicates there is potential correlation between port E and notch1. So figure G indicates there is screening by qPCR port notch1, JAG1, and HAS1, possibly notch ligands and downstream signaling intermediates, also by TCG analysis as observed in figure H. So one of the peculiar characteristic feature we observed that by port E knockout, we observed there is significant down regulation of notch pathway as observed in A2780. And OCAR4, when we overexpress port E, there is potential overexpression of notch pathway. So this stimulated us to move forward that dose-dependent overexpression of port E also associated with dose-dependent overexpression of notch1 and HAS1 and other notch intermediates. So also we observed that other survival signaling pathway like phosphorylated form of AKT and kappa beta, GSK3 beta, they are also active in port E overexpressed condition, and they are significantly decreased in port E.
Please wrap up. You have 1 minute.
So to elucidate the port E binding pattern, we have carried out IPMS by pulling down port E, and we observed that these port E interacting proteins plays an important role in potential cellular component biological process and molecular processes. So we, to target the port E and notch signaling axis, we inhibited notch pathway by the APT notch inhibitor, and we observed there is potential significant decrease in notch, significant decrease in port E also, and we observed that port E significantly compensate notch1 stability by cyclohexamide experiment. So another thing we carried out a reconstitution experiment where we observed that decrease of DAPT, and in another condition, decrease of DAPT associated with the port E overexpression associated with recompensation of the reactivation of the cell signaling and other signaling intermediates. So port E possibly stimulates notch1 to compensate the other signaling intermediates. So whether port E interacts with notch1 and by transcriptionally and physically, so we carried out IPMS. And
so your time is over. Please wrap up.
We observed that port E interact with notch1 promoter and NACD1 directly by immunoprecipitation and qPCR. So by organoid and spheroid model, we observed that port E overexpression associated with increase in overall size of the organoid and spheroids. So this is our team, and Professor G.K. Rath, Ashok Samma, Professor M.D. Ray, our mentor. This is our team. Thank you.
Thank you.
So to conclude, we observed that targeting port E and notch1 axis can regulate oncogenic phenotype, and we are targeting one drug diclofenac. That is another work going on.
Yeah. So any question?
Thank you, sir. Your presentation was very nice. Sir, my question is that you are targeting potty. Ma'am, sir, have you thought about early detection of epithelial ovarian cancer using the same phenomena for early detection? Like you said, CA125 is less expressed. So anything for early detection?
That data I have shown. In serum also 40 overexpression is there in ovarian cancer with respect to the healthy controls serum. So that part we are also working to use as a early biomarker what you have.
Thank you, sir.
Any further question? Thank you.
Thank you, Dr. Vimal. Next, we have Mr. Vivek Uttam. He's a PhD scholar in Central University of Punjab and shall be delivering a presentation on immune-related long non-coding RNA signature in esophageal cancer. Mr. Vivek Uttam.
Good afternoon, everyone. My name is Vivek. I'm a PhD scholar in the supervision of Professor Akhil Jain from Central University of Punjab. Today, I'm standing here to present my work on the topic immune-related long non-coding RNA signature in esophageal cancer. As highlighted by the Globocan 2020 cancer statistics, esophageal cancer is the eighth most prevalent cancer in India, and esophageal cancer is the eighth most prevalent cancer in India, with with and sixth leading cause of cancer-related mortality. In a retrospective study done by our lab in the Malwa region of Punjab, we found that esophageal cancer is the fourth most prevalent cancer in this area. Thus, this cancer poses a significant burden on public health in India. For this, to deal with such disease, we wanted to explore the novel biomarkers with high reliability and robustness to detect these diseases early in the early stages. For that, we included we tried to identify the immune-related LNCRNA, which were associated with prognosis by using the TCGA data of 162 esophageal cancer patients and 11 adjacent normal controls. For this, first we have done the differential expression analysis, and we found that around 3,700 differentially expressed RNA were found in esophageal cancer. Among these, among these 967 LNCRNA were reported, and 2,222 mRNAs were reported. From these mRNAs, we tried to find those mRNAs which were especially play a role in immunity. And using those immune-related mRNAs, we done the co-expression analysis with the significantly differentially expressed LNCRNAs. And then using those differentially expressed immune-related LNCRNAs, we try to find the those LNCRNA having the prognostic role. And in our study, we found 12 such LNC RNAs having a role in immunity as well as prognosis of esophageal cancer patients. These are the 12 LNC RNAs that we found having a significant prognostic role in esophageal cancer. Then, using these 12 immune-related LNC RNAs, we plotted a forest plot doing the COX regulation hazard analysis, and the results showed us that they are uh, among these only one LNC RNA, that is AL35, is more hazardous, significantly hazardous than others. So we tried to make a risk score out of these signature, and using the risk score, we calculated the risk score using the expression value of these LNC RNA and the hazard ratio. And after that, we divided the patients based on these risk score into high risk and low risk population. And the Kaplan-Meier plot. Then we plotted the Kaplan-Meier plot using the risk score, and the result shows us that this risk score of ours significantly differentiate the population into a high risk and low risk, with the low risk population having more overall survival than the high risk population. Further, using the receiver operating characteristic curve, we validated that these LMC RNA signature can significantly differentiate the population, and can be used for diagnosing the patients using the training set and test set. And the AUC value above 0.7 significantly shows that our risk score is can moderately diagnose the patients, prognose the patients on the risk score basis. Further, we try to find the pathways and gene ontology terms associated with this LNCRNA signature, and the result shows that the inflammatory response and response to cytokines and cytokine-mediated signaling pathways are significantly enriched with these LNCRNA signature. Moreover, the other immune-related pathways like toll-like receptor pathways, natural killer cell-mediated cytotoxicity are also significantly enriched in this signature. Finally, to check if there is any translational potential of this immune-related LNCRNA-based risk score, we tried to see if our LNCRNA signature can significantly differentiate the population, a high risk and low risk population on the and the immune checkpoints expression. And the result shows that our signature can significantly differentiate the PD-L1 and PD-L2 and TIM3 immune checkpoints. Thus, we can employ the immunotherapeutic drugs on those patients with the high risk population. And furthermore, we using the cybersort and cybersort algorithm, we also try to see the significant enriched immune cells present in the high risk and low risk population. And the result shows that B cell, naive B cell, macrophage, and
you have 1 minute left.
Plasma cells were highly significantly enriched in low risk population, whereas the M2 macrophages, that is tumor associated macrophages, were significantly highly enriched in high risk population. Thus hereby I conclude that this study identified the 12 immune-related LNC signature that effectively divide the esophageal cancer patient into high risk and low risk population, demonstrating that its prognostic significance. These immune-related LNC-RNA were closely linked to immune-related pathways and immune checkpoint markers, suggesting their potential role in predicting immunotherapy response. For future research and clinical application, we are thinking to further validate these LNC-RNA signature in larger cohort using the QRT PCR and functional assays. In integrating these immune-related LNC-RNA-based risk model with other molecular and clinical parameter will enhance the personalized treatment strategy, providing new insights into immune modulation and potential therapeutic targets in esophageal cancer. Thank you.
Thank you. So now we can have some questions. None is there. So these samples were collected from where?
Database.
That you said they were
from TCGA database, the Cancer Genome Atlas.
okay. Okay. So yeah, thank you.
Next, we have Dr. Joni Yadav. She is a postdoctoral student at Delhi University and shall be talking on head and neck cancer exosomes, key players in macrophage functional modulation.
A very good afternoon, one and all. So today I am going to speak upon head and neck cancer exosomes that are the key players in macrophage functional modulation. So these exosomes are the smallest type of microvesicles. They are released in the tumor microenvironment. So if we talk about the tumor microenvironment, there are n number of cells which are interacting within themselves. And there are many ways, like direct contact. It can be indirect, using via different soluble mediators. Among those, the one of the most important is the exosomes, which are the smallest type of vesicles, and they have a specific size range around 30 to 100 nanometers, and they have the specific surface marker on them, which includes like CD99, CD63, Alex proteins, and they are released by all type of cells in their extracellular microenvironments. Initially, they are considered as a trash cans, which are released by the cells. However, later on, it was found that they are rich in different types of lipids, polypeptides, proteins, DNA, RNA, which are active in the recipient cells. So initially, we have isolated these head and neck cancer exosomes from the cell lines, and we have characterized them. We have for this, we have performed the transmission electron microscopy as well as the dynamic like scattering for their size assessment, and we found that our exosomes having the size ranges around from 40 to 90 nanometers. Later on, since we want to check their impact on the macrophages, so we have taken the THP1 monocytes. Initially, we have treated those cells with the PMA and we converted from monocytes to the macrophages and not macrophages. Then later on, we have checked their uptake in these THP1 differentiated macrophages. So we have checked on the different time points, and we found that the uptake process has been started from the 30 minutes within after the co-incubation of these isolated exosomes with these THP macrophages. And it goes on increasing, and we found that at the 4 hour there is a highest uptake in the THP1 monocytes, macrophages, sorry. Later on, for confirmation of whether these exosomes are able to polarize the THP1 in M1 or M2 macrophages, so we have checked this using the real-time quantitative PCR, and we have taken 3 markers, that is TNF alpha, INOS, and IL-12P40 for the M1 phenotype markers. And for M2 phenotype, we have taken the TGF beta, arginase 1, and IL-10. And we found that our head and neck cancer exosomes, they tend to polarize the THP1 monocyte macrophages into the M1 phenotypes. Later, we also checked using the immunoblotting assay, and we have checked the different before checking with the lab with this immunoblotting. We have searched the literature. We found that for the signaling is involved in this polarization process. So we have taken the proteins member related with these NF-kappa B AB1 family members, and we found that yes, there is a differential expression and which are basically favoring the M1 phenotype. Also, along with this, we have performed the transcriptomic and the proteomics analysis. And interestingly, we found that the sum of the transcripts of these polarization markers have been exported via exosomes into these cells. Also, along with this, we have checked and we found that the different NF-kappa B, AP1 and the STAT1, basically these three transcription factor related transcripts has been exported via these exosomes to the recipient cells. So in conclusion, we found that these exosomes have been taken by these macrophages and there is an elevated level of STAT1 and NF-kappa B, AP1 family proteins members, and along with this, the transcripts are also exported by the exosomes into these cells. However, in the proteomics analysis, we didn't find any proteins related with these signaling molecules. So, this is very interesting since the transcripts has been exported via these exosomes. However, whether they are translationally competent in the recipient cells, this is basically under investigation and we are working upon this. Thank you very much.
Thank you. Finishing well ahead of time. So now we can have some questions. Yeah. Yes. Yeah.
Oh, thank you so much.
Yeah, please. Can you give him?
Nice presentation. So how selectivity will be displayed? You said only transcripts will be selected for the, in the exosomes, but not the proteins are not part of the exosomes. So how that selectivity will be decided by the cell? Do you have any thought about that, Ari?
In our case, we found only the transcripts related with these. We have targeted the AP1 and STAT1 NF-kappa mediated signaling, which is responsible for the M1 phenotype. So in our case, we didn't find any proteins related with these. It might be possible that different system or different cancer might have these proteins as well as. In our case, we didn't find any protein.
So the selectivity, the exosomes may carry both proteins and microRNA, sometimes long non-coding
yes,
RNAs.
Yes, there are
also
studies which are basically via microRNA or non-coding RNA.
Correct. But are there any receptors? Probably you can look for the which are actually absent, so that those proteins are not part of that or something like that.
Sir, we are working on this right now. I can't say like.
Okay, so here is you want us.
Hi, I just have one query regarding this because nowadays exosomes are also using to deliver some drugs or encapsulating the drugs inside the exosomes or loading on the surface. So you were saying here that exosomes are also responsible to polarize the THP into it. So in cancer therapy, if someone is working on this, they are also encapsulating the drugs inside the exosomes and deliver them. So will there be any possibility that it will show the therapeutic although, but maybe it can also polarize the THP into?
Yes, because since there are different case they are also polarizing towards the M1 type or M2 type. There are different studies are there. So we can exploit this nature, whether they are beneficial to us or not. So we can use this property whether they are polarizing to M1 or M2 phenotype.
So any more question?
It's a nice talk. So because you have finished early, I'll just ask one question. So since your data indicates that if you treat the macrophage with tumor cell derived exosomes, so it will polarize the macrophage to the M1 phenotype, right? So if it is the case, then if you think about the tumor microenvironment, so those stamps are mostly M2 type. Can you comment on that?
So since M2 is like for favorite,
Yeah.
if I'm not wrong.
So I'm saying that mostly if you see the tumor microenvironment, like the TAMs, these are mostly closely resembles the M2 phenotype. So what is your comment on it? Because they are constantly interacting with the exosomes released by the cancer cells. Okay, so yeah, so what I'm trying to ask you that since you said that the interaction with the tumor-derived exosome, so that polarize the macrophage to M1 phenotype. Yeah, so but if you see in the tumor microenvironment, so those like those TAMs are mostly M2 phenotype, right? So what is because they are also interact.
Like in head and neck also, like there are different study and they showed that these exosomes are also favoring the M2 phenotype. So there is no like head and neck cancer exosomes are favoring the M1 only. So they are like composition is different since different origin. In head and neck cancer, there are different cell lines of the from the different origin. So might be like the cargo which is carried by these exosomes might be different. That's why they are polarizing differential.
Okay, thank you. Thank you.
Thank you.
Thanks, Joni, and good luck for your exam. Now we move to the next speaker, Ms. Unnati Shetty. He is a pharmacy student of Manipal College of Pharmaceutical Sciences, and she will be speaking on investigation of CYP2D6, C100D allele frequency in lung cancer patients in tertiary care hospital in southern India.
Good afternoon, everyone. I'm Unnati, and I'm a fifth pharmacy student studying at Manipal College of Pharmaceutical Sciences. I'm honored to present my work, Investigation of CYP2D6C100T allele frequency in lung cancer patients at a tertiary care hospital in southern India. This was carried out under the mentorship of my guide, Dr. Mahadev Rao. Among various types of cancer, lung cancer stands out as most commonly diagnosed cancer and also attributes to the highest cancer-related deaths worldwide. According to Globacon 2025 data, it's predicted that it's 1.95 million deaths is going to occur this year due to lung cancer. In India, 5.8% of all the cancer and 8.2% of all the cancer-related deaths are attributed to lung cancer. Speaking of rank, India ranks fourth in both incidence and mortality for lung cancer. So this highlights the need for proactive measures in cost-effective treatment strategies for the treatment of lung cancer. Speaking of the gene of interest, CYP2D6, it is a highly polymorphic gene that encodes CYP2D6, a drug metabolizer. Alteration in this gene has been attributed with both adverse drug reaction as well as decreased drug efficacy. The alleles in the CYP2D6 can be classified as having high function, low function, normal function, or no function at all. This gene encompasses various single nucleotide polymorphism, structural variants, and small insertions and deletions. The frequency of these alleles differs from one population to another. which could have significant influence on the drug metabolizing enzymatic function of CYP2D6. So that is why the rationale of this study is that knowing the frequency of CYP2D6 alleles among different populations will enable the clinicians to identify the individuals who will mostly who will benefit the most from preemptive genetic testing from actionable pharmacogenetic variation. The CYP2D6 gene harbors a missense variant that is 100C to T, known to significantly impact its expression and enzymatic activity. The study currently explores the allelic frequency of CYP2D6 100C to T in lung cancer patient in the Indian population. That is the main objective of this study, that is to determine the allelic frequency of 100C to T in lung cancer patient. We followed the following methodology, that is we recruited the lung cancer patients after medical evaluation by the oncologist, and we collected the clinical demographic data collection data using structured case report form. The blood sample was collected and sample processed and the DNA was extracted, and the SNP genotyping was performed by real-time PCR. The SNP CYP2D6 present on the Q arm of chromosome number 22. It is a drug metabolizer with the RSID of 1065852. It's a missense variant which causes a change in amino acid from proline to serine. These are the results of the study. That is, we recruited total of 44 patients, of which 60 who had a mean age of 61.55 plus 8.35 years. Most of the patients recruited were male, that is 64% of them, and 36% were female. The smoking status was that 66% of the recruited patients were non-smokers, whereas 25% were smokers, and 9 of them were former smokers. Alcohol consumption status was as follows: 79% of non-alcoholics, 14% of alcoholics, and 7% of former alcoholics. 84% of the patients did not have any history of tobacco chewing, and 16% did. Most of the patients recruited were in the terminal stage, that is stage 3 or stage 4, that is 82% stage 4 cancer patients, whereas 18% of stage 3. ECOG status were as follows: 91% of the patient had an ECOG status of 1, 5% had a 2, and 2% each for ECOG 3 and 4. The histology of the patient were as follows. Most of the patients were diagnosed with adenocarcinoma, that is 73% of them, followed by squamous cell carcinoma in 20%, small cell carcinoma and non-specified, not otherwise specified in 2% each. And the location of the tumor in the cancer patient, most of the patients had the tumor in the right upper region, followed by left upper region, and right lower region, and 11% in right middle, whereas 7% of the patients had the tumor in the left lower region, whereas 5% had it in the left hilar region. Mutation status of the cancer patients were as follows. Most of the patients had EGFR positive mutation, that is 59%, followed by TP53 in 16% and ALK in 13%. KRAS was found, KRAS, BRAF, and PIK3 and ROS mutation was found in 3% of the patients. Coming to the final cancer patient, the genotype GG was found in 59% of the patient, whereas GA in 36.3% of the patients, and AA in 4.5% of the patients. The allelic frequency of G was 0.77 and A was 0.22. These results are the part of ongoing pharmacogenomic studies of anti-cancer drugs in lung cancer patients. The translation potential of this study is that identifying the SNPs will facilitate the development of personalized treatments strategies by detecting potential biomarkers with adverse drug that are associated with adverse drug reaction. This study would comprehensively design the precision therapy of cancer drugs in lung cancer patients to improve the therapeutic outcomes by validation through non-randomized clinical trials, non-randomized controlled trials. These are the acknowledgement. I'm thankful for intramural funding, Marhi Manipal, and also the Department of Medical Oncology, Manipal College of Pharmaceutical Sciences, and Global Cancer Consortium and Amity University for providing me this opportunity to present my work. And lastly, the staff, research scholars, and friends at my department. Thank you, everyone.
Thank you. finishing on time. So now we can have some questions. Yeah.
Very nice work. It's interesting, most of your lung cancer patients are non-smokers and appropriate. I said, very nice work. Most of the lung cancer patients are non-smokers, and so it makes sense that the majority had EGFR mutations or ALK rearrangements, and only a minority had KRAS mutations. Are you following outcome on these patients? Are they getting? Do these patients have access to treatment with the targeted therapeutics? And it'd be interesting to see if the pharmacokinetics affects, drug metabolism. So, what are they being treated with? These patients being treated with? What drugs are they being treated with?
Oh, so they are being treated with EGFR, TKI inhibitors, mainly gefitinib, and all the other chemotherapy treatments.
And you're looking at the pharmacokinetic are you following pharmacokinetics of the drugs based on? All right.
The treatment is being done based on their mutation profile as well.
That makes sense, but it'd be interesting to see if the pharmacogenetics affects.
That will be the next step in the project.
Any further question? What is the normal allele frequency of this particular site in normal population? What you haven't got? Similar to what you have got with the patients, right? So there is no further question. Thank you.
Thank you so much. We have a small announcement. Lunch is served. Those who wish to go and proceed for the lunches can do so, but we shall be resuming with the presentation as it is. So those who wish can move and proceed to the lounge. Others and the speakers shall stay here for the presentation to resume. Next, we have Mr. Ayush Khandelwal. He is a research scholar at Manipal School of Life Sciences, Manipal, and he shall be speaking on exploring the role of MEF2A in cervical cancer. Ayush.
Good afternoon, everyone. My name is Ayush Khandelwal. I am a research scholar at Manipal School of Life Sciences. The title of my presentation is Exploring the Role of MEF2A, Myocyte Enhancer Factor 2A in Cervical Cancer. According to the GlobeCan report, cervical cancer is the fourth highest cancer in the world among females and second highest cancer in India among females. The risk factors that include in cervical cancer are multiple sexual partners, HPV infection, epigenetic modifications, smoking, and personal hygiene. The treatments that are available for the cervical cancer are targeted therapies, radiation therapy, surgery, and chemotherapy. This pictorial representation shows the stage-wise progression of cervical cancer. In the last year, July parliamentary session, Honorable Sudha Murthy ma'am also spoke about to combat the cervical cancer cell in the parliamentary session, from which government have taken certain initiatives like Sustainable Development Goal 3.4 is dedicated to reduce cervical cancer, that's by 2030. The Serum Institute of India also launched the Ceravac vaccine to combat the cervical cancer cells in India. The MEF2A gene, myocyte enhancer factor 2A gene, belongs to the MEF2 protein family, and it is a transcription factor which is highly conserved in humans, and it is composed of 12 exons. The chromosomal location of MEF2A is 15q26.3, and here this image represents the protein structure of MEF2A, in which it contains the METBOX domain, which is responsible mainly for DNA binding region, the MEF2A specific domain, and the TAB domain, the transcriptional activation domain. It majorly interacts with different cofactors to follow the further signaling. And it's at C-terminal region, it contains the nuclear localization signal. The cellular role of MEF2A is, it is a fundamental regulator in hypertrophic response. It is a muscle regulatory factor in the skeletal myogenesis. It is responsible for neuronal differentiation. And recent studies have showed that MEF2A plays a big role in the tumor inhibitory or promoting role based on the interaction that is between. So the research gap that we find in our study is to understand the mechanism of MEF2A gene and its aberrant expression in cervical cancer. Our hypothesis and previous data suggests that MEF2 has been downregulated in the cervical cancer cells and through multiple mechanisms facilitate the growth and survival of transformed cell. So we aim to analyze the impact of MEF2A dysregulation in cervical cancer. So we had done the in silico analysis for MEF2A regulation in cancer and understanding the biological pathways. And second, to characterize the biological function of MEF2A in cervical cancer. For our methodology for in silico analysis, we use publicly available database. For protein-protein interaction, we use a string database. For expression analysis, we use TCG-OLCAN. And for function enrichment analysis, we had used ShinyGo tool. For our in vitro studies, we had taken human cervical cancer cell lines, CHA, which is HPV16 positive cells, and C33A, which is HPV negative cells. We had done the MEF2A overexpression and generated the model system for MEF2A overexpression cell line. We picked the colonies and confirmed with the Western blot, and we had run further cellular assays. The in silico analysis shows that the MEF2A has been downregulated in the tumor cells, and it has been downregulated across the all stage-wise process. The protein-protein interaction shows the top 10 hub genes, which is interacting with the MEF2A, that is HDAC4, 5, 7, and 9, MyoG, MyoD1, MEF2A, and MEF2D. The biological process that involves in the MEF2A analysis is cellular response to DNA damage stimulus, chromosomal organization, and cellular response to stress. In Schett pathway analysis, we know that it involves in the B cell receptor signaling pathway, viral carcinogenesis, and it is involved in the microRNAs in the cancer. This is the in vitro study where we confirmed our overexpression of Western blot for the CHA as well as the C33A cells. And further, for the biological characterization, we had done the migration assay from 0th hour to the 48th hour, where we had seen that the control vector cell shows the much more migration rate compared to the MEF2 overexpression cell line. And the same result has been followed in the C33A cells also. Further, for checking the proliferation rate has been reduced for the CHA MEF2 overexpression cell lines compared to the vector cells for both in CHA as well as C33A cells. This colony formation assay also shows the retardation growth for the colony formation of cells for the overexpression of MEF2, in which the vector cell shows a much more colony formation rate compared to the MEF2 overexpression cells. Then further, we had done the actin phyllidin staining, in which we had checked the localization of the MEF2A protein. So we had done transfect our control cell with the only GFP containing plasmid, but the MEF2A overexpression cell has localized directly to the nucleus, which has been confirmed while using the haste dye, and we had done the merge images for this. So in our conclusion, the in silico study indicates that MEF2 is significantly downregulated in cervical cancer. The top 10 genes that are interacting with MEF2A are HDAC4, HDAC5, 7, 9, EP300, MyoD1, MEPK, MEFD. The function enrichment analysis showed that its pivotal role in chromosomal organization, cellular response to stress, and it involves in the signaling pathways including microRNAs in cancer and viral carcinogenesis. In vitro results shows that the overexpression of MEF2A cell exhibited reduced proliferation, migration, colony formation rate compared to the control vector cells, and MEF2A localization to the nucleus compartment of the cells. These findings underscore the potential tumor suppressive role of the MEF2 in cervical cancer, suggesting it has a promising target for therapeutic strategies. We thank Welcome Trust DBT India Alliance for their financial support, and we also thank Manipal School of Life Sciences for providing the infrastructure. Thank you.
Thank you for finishing well at time. So we have some questions. Any questions?
You have a question?
No. No. Okay. So how this MEF2 is in mechanistically, doing all this is you said the overexpression down inhibits the cell growth, right? So kind of a tumor suppressor. So what would be the mechanisms?
Yeah. While starting our project, we discovered that MEF2 is being downregulated in the cervical cancer cell lines. And in many literature survey, it is also reported that MEF2A plays a major important role with the EMT markers that plays a role with the proliferation and migration rate of the cells. So in cervical cell, it is down-regulated. So therefore, we had made that we make a model system for the MEF2A overexpression cells, so that to see the if we do overexpression of a MEF2A, thus it is inhibiting the proliferation and the migration rate for them. So therefore, we generating the model system and do the cellular assays to check whether the proliferation rate and the migration rate has been reduced for the cervical cancer cells.
Yeah, okay, but what's the mechanism? You know, how the it is doing that?
Mechanism, actually, we still working in our lab, but therefore we had identified it majorly plays a role in EMT markers. That data I haven't put into that, but still we are confirming other more pathways which are involving in the regulation of lowering down the proliferation rate and the migration rate in the cervical cancer cells.
Okay, thank you.
Thanks.
Now we move to the next speaker, Deeptima Jaiswal. She is a master's student from the National Institute of Science, Education and Research. She will be speaking on CHST4 and its role in gallbladder cancer susceptibility, mucin expression modulation via keratin sulfate pathways.
A very good morning to everyone present here. This is Deeptima Jaiswal, final year integrated BSMS student from NISA Bhubaneswar, and I'm going to be presenting my 2 years of master's thesis work that I have completed thus far under the guidance of Dr. Manjusha Dikshit. So the title of my work is CHST4 and its role in gallbladder cancer susceptibility, mucin expression modulation via keratin sulfate pathways. So to begin with, if you look into the GloboCan 2022 data, GBC ranks 22nd in the terms of incident rates globally. So the question that we get asked most frequently is why we chose to work with GBC instead of some other cancer type. So the answer of this lies in several factors. Firstly, if you look into gallbladder, it's, as we all know, it's a pretty small organ that lies slightly behind the liver, which makes it very difficult for it to be imaged via the tools and techniques that are currently available. Furthermore, it has been observed that 90% of patients that with GBC are actually asymptomatic until their cancer has been progressed up to stage 4. All of these makes it very difficult for the treatment of the patients. Furthermore, if you look into the incidence rates, the incidences, it has been observed that certain particular regions and populations across the globe report much higher incidence rates of GBC compared to the rest of the world. So based on this, it was hypothesized or concluded that both environmental and genetic factors might be playing a role in GBC development. So our question was, what could be the molecular target that could be associated with GBC development, progression, and or genetic predisposition in order to explore the potential treatment options for these patients. So to begin, for starting our search, we went to Human Protein Atlas. The idea was we thought if we could find a gene that has a very organ or tissue specific expression pattern in gallbladder, then could it be expression patterns of this gene could lead to GBC. So, and we found, fortunately, we found a lead going down this pathway, and we found there were 6 genes that had very organ-specific expression pattern in a gallbladder, human gallbladder, out of which we went to literature review, and we found that CHST4 has been implicated to play a tumorigenic role in cholangiocarcinoma and hepatocellular carcinoma. So based on this, we picked up CHST4 and we looked into the basic molecular functions of it and the metabolic pathways that it is involved in. So the basic function is a glycosylation of mucin type O glycans. So now that we had this, we first needed to know whether it is actually playing a role in GBC or not. For this, we went into bioinformatics. Sorry. Another thing, once we had this, that it is involved in Olin glycosylation, our question was whether this could be involved in cancer. And although we didn't find any studies in GBC, we did find studies in several other cancers that stated that yes, aberration in Olin glycosylation process is involved in cancer. So the glycan that is involved from our molecular pathway, we knew it is keratin sulfate. But how is it related to protein functionalities and molecular pathways? For this, we performed string analysis and found that 95% of the interactors of CHST4 were actually mucin family members. And how keratin sulfate is related to mucins? For that, we looked into the molecular and chemical structure of mucin family members, and we found that keratin sulfate and other such glycans that fall into the same category of families, that is dermatan sulfate, chondroitin sulfate, they actually form the backbone of the extracellular membrane of the mucin molecules. So based on this, we went into our bioinformatic analysis, and we, although we didn't find, only found 4 data sets in GEO containing GBC samples. We also looked into cholangiocarcinoma, and we found that yes, it is overexpressed in tumor samples compared to the normal patient samples, and it is leading to a worse prognostic survival rates in patients. And then performing DEG analysis and KEC pathway analysis on both GBC and cholangiocarcinoma samples. We checked for the commonalities, and we found that the most elevated or most likely involved pathways are MAPKs and PI3Ks. And the second part of the question was which out of the 23 mucin molecules, which of them is likely to be involved in GBC? For that, we again looked into the same data sets, and we found shortlisted mucin 1 to be likely candidate of this. And based on this, our hypothesis was that CHST4 might be involved in GBC development and progression via modulation of mucin 1 expression. So once this was done, we went on to in vitro validations. We created stable cell lines overexpressing CHST4, and we performed cell-based cell proliferation assay, colony formation assay, and scratch wound healing assay. And we found that yes, upon overexpression of CHST4, all of these abilities of the GBC cell lines were being upregulated. Furthermore, we performed an Alcian blue staining assay to confirm the sulfation extent of the glycans or glycoproteins present in these cell lines. And we found that upon overexpression of CHST4, the sulfation extent of the glycoproteins is also being elevated. So this was all going into our hypothesis that yes, CHST4 is showing a tumorigenic effect, and upon overexpression of CHST4 in GBC cells, glycoproteins is getting increased. So once, furthermore, we needed to know what are the exact molecular mechanism that is being employed once the glycoproteins are glycosylated and sulfated. So we performed immunoblotting assays, and we found that mucin 1 is leading to a change in overexpression in beta-catenin pathway, which is leading to ERK downregulation and AKT473 upregulation. And this data was further validated in vivo mice, not-skid mice model, and in which we found that yes, the xenograft.
You have 1 minute left.
Sorry. The tumor volume and weight is getting increased. Similarly, on performing IHC on patient tissue samples, we found that overexpression of all these were found. Now, the second point that I mentioned was, could it be involved in genetic predisposition in individual, for which we performed Sanger sequencing on approximately 150 patient sample and 150 normal samples. And we found that one particular variant, which is not reported thus far, involved in ODIA population, and we are currently looking into molecular aspect of whether this SNP could be involved in GBC. Thank you. So I would like to thank my PI Dr. Manjusha Dixit, and my PhD scholars, Somam Chaudhary, which my PhD guide, and the rest of the PhD mentors in my lab. Furthermore, I would like to thank AHRCC and AIMS Bhubaneswar for the samples they have provided me. Thank you so much.
Thank you. Yes. Any question?
Hi, thank you so much. It's a nice presentation. So I have some question. So did you ever explore the environmental toxicant like arsenic, lead, and cadmium, the role of this environmental toxicant in progression of GVC?
I didn't explore that. Actually, initially, I understand arsenic and these are reported to be a risk factors, but those are actually in the Gangetic belt mostly. And I am working with Odisha population, so our point was about that.
Okay. So and one more thing, the population what you have studied, from which background that they are coming from? Like they are from rural areas or from the urban areas?
Mixed population.
Okay. And because why I am telling you, because in
Yeah,
Oriya
there has
also
been
the food habit, food habit is also very like face, and this the kind of things is very common. And through this food like face and this another things, they are coming like arsenic and lead are coming through that is why I was very much
That
curious.
is coming, but our initially when we started studying, we were thinking that majorly the studies that have been conducted thus far, they report variants or SNPs that have been involved in certain particular populations like Bolivian, Peruvian, even in India, the studies that have been done revolve around Bihar and these regions. So we were thinking that could there be a gene that could be maybe involved in all, like could be a holistic approach instead of a particular population. So that is why we picked up a gene that is very organ specific, and from there we began.
Yeah, thank you so much.
Thank you.
Now we are proceeding to our last speaker, Deepshika Singh. She is a PhD scholar from IIT Gandhinagar. Her talk title is G quadruplex structures in dysregulated long non-coding RNA of ovarian cancer and their binding interactions with human serum albumin.
Good morning, good afternoon, everyone. I'm Deepshika Singh, second year PhD scholar from IIT Gandhinagar. I'm working under Dr. Bhaskar Datta, and the title of my presentation today is G quadruplex structures in dysregulated long non-coding RNA of ovarian cancer and their binding interactions with human serum albumin. So to start with, there are three aspects of this project: ovarian cancer, long non-coding RNA, and G quadruplex structures. So G quadruplex structures are basically structures. They are non-canonical four-stranded structures that are formed in guanine-rich nucleic acid sequences. Four guanine bases come together to form a G tetrad, and these G tetrads stack onto each other to form a two-tier, three-tier, or a four-tier G quadruplex structure. Based on the number of molecules that are involved, they can be bimolecular or a tetramolecular or a unimolecular G quadruplex structure. So, and based on the orientation, they can be parallel, anti-parallel, or a hybrid type of G quadruplex structure. These structures are stabilized by Hooke's hydrogen bonding and monovalent cations. So there has been a few reports of RNA G quadruplex mediated functions in various types of cancers, such as TERA, which helps in maintaining genome stability, LUCAT1, DHX36, MALAT1, NEAT1, and REG1-CP, which are all involved in cancer cell progression and paraspeckle formation in the nucleus. But there are only two reports of G quadruplex structures, RNA G quadruplex structures in ovarian cancers, and that too is with respect to drug resistance. So there has been no report of any other RNA-mediated G quadruplex structures in ovarian cancer. So based on that, I have two objectives. First is the identification of G quadruplex structures in dysregulated long non-coding RNA in ovarian cancer, and to study the binding interactions of these G4-forming LNC RNAs with proteins. So to shortlist the LNC RNAs that are dysregulated in ovarian cancer, we used
So we used LNC2 Cancer 3.0 database, which gives a list of dysregulated LNC RNAs. Then we retrieved those sequences from NCBI database and then fed those sequences to QGRS Mapper and G400 database. And we shortlisted six LNC RNAs. The G tracks are highlighted in blue. Then we synthesized these fragments of the selected LNC RNAs in vitro by using in vitro transcription. After the in vitro transcription, it's not. So after synthesizing the RNA by in vitro transcription in the lab, we did biophysical characterization of those G4 following LNC RNAs. So first we did CD spectroscopy. It tells us about the conformation of the G quadruplex structures. So based on the characteristics of the peak, here we can see that there's a negative peak at 240 nanometer and a positive peak at 265 nanometer, which signifies that all these structures are forming a parallel type of G quadruplex structures. We also studied the effect of ions such as KCl and LICl, and in the CD spectroscopy, no significant effect of ions was seen. Further, we also demonstrated the effect of ligands such as TMPYP4 on the stability of the G4 structures. TMPYP4 is a known G quadruplex destabilizing ligand. However, it stabilizes DNA G quadruplex. So in our study, we found that it had a significant destabilization in 2 of the LNC RNA selected. For the others, it did not have significant destabilizations, suggesting that the quadruplex that is formed is fairly stable. Then we did a THT fluorescence enhancement assay. THT is a molecule, thiofluorine T is a molecule which has inherent fluorescence, but when it interacts with G quadruplex structures, its fluorescence gets enhanced to multiple folds. So in this fold change graph, we can see that in the presence of KCl and LICl, there is multiple fold enhancement of THT molecule. However, the fold enhancement of KCl is higher as compared to LICl, meaning that KCl is somehow making the G quadruplex structures more stable. To validate this assay and to find out the role of each G tract, we carried out deletion mutant assay and competition assay, in which complementary DNA oligonucleotides were used to find out which G tract was absolutely important for the stability of the G quadruplex. And then we also carried out reverse transcriptase stop assay. In this assay, the reverse transcriptase enzyme, when it encounters a secondary structure, such as in this case, a G quadruplex structures, it halts and we get shorter products. So in the gel, we visualize those products. So in the graph, we can see that as the concentration of ions is increasing, the full length template is decreasing and the stop product intensity is increasing, suggesting that both KCl and LICl are showing G4 stabilizing effect. However, the stabilization effect of KCl is higher as compared to LICl. Then we did a dot plot assay in which BG4, a G quadruplex specific antibody, was used to get a clear idea whether these selected LNC RNAs do form G quadruplex structures. Since BG4 is a very specific antibody, we were able to confirm the formation of G quadruplex structures in the presence of ligands also. Ligands TMPYP4, carboxypedase, and BRCA19. The next objective was to study the binding interactions with proteins. Some of the selected LNC RNAs were also found in circulation, and our main goal was to find the interaction of those circulating LNC RNA with human serum albumin. Since human serum albumin is also present in the blood, so there is a higher chance of interaction. So we used ITC, isothermal titration calorimetry, to study the binding interactions. We could find three LNC RNAs that were able to bind to human serum albumin by ITC. So all the delta G values were negative, meaning a spontaneous reaction, and the KD values were in the nanomolar to micromolar range, suggesting a biologically relevant KD value. We also carried out the THT fluorescence enhancement assay in the presence of increasing concentration of human serum albumin. So as the concentration of human serum albumin was increased at a constant concentration of RNA, it was seen that the fold enhancement of THT was gradually decreasing. This suggests that either human serum albumin is actually binding to the G quadruplex structure, or it is just displacing the THT molecule and it is interfering with its fluorescence. To confirm the binding, we carried out an EMSA assay, electrophoretic mobility shift assay. In a normal case, when a nucleic acid and a protein would bind, its molecular weight would increase.
You have 30 seconds left.
Yes, and the bands would migrate slower on the gel. But in this case, we found that the bands were migrating even faster. So this suggests that after the interaction with human serum albumin, the molecularity of the G quadruplex forming RNA was changed. So instead of forming intermolecular G quadruplex, they are now forming intramolecular G quadruplex, which migrate faster on the gel. So to conclude, we were successfully able to demonstrate that all the computational analysis tools that we have used predicted LNC RNAs, which actually do form G quadruplex structures in vitro. And in future, we are planning to develop a sensitive detection technique to detect G quadruplex structures in long non-coding RNA and potentially use them as an early diagnostic marker in blood. These are some of the publications, and I would like to thank Indian Institute of Technology, Gandhinagar, and GCC and Amity University for giving me this opportunity to present my work. And this is lab. I will also thank my lab members and my PI for supporting me. Thank you.
Thank you. So, any question? So, there is no question. So, how do you think that this link RNA, this G quadruplex structure would have some function to, some regulations? So, any speculations or any comments?
So there are four models which is suggested in which these LNC RNA which have G quadruplex structures play a role. So they can act as a scaffold. They can act as a platform for other molecules to interact. So in many cases, you must have heard about the competitive endogenous RNA, where an miRNA binding to some gene is causing the transcription upregulation or downregulation of a downstream gene. So these G quadruplex structures can act as a platform for and mediate those kinds of interaction, and they can also act as a decoy or a in transient mediator for reactions to occur.
Thank you.
Thank you.
So this is bring us to the end of this technical session of the oral talks. I would really like to thank our judges, chairpersons, Dr. Danny Welch, Dr. Jayanta Bhattacharya, and Dr. Shushanta R. Chaudhary. I will request them, sir, that you can proceed for the lunch now. We are really, really thankful for your patience and for evaluation. Thanks a lot.
A very good afternoon to everybody present here. Now we have a very interesting breakout session on IPR and immunotherapeutics with Dr. Meera Sharma, who is in ECS India, works on the strategies for the protection of immunotherapeutics development. The session is chaired by Dr. Pallavi Agarwal, who is a Ramalingaswamy Fellow and works as a professor at Answer Amity University, Noida campus. Ma'am earned her PhD from University of Cologne, Germany, and postdoctoral from the prestigious University of Cambridge. Her research work focuses on epigenetic pathways and novel strategies to combat chemoresistance. Ma'am, it's over to you.
Thank you so much. Thank you. So it's a pleasure to welcome Dr. Meera Sharma. Dr. Meera Sharma is an immunologist, IPR consultant, and co-director of ECS, overseeing IPR and technical consultancies, a registered patent attorney, and scientific advisor with the Indian Patent Office. She mentors startups under India's National Innovation Mission and is listed with WIPO as a patent landscape search report provider. She is affiliated with several universities, including Gujarat Technical University and MS University, and is an IPR committee member of SGCCI Gujarat. A gold medalist and recipient of prestigious awards, she has expertise in intellectual property management enforcement and clinical trial management. She has filed over 100 patents, many of which are commercialized, and has extensive industry experience in diagnostic kit development. With this, I welcome her and we are eager to hear you, ma'am. Please come on the stage. Please give a big round of applause.
Thank you very much, Dr. Agarwal. And since the audience is too less, I was expecting more. This is the lunch time, so not a good time for this kind of session. But still, even if one person would get motivated, I think my coming all over to Amity is justified. So I'll begin with my insights I'm into IPR consultancy since 16 years. So I hope my experience helps you out. Before I start with my presentation, I would like to thank Dr. Hridesh for this excellent scientific treat we are witnessing since 2 days. And the organizing committee, of course, the tireless efforts they have put into the smooth management of the whole conference. Thank you very much, MET organizers of this conference. So now I go with this strategies for the protection of immunotherapeutics developments. Now, this is the brief history. I wonder if you know that immunotherapeutics started in 1891 by Dr. William Coley, and he injected 2 bacteria into a bone tumor patient, bone sarcoma patient, to cure it, and he cured it. The bacteria were Streptococcus pyogenes and Serratia marquescens. And that is why he's called as the father of immunotherapy. But father of cancer immunotherapy is Dr. Stephen A. Rosenberg. He actually used immune cells and cytokines to cure cancer patient, and he remitted the cancer patient oncology, oncopathology, right? So he's called as the father of cancer immunotherapeutics. So I found this thing very interesting, and I thought that the students would not be knowing about it, so might as well tell about this, because everyone is doing very high scientific developments of the latest era, but we must always appreciate the people who started it all. So this is the development which has taken place, how it has gone through various years, how the developments of the various cytokines, monoclonal antibodies, various
cars T cells, how they have been discovered and how they are now being utilized for cancer immunotherapy as cancer immunotherapeutic agents. So this is just a brief outlook till 2015 because the slide was getting very big, so it was not getting covered. And after 2015, of course, all of you have covered in last, many big scientists have covered in last 1.5 day already. So now coming to how to have the legal protection and what are the legal rights, how to commercialize, I feel that any scientific development, unless and until it reaches the masses, it solves the problems, it gives the solutions, it is of no use. I feel so. It is just another paper lying in the sack, right? So now intellectual property rights, which we say, is comprising of all these patents, copyrights, designs, geographical indications, trade secrets, trademarks. Trademarks go for branding of your startup, of your product which you are launching. Design is when you must have seen that during coronavirus epidemic, that diagnostic device was being used. Within 15 minutes, you would get a report, you would get the result. Even for pregnancy test, within few minutes, you can get the result. That is a lateral flow immunoassay, right? So that design of that particular device where you put in the sample and then the 3 lines would come on the NCN. So that is the design patent, design, that's the outlook of it. And copyright is, Dr. Danny Welsh has just gone out. Yesterday I was observing only in his slides, it was written copyright protected. Rest, no one had written that. So it is the moral right of you, whatever you write, whatever teachers make the question is, they have the moral right over it. Moral right goes nowhere. But if anyone steals your idea, steals your write up and makes his own, then it is infringement. And how will you get the benefit out of this infringement? How can you sue it unless until you get the legal right over it? That is, copyright should be registered. So that all literary, dramatic, artistic works, performing arts, all this can be copyrighted. And the beauty of copyright is if you get it registered in India, it is applicable and for your lifetime and for the 60 years after your death, you can get the royalty. Even Amitabh Bachchan is even now getting the royalty over Harivansh Rai Bachchan's poems or the writings which he had published. So this is the beauty of copyright. You don't have to go to 181 other. Coming to patents, which I am going to focus on in this talk, patents are the techno-legal rights. For your technology, you get the legal rights to use it, to sell it, or to do whatever you wish to do. Assign it, or make use of it, or you do not make use of it, it's your choice. But it is intangible rights in your name, and it is more or less a techno-legal document. That patent certificate is more valuable than any of your other certificates. Mind it, this is going to fetch you revenue. It is like investment from FDs and the share holders and the debentures, you will not get as many returns as you will get from the patents. Mind it. Please start thinking in that way. Right? So now, how the thought process of a scientist goes. In this slide, I have focused on that. How the thought process goes in 3 ways. First, I have developed a new process, new product, and I think I should display it in the exhibition or trade fair so that people should appreciate it and people should applaud my work, and I will get the feedback before investing in this product. So what are you doing? You are leaking out your idea to the public, to the masses, and you lose the hold on your idea by that. Another thing is we have developed a new product process and we are going to discuss it with the potential investor. Okay, earlier was open-ended investor, now is a closed-door investor where you are going to discuss it. Now that investor, if he does not invest in your idea, but that idea will go into his head and he will materialize it with somebody else, right? Then third is we have developed a new technical solution. Now we are going to publish a research paper, which is the mindset of all over India. Let us publish first. They all rush to publish it in high impact factor journals. But what is happening? The idea is getting leaked out. So people who will make a product out of it, they will file a patent for it, they will get the legal rights over it, and if you make a product, they will sue you for an infringement of your idea, initially, which was your idea. So, this is a thought process which needs to be changed. How? That is what I'm going to say. So, because if it comes in the public domain, anybody is free to use. You cannot you cannot hold anyone's hands that you cannot use it because it's in the public domain. You've told him just bindas ekdam bata diya. So that is not going to go take you anywhere, right? So it is not recommended at all. Without signing a non-disclosure agreement, please do not discuss your idea or your concept with anyone because you do not know who's going to use your idea in what way tomorrow, and if he files the patent of your idea after you will not he will not get the advantage. But if you file after that fellow, then you will not get the advantage. It's the first to file a patent will get the advantage of getting patent granted. Otherwise, it will not be. So, why should we file a patent application? So, it is for the protection of your invention, for the protection of your creation of mind, for which you have put in a lot of time and money and so much of energy into it, right? So once you file a patent application, the person who are filing the patent application later to your application will not get any protection. This is what I told you just now. Second is, it is advisable for a patent application before any public disclosure. So what all public disclosure? That is any business or commercial discussion related to your invention, publication of paper or research, launching a product service in the market, displaying a product prototype in the exhibition fair. So this is all public disclosure. So if you do a public disclosure, your idea comes into the public domain. So it is no longer patentable. It loses its novelty. And for patentability criteria, there are three things: novelty, inventive step, and industrial application, which needs to be taken care of. Now, coming for the invention, a new product or new process should have an inventive step. It should be non-obvious to a person skilled in art, and it should have some technical advancement and can be used and manufactured in the industry. It is clearly written in Patent Act, in patent law in section 2(1)(j), that please remember for patents for functional aspects, not for the outlook of any product. It is a technical advancement which is going to get protected, right? So now this section 2(1)(ja) is clearly saying that technical advancement as compared to the existing knowledge, then having economic significance or both, and not obvious to a person skilled in art. I guess the cursor is there. So not obvious to the person skilled in the art. That is, you all are skilled in the art because you all are doing science at one point or the other of the time. So you can also think of that thing and you can also make it. So if it is very, very obvious, then it is not a patentable subject. Anyone can do it. So that kind of thing should not be there. It should be like something extraordinarily you have done, out of the box thinking is yours, not which anyone could not have thought about. Maybe even if it is a simple thing like safety pin. Safety pin is the beautiful example of a patented product. Now it is in public domain. That is why everyone is making an $112 billion per year business it is fetching, even now. So this is the beauty of any new invention, new product. Now, basic principles of the patent is it is territorial in nature and making, using, offering for sale, selling or importing for those processes that product in India, this right you get. Then patent rights are limited to 20 years from the date of filing, not from the date of grant. Then various fields, that is electrical, electronics, mechanical, biotechnology, pharmaceutical, for both product and process, you can file the patents. Then this is the process flow, how the patent is first a concept is envisaged, then whether the subject matter is allowable, the prior art search is done, then you establish the novelty, you satisfy the criteria laid down in section 21J, then whether it is inventive and what about its obviousness, and then usefulness, that is why it will be taken up by the industry. Why would an industry like to collaborate its money into your product unless until it sees the usefulness? It is solving some problem of consumers, of people at large. It should be marketable, it should be vendable. So then complete disclosure of the invention is a must in any patent specification, which your IPR cell in charges and Madam Agarwal also knows. Then you file a patent, then you get a patent. Now, this is a brief procedural detail. I'm just going to go through it quickly so that you have some idea. I'm sure you, ma'am, must be teaching you also all this, that you have a concept, then you go for a patentability criteria search, whether novelty, inventive step, or industrial application is met with. Then you go for prior art search, you file a provisional specification to save the priority date. Once your experimental data is complete, then you go for complete specification, and after that you go for publication. In a publication can be, if you go in the routine publication without any extra cost, after 18 months it is automatically going to be published on the website. But since technology is moving very fast, I always advise my clients that go for early publication. It is for very less cost, and for early publication, the moment you apply, within 1 month, your patent application gets published on the Indian Patent Office website. Anyone can see it. So it expedites. Instead of waiting for 18 months, within 1 month, your application is going to be published on the Indian Patent Office website. It is good for your career also, for your resume also. Wherever you go, you can show the interviewers, see, this is the application number and it is published on the website, right? So then request for examination is filed and the first examination report is received. You give a reply to it, a hearing notice comes, there are further objections in the hearing notice, and address all the objections in the hearing and submit the written submissions. That is for the professionals to do mostly. And then in case the controller advises certain amendments, make the amendments, submit it, then the controller will either accept it or reject it. If it is accepted, their patent is granted for 20 years. Then you just have to maintain by giving a very small maintenance fees to the patent office every year for 20 years, right? And then it will be, of course, published in its journal, and worldwide it will be seen and accessed. Then initially, India used to have process patents, but since 2005, amendments were made in the TRIPS regulation agreement by India, and product patents were also introduced.
Dr. Meera, 5 minutes, please. Yeah?
5 minutes?
Yeah,
Oh my
please.
God.
Because many people are waiting for lunch. Sorry.
Okay.
Yeah,
I'll
please.
try
Please be fast. Yeah.
Okay. I'll have to rush through. So, all these patentees, licensees and assignees have right on these patents. So now strategies. What should be the strategies to commercialize? Earn money out of it. It's not just like a scientific, just resume में एक लिख दिया sentence that okay, this is my invention, not like this. So strategic partnerships with the industry, the licensing agreements with the industry, and joint ventures like collaborative projects with the industry will fetch you money. So that should be, that is how it should be, and it will bridge the industry academia gap which is being faced in India as of now. It is a very big gap. So next is risk mitigation and competitive intelligence. That is how to do freedom to operate search, then monitoring the landscape. That is, landscape is which geographical region is having which problem and where you should file it. If a disease is not occurring in US, for example, Kala-Azar is not there in US, and you want to file a patent on a molecule of Leishmania donovani in US, it will not be of any use to you. So that is the landscape search report which should be done before you go for international filing. Then litigation readiness, that you should be sure that you are the first ones, you are not infringing anyone else's patents or technology which is already there in anyone's name. So that will save you a lot of trouble of case suits. Now, problem solution approach, like cycle parking, this is occupying so much of space. If you have a vertical stand, the space will be less. So similarly, sustainable development goals which were discussed by Dr. Gopal Kundu yesterday. This is an example, clear-cut example of a patent granted in India, which is solving a personalized medicine, platform for a personalized medicine, a system for simultaneous cell imaging and growing. Patent number is also written over there. You can check about it. And there, it has already been commercialized also. This is the machine which is, the picture is there, which is showing this microfluidic, 3D microfluidic imaging technique for cancer detection. Then novelty. Now you see, if a potassium is just replacing the sodium, it will not be patented. But in case of drug for control of blood sugar, you see the components are entirely different, so it will be patented. So it should be novel and non-obvious, because non-toxic inventive step is involved in this case, right? Next is, how is scientific article different from patents? It's a techno-legal document, legal requirements are there, formal technical objections are there. Then impossible for inventor to add additional experimental data or information after it is filed in the office. Whereas you can add additional data in your papers, research papers, once the objection comes, right? So I'm quickly going to go through. See, theranostics is the latest trend. It is combining drug delivery and diagnosis, especially for diabetes. There are small patches which are now available. If you just put a patch on your arm, wrist, forearm, it will keep on monitoring your blood sugar levels and keep on injecting insulin side by side. So you don't have to worry about what you eat, what you do, what you sleep, or walk, or do any work, or go anywhere. So this kind of thing is being worked in oncology also, especially in breast cancer and lung cancer. A lot of development has been made. So these are the different stages. I skipped these slides because of the lack of time, because it is just about the theranostics, which I have already told you, diagnostics plus therapeutic modalities, it will give you theranostics. Next is, this is the amount of patents worldwide which have been filed for immunotherapeutics in different areas of cancer immunotherapeutics. And where is India? Nowhere. This is the legal status: active ones, active applied ones, and then inactive, expired, rejected, all that, the stages of those patents, these earlier patents which I told you, they are in these stages. Now, these are the companies which are owning those patents. They are all companies, not individuals, because a lot of funding is involved and funding is provided by the industry. That is why I said go for joint ventures, go for industry partnerships. Recent advances, you all know. I'm not going to touch this topic. Already so much is being said about it. Now, CAR T cells therapy. Again, see, where is India? Nowhere. China, Russia, Korea, Japan, Mexico, and India. This iron last one is actually a foreign filing in India. A US inventor, there are 10 inventors from US who have filed in India. But no Indian in India has filed in this area, unfortunately, though so much of work is being done out here. And this is the legal status of these patents. And then we come to ICI, that is immunocheck inhibitors. Now see again the companies which are owning these patents and the legal status. And this is the distribution. See, the corporates are having the major chunk of it, 68%. And independent inventors, 9%. Research universities, 20%, and collaborators, 3%. Individual collaborators. Oncology is having the 55% of the patents filing in the AI mode. Dr. John Silke, yesterday, he told about AI-based oral cancer detection kit. A patent on, but I asked about the patenting thing. He had not filed it, but he had developed that kit. So if he's making a public disclosure, he should file it, and I suggested that too. I'm not there to advise him. He's a very well-known scientist. How can I? But suggestions are always welcome from anyone. So you see, AI-based technology is there in the cancer diagnosis too, apart from other infectious diseases. So these are the startups in India which are funded by Niti Aayog, and they are actually working very extensively and intensively into AI-based devices, diagnostic devices, or solving problems of the public at large, and they are now running into crores of business too. So here you can see Niramai is actually into early detection of breast cancer.
Dr. Meera, 2 minutes, please. 2 minutes.
I'm winding up. This is, I think, my last slide.
Thank you, thank you.
So, and the platform is Hermalytics has already bought its rights. So this is the beauty of patent. You are all young students who are sitting out here. If any one of you is also, if any single one of you is motivated by my lecture and having certain concepts cleared, I'll be happy that I came over all the way over here and gave this session. That's all. Thank you so much. I hope I made some difference to your existing knowledge.
It was exceptional. I would say patenting is the backbone when we want to commercialize our products or processes. And scientists especially are very much unaware of it. And thank you so much for your presentation. Any questions here?
Thank you so much, ma'am, for the elaborated talk. I got a lot of information regarding the patent. Even I was much aware about it earlier also. So, ma'am, I have some question regarding this. First question is like recently I got two grant, like two design patent has been granted on my name. So I have to pay something for the next 20 years for the design patent.
You have a grant for your research project, right?
Yes, ma'am.
And you have got it patented?
Yes, ma'am. Two design patent we have granted recently.
So, since you have worked on a grant, the legal rights will go to the granting organization. You will have only the moral rights.
But it's in the
And
individual.
for design patents, you do not have to give any maintenance fee. It is for 10 years directly design patent is granted, and after 10 years you can get extension for only 5 years once only. So maximum for 15 years you can get the patent protection for your design registration.
Okay.
But for patents, technological based patents, it is for 20 years, and for them, those patents, every year maintenance fees has to be paid. And for trademarks, for branding of your startup or anything, it can be indefinite period, you can get it registered, but after every 10 years, you have to pay the fees, maintenance fees, renewal fees, it is said.
Ma'am, I am facing one problem. Like, is there any way to get certificate of the design patent through individually without the consent of patent agent? Like, I am having some problem.
पेटेंट एजेंट का तो कोई रोल ही नहीं है बेटा इसमें. पेटेंट एजेंट कैन नॉट स्टेक क्लेम ऑन योर पेटेंट.
No, but I don't have the certificate till now. My patent has been published.
No, but then whoever has filed a patent for you will, it is his moral responsibility to get the certificate for you. If it is filed in your name.
Yes, ma'am, it is my name only. And some another thing, like if in the patent, if the institution are the applicant, so how I will get, being an inventor, how I will get benefited from the utility patent?
Depends upon the IPR policy of your institute.
Okay.
If the IPR policy says that the inventor will get 40% and the institute will get 60%, if it's clearly written out over there. So wherever your patent is commercialized, you will get that 40%.
And ma'am, two more questions. I'm sorry.
I think you can discuss later. Any
Yes,
more questions? You can discuss with Dr. Meera later.
Yeah, I'm available only till tomorrow.
Yeah, so I think it would be better the students can discuss later. She is available and it will be very informative for you. Thank you so much. Please give her a big round of applause.
Thank you so much, Pallavi ma'am, for sparing your time and moderating the session so well. Thank you so much.
Hey, good afternoon, everybody. So, Andreas, if you are listening me, I see that you are online. So, you are the next. So, please join the session. And
yes, I'm here. Can you hear me well?
Yeah. Who is this? Oh, yeah. Hello, hello, Andreas. It's me. Hi. Okay. So. So can we start the session? Yeah. Yeah. Yeah, good afternoon, everyone. So we start with the next session, which is where we have 4 talks. And let me just quickly see. Yeah, it's a translational cancer research, and we have 4 speakers. First is Andreas Wiegert, my own collaborator from Frankfurt, and followed by Rama Khokha, and then followed by another my friend Sergi, and then one more talk. So, Andreas, welcome to this session. Over to you.
Yeah, thanks a lot for this very nice introduction. And I would like to express my gratitude for being able to present our data in this really exciting meeting. What I want to talk about today is how cell death actually affects cancer biology and what we could do at a translational level to interfere with cancer-promoting pathways. And I would like to specifically focus on signals which are produced by apoptotic tumor cells and how these affect the tumor microenvironment. And if you think about this premise, you might think, okay, what we actually have learned so far in the literature is that tumor cells supposedly are resistant towards cell death. So tumor cells usually do not die by apoptosis, and a lot of therapeutic strategies are designed to induce apoptosis in tumor cells. And while this is, of course, true for a large population of tumor cells, this statement, as many of these fundamental statements, is actually false. And you can see this by looking at the tissues where apoptosis has actually been discovered. And this was discovered in tumors already in the 1970s. And the reason for that is that tumor cells rapidly proliferate. And when you have large amounts of proliferation, always cells will die by apoptosis. And this also happens in tumors, not all tumor cells, but many. And actually, you can only see apoptotic cells in tissues where you have massive amounts of apoptosis, which actually surpasses the capacity of macrophages to phagocytose these cells. And you see this in tumors. So you have a lot of apoptosis going on in tumors as demonstrated here. So normally apoptotic cells are recognized by macrophages. In tumors, they are also recognized by tumor cells themselves. And they produce specific signals, which usually tell the immune system to shut down immune responses because we have overshooting tissue damage. And we believe that tumor cells actually hijack these signals to promote their growth. And that's what a lot of the research in my laboratory is about. And we can see that apoptosis plays a role in tumor biology by looking at apoptosis indices. And an apoptosis index often correlates with malignancy or metastasis and positively correlates with malignancy, which means if you have a large amount of apoptosis in tumors, you will have a poor prognosis for the patients. So that's kind of a dogma we have to kind of shift around to understand the following slides. So usually in my lab, we look a lot at the signals that apoptotic cells produce. In the following project I want to show you, we actually tried not to do that, but ended up anyways at this kind of point. So what we started out with this project was to look at the tumor lipidome and to see how the lipidome in tumors changes from the normal tissue with the goal to find novel antigens on a lipid basis. So there are specific T cells, for example, that can recognize lipids as antigens, and we wanted to see if this is something that actually happens in tumors. What we did here, we extracted lipids from the mammary gland of mice and of mice which harbor transgenic-induced mammary tumors. And this is the polyomymality oncoprotein model, which I will come back to later on. We extracted the lipids and we screened for lipid antigens. And what we found was indeed a change in the lipidome of tumors compared to the normal mammary gland, but this change was not really a lot. So not many lipid species were changed. When we looked at these lipids more in detail, so this is the heat map in the tumor and the mammary gland, we found that particularly phosphatidylserine, which is a phospholipid with a serine head group, was changed in the tumors compared to the mammary gland. And not only phosphatidylserine was changed, but this was a specific species of phospholipids, which you see here indicated by the O's and by the P's. And these lipids are special in a way that the fatty acids are not coupled to the glycerol by ester bonds, which is usually the case, but by ether bonds. So this gives a slightly different structure. We have these ether lipids in many, many tissues, but we really do not understand their function. And it was exciting to see that these are actually overrepresented in these tumors. To first understand if these changes are anyhow meaningful, we looked first at human databases. First verification by mass spectrometry. We found by mass spectrometry that indeed ether lipids in general are increased in tumors compared to the mammary gland, here in black, and that specifically phosphatidylserine was really strongly induced in the tumor and the mammary gland. And this on a quantitative level, this was only qualitative. And we actually went a long way to produce one of these phosphatidylserine ether lipids, this one here, the easiest one. This is a lysophospholipid. And we use this as a standard in mass spectrometry to actually show that these lipids are indeed enriched in our tumors. indicating that we have indeed increased ether phosphatidylserine lipids in mammary carcinoma. Now coming back to what I wanted to say, is this anyhow meaningful? Now we see changes, but does this make any difference to patients, for example? So we looked into patient data. What you need to know beforehand is that phosphatidylserine as a phospholipid is in humans produced by exchanging the head group of existing phospholipids, phosphatidylcholine, phosphatidylenolamine, to serine. And this is done by two enzymes, phosphatidylserine synthase 1 and 2, with slightly different substrate specificities, and I'll come back to that later on. So what we did is we looked at the expression of these enzymes in databases of mammary carcinoma patients. And what you can clearly see, focusing on these enzymes up here, is that phosphatidylserine synthase is actually correlated with a poor prognosis in many breast cancer patients. So a large data set of 2,000 breast cancer patients was screened here. To verify this at the protein level, we went to tissue microarrays, and we stained these tissue microarrays with antibodies for phosphatidylserine synthase 1 and markers for tumor cells and a couple of immune cells. I'll come back to that as well. And we found indeed groups of tumors which had high expression of this synthase 1 here, these are orange, and some which had low expression of this enzyme. And if we stratify these tumors into low and high, we could show that a high expression of this enzyme actually leads to poor prognosis for these patients. And you can look at databases of many different tumor entities, you will find the same pattern, with a notable exception which is colorectal carcinoma. Now, this is only correlation. This is, of course, not causation. So to see if this really is functionally relevant for tumor growth, we went back into the mice. So we used these cells from the transgenic tumors, which we characterized the lipids in at the first place, and we knocked down this enzyme here. We injected the tumor cells into the mice, the mammary gland, and looked at tumor development. And we saw some interesting pattern, at least for us, this was very interesting. We saw the control tumors actually grew continuously. The knockdown tumors actually also started to grow, but were then stalled or even rejected after 3 weeks, which for us indicated that the immune system was evolved. And this protection was long-lasting, as no animals actually died or had to be sacrificed due to ethical endpoints after 10 weeks, which in this tumor model, in a graft model, is actually really a long time. So there was tumor control going on. Now, if you look at such a pattern, you would think the immune system, so particularly the adaptive immune system, would be involved in rejecting these tumors or stalling tumor growth. And I want to cut this very short. We went a long way and we kind of neutralized all kinds of adaptive immune cells in these models, natural killer cells, T cell subsets, specifically this subset which can recognize lipid antigens, but nothing actually happened. So we went deeper into the tumors by polyspectral flow cytometry, and we saw one really interesting pattern, at least for us. And this was that when we knocked down the phosphatidylserine synthase 1, we actually had reduced infiltration of macrophages in these tumors. And this was also true in the human tissue microarrays, where we actually stained for macrophages together with the phosphatidylserine synthase 1. When we had much of this enzyme, we always had higher macrophage infiltration here in blue. When we had low expression, there were few macrophages. This was true for all kinds of molecular subtypes of breast cancer, particularly triple negative breast cancer here. So there is a correlation between this enzyme and macrophages, both in murine and in human tumors. So how can we understand the impact of these enzymes on macrophages? And now I'm coming back to the apoptotic cells, which we didn't want to go to in this project, but we ended up there anyways. So what we propose is that phosphatidylserine synthase produces phosphatidylserine. During apoptosis, this lipid, which is normally confined to the inner leaflet of the plasma membrane, is externalized, and macrophages have receptors to recognize this. And once they recognize this, they know that the cell has died. And then they will take up the cell and digest it. But not only will they do that, they will also be limited in their capacity to produce pro-inflammatory cytokines, which is good for a tumor. And they do other things, improving tumor cell survival and all kinds of things. So we wanted to know if this is really actually changed, this interaction, when we knock down this enzyme, because we saw a reduction in phosphatidylserine when we knocked it down. I didn't show you the data, but this was very clear. But we wondered if this really anyhow reflects on this externalization And the result was surprising, at least for me. When we kill tumor cells with staurosporin in this case and look at externalized phosphatidylserine, you can do this by annexin 5, which can bind to this externalized phosphatidylserine. Over time, we see that the cells are dying, so they externalize phosphatidylserine. If we knock down the phosphatidylserine synthase 1, this is largely reduced. And this was somehow related to the ether phosphatidylserine, and we don't really understand the mechanism behind this. So this result was surprising for us. Now, is this functionally relevant? Does this change the macrophage phenotype? For that, we looked at cytokine production by the macrophages, specifically TNF-alpha. So the macrophages produce a certain level of TNF-alpha, and if we just give them the supernatants of the dying cells, which have vesicles with phosphatidylserine, which is recognized, then we suppress TNF-alpha. This is expected. But if we knock down the phosphatidylserine synthase 1, we have less exposed phosphatidylserine. This suppression doesn't happen. If we pre-incubate these supernatants with recombinant ether phosphatidylserine, we rescue this kind of suppression. So indicating that indeed the externalization or the presence of phosphatidylserine is necessary for reprogramming the macrophages. Now, I showed you here that macrophages have specific receptors for these lipids here. So which receptor was involved in our model? So the highest expression which we found in our macrophages of these potential receptors, there are many, so redundancy in the system, was a receptor called MERTK, which is a tyrosine kinase. So was this involved? Indeed, we checked in the same assay. We had macrophages, we gave them supernatants of dying cells. This suppresses TNF-alpha, but this doesn't happen if we block the MERTK, this tyrosine kinase, with an inhibitor. If we have the knockdown of phosphatidylserine in this one, really nothing happens, and this inhibitor doesn't change anything because the interaction is already disrupted. Now, was this relevant also in vivo? We checked this by doing kind of a comparison between different groups. So this is the experiment I showed you before, wild-type mice injected with control tumor cells and cells lacking the enzyme. So when tumor cells die, they have less phosphatidylserine. We did this also in mice which actually selectively lacked MERTK in macrophages. So this is a genetic model. We injected control tumor cells and PDDSS1 knockdown cells. And what you can appreciate here, I think, is that tumors in the control situation, all control, they grow. If we have knockdown of phosphatidylserine synthase 1, we again get this stalling of tumor growth. And the same is true if we block this receptor selectively on macrophages in the tumors, indicating that this interaction really plays a role. And not only this was seen, but also that we have lower infiltration of macrophages in these tumors very clearly. Now, we also did transcriptomics, and again, we saw an overlapping profile of tumors where phosphatidylserine was knocked down in the tumor cells and where MERTK was actually knocked out in the macrophages. And all of these transcriptomic profiles pointed to increased proliferation of macrophages in situ triggered by this interaction. And this really corresponds to the low macrophage numbers in these tumors. So what's the mechanism behind tumor growth? We didn't see any dramatic changes in macrophage phenotypes by multispectral immunohistochemistry. Just not going into detail, but what we saw was that the tumor cells were lower proliferating, which you can see here in the graph. So when we knock down the serine synthase in the tumor cells or the receptor in the macrophages, we have low tumor cell proliferation. And this was really the mechanism behind reduced tumor growth. So now, speaking of translation, could we use this enzyme to actually do something against tumors? So could we inhibit it? Interestingly enough, there were no inhibitors on the market when we did our study. So we went to a colleague in Rostock, and this guy is a bioinformatician known for creating public libraries like this one. He modeled the enzyme into a membrane, looked at the active site, and screened a couple of FDA-approved drugs through this active site. And we found a couple of interesting molecules which were already validated in the clinic, among them chemotherapeutic drugs, which might have been inhibitors for this enzyme. And looking at phosphatidylserine levels by mass spectrometry, we found that indeed some of these inhibitors, for example, epirubicin, lowered the phosphatidylserine concentration, very similar to knocking down the enzyme at a similar level as in the mice. Now, we wanted to have selectivity for different isoforms, and here you can see that this enzyme accepts phosphatidylcholine as a substrate, while this does not. So if we have a good inhibitor of this enzyme, we should see a shifting rate between the precursors and the product when we block the enzyme. And this was, for example, for epirubicin really true. So we get a shift from phosphatidylcholine to phosphatidylserine indicated here, but not ethanolamine because this enzyme is still present. So this was a selective inhibitor. Now, interestingly enough, epirubicin is an epimer of doxorubicin, which is a common chemotherapeutic drug. So it's different just by a hydroxyl group sticking out the other way. So it's very similar, but this enzyme actually does not inhibit the PDD-SS1. We had used this chemotherapeutic drug before in a mouse model where we looked at synergism between chemotherapy and immune checkpoint blockade, and this was effective. So the question was, if we at the same time inhibit the PDD-SS1, would this be superior? Interestingly, while we were thinking about this, a company from Japan actually found very similar data to our stuff. So they found that this enzyme is important in cancer, and they actually invented inhibitors. So we were wondering, can we use our inhibitor or their inhibitors to really target tumor-associated macrophages? And this is basically my last slide. This is where we stand at the moment, so all unpublished. We use tumor organoids, which you can see here in structure. So they really resemble a mammary gland, these organoids, and we infiltrated them with monocytes, treated them with doxorubicin, which does not inhibit PDD-SS1, epirubicin, which does and induces cell death, and this inhibitor only inhibits PDD-SS1 but does not induce cell death. When we look at the growth of the organoids in the co-culture with the monocytes, we see that epirubicin is far superior than the other drugs. And you can see this even better if you compare the organoids alone with the co-culture. So here, the organoids alone shrink if you give chemotherapy, which is not surprising. The inhibitor does nothing because it just inhibits this enzyme. If we add macrophages to these co-cultures, the tumors grow better. Macrophages always support tumor growth if they're converted. This is also true if you do give chemotherapy with doxorubicin, but it's not true if you give epirubicin, which blocks the interaction of dying tumor cells and macrophages. And again, macrophages were lowered in this case. So this is where we stand with the project. Brief summary. We know that mammary tumors have increased levels of ether phosphatidylserine. We know that the enzyme which produces these is linked to patient survival. If we knock it down, we have stunted mammary growth and tumor growth in tumors. And this is probably true via interfering with macrophage proliferation. So really the remaining question, we are really tackling this at the moment, is can we target this enzyme to restrict tumor-promoting immune responses, particularly in macrophages? And I would like to stop by acknowledging the team. These are the people who did most of the work in the project. Ivan is still working on the project. These are our funders, collaborators. And I would really like to thank you again for inviting me to this meeting. I hope we still have time, 2-3 minutes for questions. I'm very open for questions. Thanks a lot.
Yeah, it's thanks, Andreas. Good to see you here. Good to see you here. This is HP. Yeah, so we were together. So I would like to introduce Dr. Andreas as my collaborator on our Indo-German bilateral grants on the sphingolipid. So I'm very happy to see this talk, which is going in line of our discussion on TEM polarization. So we have a scope for 2 questions. Yeah. Anybody? And maybe
I would like to ask, if possible, Rama here.
Yeah.
Yes.
Rama, yeah.
So Andreas, very nice talk. I'm also online. So in your organoids, you can actually introduce macrophages in the mammary organoids?
Yes, we can do that. So we do not introduce macrophages, but we introduce monocytes. And these monocytes locally differentiate to macrophages, which is, I think, a process we need so that we have the tumor-associated macrophage phenotype really in the organoids.
And have you had the opportunity to look for that same lipids in the microarrays that have a variety of breast cancer subtypes? You know, hormone receptor positive versus triple negative, and do you see any specific patterns? Because it's very interesting what you have here.
Yeah, so that's a really important point. We have not done this yet. What we're doing at the moment, we are collecting tumor organoids from patients, and we are looking into these organoids actually for lipid profiles because we want to have this kind of sustained in a tumor cell intrinsic fashion. So that's not done yet, but we are on the way to actually doing this. But that's a really important point to really see that this happens also in humans, not only in the mice where we studied it. Yeah. So the enzyme expression is very similar, this PDD-SS1, but we have not looked at the lipid yet. Important, yeah.
Thank you. Yeah.
Thank you.
So, if there's no other question, then I have a question to you, Andreas. So, when you blocked up the phosphatidylserine clipping, it should, in principle, actually affect the phagocytic index of the macrophages, right, which are in the tumor microenvironment.
Yes.
So, if you block the phosphatidylserine, so I think that this will probably impact. So, how it's going? Is it also engaging the affecting the CD206 and 163? Recycling on the surface of the macrophages, affecting their tumor killing ability.
Yeah, it's a very important point you raise. We have, of course, checked this if the uptake of the tumor cells is changed. And the interesting part is it's actually not. So there are other eat-me signals besides phosphatidylserine, which are apparently enough to get the cells ingested. And this profile, which you get downstream of the MERTK receptor, which is important here, is very specific. So it's very much limited to suppression of selected cytokines. So CD206 and 163 were not affected, but TNF-alpha was suppressed. A couple of other chemokines were suppressed. And the main important point is what we really changed was the proliferation of macrophages. So usually in the field, there was long time a consensus that macrophages do not proliferate, but they do under certain conditions. And what we tackle here specifically via this MERTK pathway, and that's very selective, is this expansion of macrophages. And if we block this, the tumors do not get critical growth signals from the environment.
So it means, if you use this inhibitor along with the clodronate, I think that can sensitize the chemotherapy. That can sensitize the impact of chemotherapy on patient.
That could be
my understanding.
Thank you.
Okay, so thank you, Andreas, once again. See you soon in couple of months again. Yeah.
Yeah. See you.
So thank you. Yeah. So now let me introduce the next speaker. She is Rama Koka from Canada. So she will be talking about the deconvoluting cancer precursor for pancreatic or primary cancer prevention. Oh, I'm sorry, Rama. I think we decided that you talk on the pancreatic cancer, right?
Right. I'm trying to see if I can share my screen.
Yeah, you are permitted to talk
Okay.
on
Okay.
PDAC. Yeah.
Oh, okay.
So
Okay.
let me introduce you for a minute. Yeah, so
Okay.
Dr. Rama Koka is a senior scientist and professor in Department of Medical Biophysics in Canada, and she received her MSc from Delhi University, PhD from Western University, and she was awarded Humboldt Fellowship for doing postdoctoral training at EMBL. So you are my senior from EMBL.
Yes.
Okay, good. So she began her independent program at London Regional Cancer Center. Then she moved to the Princess Margaret Cancer Center, and then was vice chair of biology of MBP and interim director of PMCC. So the list is pretty long. So to cut the time into the short, I would like to invite my senior of EMBL. Now I can call you to deliver a talk. So the floor is all yours. Over to you.
It seems that I'm having, let me see, Zoom. It's not allowing me to share my screen, and I don't know why. It displays, it's taking me to Zoom. Okay. Okay, let me see. Okay. Sorry, I'm still looking at this.
It seems you have permission. You have a green signal to go.
Yes, yeah. I certainly, but you don't see my Zoom, right? You don't see my PowerPoint, do you?
Well, we see you.
Yeah, you see, but it seems that at my end here, it does not want to application. PowerPoint. Okay, share. What systems? Setting. I don't know. My own computer doesn't want me to share this for some reason now. I am very sorry.
Maybe you go to the share.
Usually, yeah. Usually it goes like that. You share screen, and it's not allowing. It's not showing. This computer is not allowing me to share the screen. Okay, so let me try one more time. Sharing PowerPoint. Open. Allows them to share. Open. Okay.
Maybe you need to exit and rejoin. That's a possibility.
I can try that, but it seems to be a problem at my end, actually. So you know what? Do you mind if I just actually talk without the slides?
Yeah,
You know, I can just. So let's go back to Zoom here.
Because you are already awake till 3 o'clock in the morning. So
No, that's not. Yes. So good afternoon, everyone. I am really sorry that I'm not able to share my actual visual slides, but maybe I can just tell you about some of the work we're doing.
Rama, can you send your PPT to me or via email? Then I will put it out forward.
Okay, that's a good idea. Here, let me see. I'm going to, okay, close this. I'm going to send this reply. I will attach the file. Browse this computer. Save. Go back to here.
So Rama, if you
Yes.
Yeah, you are. Yeah, have you sent
I
it?
am. Yes, I'm no. I'm sending it now. Documents. Notes. Notes.
Are you done?
No, it's not done yet. Sorry. That's
Rama,
Yes.
can we like do following that we have a next speaker here? So
Yes, please. But I've already cut into their time. Yes, I think that's a great idea.
Yeah, sure.
Yes.
Okay,
I'll
thank
send
you.
it to you in the meantime. Yes.
So, excuse me for this, Rama, for the technical glitch. Okay, now it's my turn to introduce you all again. One of my friend, Dr. Sergey. Sergey, my friend, over to you. So he's my long, how should I say, old friend from Max Planck. We were together in the same building, but on opposite flanking region. He was in the DRFZ and I was in the Max Planck Institute. And he was dealing a lot with the rheumatoid arthritis, talking about the TNF. So he comes from Russia. He begins his academic career with a PhD in molecular biology at the Institute of Molecular Biology, USSR Academy of Science, Moscow. Then he became professor and head of the Laboratory of Molecular Immunology at Engelhardt Institute of Molecular Biology, Moscow. Since then, he has he has accolades several laurels, and the list is very long. He is one of the recipient of Helmont's Helmholtz Award. Dr. Sergey has directed the oncoimmunology program at Molecular Immunology Graduate Program at Moscow, and many more. So, to cut the time short, Sergey, over to you.
Okay, thank you very much for introduction. So I would like to start with, of course, many thanks to organizers for inviting me here. This is my first visit to India. I should add that, when I was in kindergarten and in a school, in early classes of school, basically we were really best friends with India. So I was raised under the slogan, believe me or not, Hindi Rusi Bhai Bhai. So whatever this means now for those who are not from here. And so, of course, I remember very well, visits, they were televised, visits by Jawaharlal Nehru, remember Jawaharlal Nehru, Indira Gandhi, and so forth. So really, and also historically, I mean, in Russian classical literature, and especially in music, there are many, many things which are related to India. So India, of course, is kind of, mysterious country for us, but so I'm happy that I finally made it. So also I would like to remind you that Russia is a member of BRICS, you know. It's very important. So it's we have now saying in Russia that it's better to be in BRICS than in NATO. So what I'm going to present is a short, very short story, unpublished story. So I know we just had lecture on patents, which means that we cannot patent this already because I'm going to present it. And this was done by very talented young scientist, Katya Gubernatorova in my lab in Moscow. And this, as you will see, it links pro-inflammatory cytokine interleukin 6, gram-negative anaerobic bacteria Akkermansia with intestinal cancer, with colon cancer. So this reminds you what is known about IL-6 in relations to cancer. Probably I need glasses to see it myself. That it's involved in, when produced by stromal cells, involved in epithelial cell proliferation, involved in induction of epithelial mesenchymal transition. More recently, it was discovered that it's also involved in metabolic reprogramming. And as we also see in my talk, it is involved in recruitment of myeloid cells, in particular of suppressor cells. So it is known from many studies that microbiota is an important factor in the development of intestinal tumors. And this shows you just examples how microbiota can interact with the immune system without penetration through epithelial cells, then with really penetration under epithelial barrier, and also interactions with various immune cells, which would lead to tumor development. So 15 years ago, my former PhD student who worked at that time at Michael Karin's lab in USD, he published study which showed that in this azoxymethan DSS model, this is a kind of root model of cancer in mice, which you can generate in many mouse strains. This is not genetic model. In this case, interestingly, interleukin 6 knockout mice, although they showed higher severity score in colitis, which is of course also related to this DSS treatment. Of course, it was done in a separate experiment. Nevertheless, they had lower tumor load. So conclusion was that IL-6 is pro-tumorigenic in this model. So more recently, actually a couple of years ago, the people in my lab, actually Katya and her student, they noticed that when they co-house mice in the same cage, and you know that because of coprophagy, mice can exchange with microbiota. So if you co-house wild-type mice with IL-6 knockouts, and then perform this experiment with azoxymethan DSS tumorigenesis, then mice which were wild-type mice which were co-housed, they will now develop much less tumors, suggesting that something transferred from IL-6 knockout mice helped wild-type mice now to resist the tumor development, and obviously somehow through microbiota. And interestingly, this co-housing had some effects on immune status without regard to really induction of cancer. So, for example, mice which received microbiota from IL-6 knockouts, wild-type mice receiving microbiota from IL-6 knockout through co-housing, as you may see, they have much less IL-6. They have both in serum and in intestine, and also they have, and also at the level of transcription, and also this transcriptomics shows that actually quite a few genes, including genes encoding pro-inflammatory cytokines, they also were involved. So then we asked, what type of bacteria may do this? And this was done through 16 rRNA sequencing. And what we found that the highest score is for bacteria called Akkermansia muciniphylla. And these mice are significant, these bacteria are significantly increased in wild-type mice after co-housing. This then suggested that we should work with Akkermansia. You know that Russia has big collections of various bugs, but surprisingly there was no Akkermansia, so we had to get those bugs from some non-friendly countries. And this shows you some data about Akkermansia. So it is known from literature that it involved in strengthening dense contacts between epitheliocytes. Actually, through its mucin-eating properties, it accelerates the process of mucus renewal. It also activates IgA production, and there were reports that it attracts, helps to attract NK cells. And so I'm sure that you know that this bacteria is approved as probiotic for many metabolic diseases, including obesity. And actually, there were some suggestions in literature without much experimental data that this may relate also to protection from tumors. So once we got this culture, microbiology, this is an anaerobic bacteria, so we could not really grow them ourselves. So our microbiologist from Moscow University helped us. So we were able to perform experiments where Akkermansia was introduced into mice. And in this case, we used genetic model of cancer. This is famous APC mean mice, which would spontaneously develop colorectal tumors. So I have to tell you that we have at the institute we have very clean facility, really super clean. So the induction of tumors in this genetic model in our facility is very slow. So we have actually to do a trick. We have also to induce stage of DSS treatment. Then mice develop tumors reproducibly, but faster, because otherwise it's very long experiment. You say it's 50 days. And so what we found that, and we applied two versions of bacteria, either live or heat inactivated, pasteurized. And so interestingly that both heat inactivated and especially live bacteria, they have a very significant effect on tumor growth in these mice. So number of tumors was going down, especially with live Akkermansia, and tumor diameter was also smaller. Then we also, because of this role of IL-6, and yes, and did I say already that, I did not say this, but I will say it on the next slide, that production of IL-6 went down with, here it is. Production of IL-6 went down when either dead or live bacteria were introduced into APC mice. And also we recorded that numbers of CD11B positive cells were significantly lower after Akkermansia, so consistent with a role in recruitment of myeloid cells. So then the question is, what is this? How Akkermansia may do this? So now this is a popular concept, what is called trained immunity. So we hypothesize that somehow Akkermansia trains myeloid cells to produce, probably to change the transcriptome, but more importantly, to produce less IL-6. And for this, we did the following experiment. So we administered pasteurized or viable bacteria to mice, then isolated bone marrow from these mice, and studied properties of this bone marrow-derived macrophages in culture. And what we noted that the reaction was to fecal microbiota. What we noticed that in this case, dead and live Akkermansia were able to significantly lower IL-6 production. If we administer pasteurized E. coli as a kind of control for gram-negative bacteria, then there was no effect, suggesting that this is really effect specific for Akkermansia, at least within limits of our study. So then we did bone marrow chimeras. So we administered Akkermansia to various mice, and then isolated bone marrow and transferred it to irradiated recipients. So now, if there is a kind of memory, it will go with transferred bone marrow with transferred cells. So, and from these mice again, we can prepare bone marrow-derived macrophages. And it turns out that in this chimeras, this phenomena holds true. So the bone marrow-derived macrophages prepared from chimeras, they would produce less IL-6, as shown here. Then we have an additional model to address this problem, because we generated some years ago IL-6 knockout mice, conditional IL-6 knockout mice in various compartments. So we have mice with deletion of IL-6 gene in myeloid cells. So this is, again, this is genetic model, but it's not genetic model of spontaneous cancer development. So in this case, again, we have to use this our DSS protocol, and it's clear from this slide that both IL-6 knockout mice and also knockout which is restricted only to myeloid cells, they have significant protection. And so if you look at tumor numbers, myeloid cell specific IL-6 knockout is even stronger than, effect is even stronger than complete IL-6 knockout. We also did, as it says here, additional bone marrow transfers from IL-6 knockout and myeloid cell restricted knockout into irradiated recipients of this genetic model, and also observed reduced tumor burden. So I think we, for this relatively short story, we are coming to conclusion. So the conclusion is that Akkermansia reduces the number of tumors by controlling IL-6 production by myeloid cells, and this was observed initially by transfer of microbiota from IL-6 knockout mice in co-housing experiments. Then we detected the potential reason for this difference was due to Akkermansia, and then we, by these experiments, direct administration, we proved that indeed Akkermansia could be that some other bacteria were also involved, but Akkermansia by itself is able to provide protection from tumors. On this, I think I should close. And this is my last slide. I just want to acknowledge my lab in Moscow. So Katya is here. But you see that we have more people, and thus we have also more projects. I only presented one project to you. So I work on Akkermansia was very much dependent on collaboration with Andrei Kruglov, who is at Moscow University, but also he is at the same time at this cancer rheumatology center in Berlin, where I used to work before. Oleg Demidov, who provided us with APC mean mice, and Olga Podosokorskaya, it's difficult even for me, who actually were able to grow Akkermansia for these experiments, and our funding is coming from Russian Science Foundation. Thank you very much.
Yeah. Yeah, thank you, Sergey. Yeah, now in time. Yeah, thanks. So now we have a scope for a couple of questions from the audience. Yeah. Yeah, sure.
Sergi is a wonderful finding. You deserve to get the patent, but anyway. So my question is about whether the Akkermansia across the globe, like in different human populations, the species is exist, and then what level of Akkermansia present in the colons of the different human populations?
I have to admit, I am not able to answer these questions. I know since I can only speculate that since this was sort of recommended by FDA as probiotic, I'm sure there is a statistic somewhere what happens with, people who are on Akkermansia. And maybe there are some already statistically significant observations, maybe also regarding cancer, but I'm not, So the idea was that Katya will come herself to present. But since nobody in my lab ever visited India, decision was that I go first on sort of reconnaissance trip. And if I return safely, then next time, some of these nice people will come. And they are more competent in Akkermansia, I can tell you. I selected this topic simply because I was told this is cancer meeting where I'm mostly working on other things, on immune regulation, not cancer related. And this was a topic which actually also relates to subject of the session, translational medicine or whatever. So translates, right, potentially.
So from your screening, there are still many other bacteria was also there. So what was the reason to choose only this Akkermansia? You also found several other bacteria in the screening
list. This was a logarithmic scale. So this was really, Akkermansia was standing out, very significantly. But you are right. I mean, we cannot exclude that there are also other bacteria, but we made a clean experiment.
Yeah,
clean
because
culture, almost like Robert Koch, clean culture, injected, observed effect. And then, of course, we also, when we injected live bacteria, we also were able to detect Akkermansia back, So
yeah, maybe
not full Koch postulates are satisfied, but at least.
Yeah, that facts. That's what I'm thinking too.
Yeah. So any other question? So if not, my friend, I'll ask one question. So you have generated the IL-6 knockout with on the LSM-3 background. So what is the immunogenic responses? How the immune responses are guarding in these mice? So is it more immunogenic, and how the endothelium is behaving in these LSM-3?
Complete knockout or
Yeah,
restricted knockout?
LSM-3, conditional LSM-3. IL-6 knockout on the myeloid, the LSM-3.
Okay.
So how the phenotype? Is it
Well,
palpable?
they are still studying. So actually, some of these nice people, actually in the first row, they are studying these mice. We have one publication related to allergy asthma model, where we have distinct phenotype with mice, distinct from similar mice with deletion in dendritic cells. Mice with deletion in all myeloid cells, they show distinct phenotype. So this is published. But other than that, immediately I cannot. They're normal. So of course, in clean animal house, they have everything, tail, ear, everything is there.
Okay, fine. So I think we close the session or the talk. So Rama, once again, I'm bringing you back. I hope we have received your PPT, so you can be
Yes.
on now. Yeah, we can resume the session.
So just 1 minute.
Yeah,
I would like Dr. Prakash to felicitate our eminent speaker, Dr. Sarkesh.
Sergi, one more time, please. A lot of walking out. Okay, now over to Rama. Please resume. I think I've already introduced Rama previously, so now I'll not take much of time. Just go ahead, Rama. Over to you.
Thank you very much. Thank you very much, first of all, for this opportunity to connect virtually from Toronto. I see the very beautiful venue, and I really wish I was there in person. So today I want to speak about our work on pancreatic cancer because I think this thematically aligns well with the this Global Cancer Consortium meeting. Okay, we go here. So my lab at Princess Margaret studies tissue homeostasis. We are interested in looking at adult tissue stem cells. These quiescent and multipotent cells work to rejuvenate the tissues, right? And the stem cells also sit within stem cell niches. And we know the stem cell niches are these privileged spaces where you have supporting cells with precise chemical and physical entities. Now, during cancer development, stem and progenitor cells are thought to, they are thought to be the cell of origin for cancers or the precursors for the cancers. But at the same time, the niche also becomes co-opted to become and facilitate tumor microenvironment. We know that the tumor microenvironment is complex, where cancer-associated fibroblasts play a very central role in promoting growth, suppressing immunity, and facilitating vasculature and ECM depositions. So today I want to cover in my talk a few things. I want to show our efforts about deconvoluting the complex pancreatic cancer tumor microenvironment. I also want to show you about Hourglass, which is a computational tool we have developed to rapidly analyze multiparametric data. I want to tell you a little bit about the PDAC tumor subtype specific biomarkers that we are working on, and also using protein-protein interaction networks as an interrogative tool to identify critical hubs in pancreatic cancer. So beginning with, if you look, a good example of a heterogeneous tumor ecosystem is the pancreatic ductal adenocarcinomas. PDACs are highly aggressive tumors that are mostly treatment resistant, and they are really characterized by substantial amount of the tumor microenvironment, or the TME. So Barbara Grunwald in my lab worked to understand the TME. She wanted to know the concrete functions of the TME and the clinical consequences related to them. So she worked very closely with our clinical pathologist, Dr. Sandra Fisher, and we began to notice that within the tumor microhistology slides of pancreatic cancer, there were recurring morphological themes. So she identified three kind of patterning within these histology slides, and we went to analyze this deeply. So I want to tell you a little bit about the strengths and the workflow of our study. So we had very good pancreatic cancer tissue resource, which had good linked patient outcomes. This tissue represented the early and the late stage. They were all treatment naive tissues. And we also had an accompanying tissue microarray of more than 600 pancreatic cores. The second strength of the study was that we applied multimodal omics, where we generated patient-matched. Let me just activate this one. Spotlight. No, deny. Okay. Where we generated matched laser capture microdissected proteomics and transcriptomics data. We also had from our colleagues availability of the whole genome sequencing on these patients. We performed over 45 to 60 immunohistochemistry stains. And then the other strength of the this study was that we had 3D models, which are the patient-derived organoid models for pancreatic cancer that we had available to us from our living biobank core. And we generated primary CARF, the cancer-associated fibroblast cultures from these patients' material to have, then we could do functional studies. And we found that in pancreatic cancer, there were two fundamental tissue states in the sub-tumor microenvironment. We call them sub-TMEs. And these sub-TMEs could coexist. So when patients had both type of sub-TMEs, those patients had poorer outcome compared to those patients that had only one kind of tumor microenvironment. So here is the study. We started with the laser capture microdissection, where we extracted the tumor microenvironment and the inhabiting tumor cells that are residing in this tissue, and performed proteomics and transcriptomics. We were surprised to see that the proteomes of the tumor microenvironments showed very large differences. More than 50% of the proteins were differentially expressed. So this was surprising, and the similar kind of differences were also reflected in the transcriptomes. We looked at the candidates within these that constituted these TMEs, and then went on to systematically validate them by immunohistochemistry. Here are some of the stainings shown. We stained for collagen, smooth muscle actin, various parameters of immune cells, and quantified this through digital pathology using QPath. So you can see the abundance of these entities in the two microenvironments, and also within the heat maps, you begin to notice that one of the, so we call the sub-TME deserted sub-TME or reactive sub-TME. In the reactive, you see this huge cluster of immune cell cluster, which is indicative of the cellular immunity in the pancreatic tissues. So within this reactive TME, we saw good examples of immune hot regions. This was marked by more abundance of infiltrating tumor lymphocytes, genomic features as reflected by SNVs and neoantigens, markers of checkpoint inhibitors, as well as many immune suppressive features. Going forward on this, we summarized these deserted and reactive TMEs. Deserted TMEs were rich in ECM signaling molecules and humoral immunity. Reactive TME, on the other hand, had cellular stress responses, growth factor and cytokine signaling, and cellular immunity features. So that there were these are hugely different tumor microenvironments existing in the same patient material. Looking at the reason for this, we resorted to CAFs, cancer-associated fibroblasts. We generated 11 new cultures from the patient-derived material. We performed single-cell RNA sequencing on them, did functional assays and bioinformatics, and then we also combined the conditioned media from the CAF cultures onto the patient-derived pancreatic organoids and studied the effect of the CAF on the organoid growth. And we found that the deserted TME conditioned media was chemoprotective, whereas that obtained from the reactive TMEs were tumor progressive. Now, we found that as using scoring the PDAC biospecimens, for which we had the needle biopsies, we found that as patients are treated, the deserted TMEs get more enriched in the pancreatic cancer, consistent with its chemoprotective role. Looking at the calves itself, the single cell RNA-seq data from the calves, we looked at the differentiation trajectories between the calf cultures of the two sub-TMEs, and we found that the calves that were in the deserted were more de-differentiated, whereas those populations that were present in the reactive TMEs were more advanced, they had more calf activation markers as well as immune activation. So in summaries, we found that tissue self-organization, we think, is dictated by calf states in the PDAC. And these calf states then help create regional ecosystems in the tumor microenvironment of the pancreatic cancer. We know that the reactive ones are immune hot, they support growth, and they're anti-differentiation, and they allow disease progression. Deserted TMEs, shown in the pink, on the other hand, are immune cold, but also chemoprotective, rich in many collagens, and they interfere with the treatment response. So both TMEs have clinical consequences. So in the course of this study, we had generated very large data sets, and we were always doing these correlations manually, and which really, is a very problematic situation when we have large data sets. So Kazira in the lab, she decided to generate this computational toolkit, we call it Hourglass, and this toolkit really helps mine large multiparametric data, especially that derived from the tissue microarrays. And it can more rapidly facilitate your analysis and help identify hidden biological patterns. So just pictorially, here's the hourglass. You can feed into it all kind of patient annotations, quantitative imaging data, and on the outcome of the tool is actually produces these visualization analysis of your data very rapidly. So I want to highlight that here so people can have the opportunity to use it. So to test drive this, we figure out, we'll look at the IL-6 expression and analyze in our PDAC samples through Hourglass. You can see the IL-6 heterogeneity, interpatient, intratumor heterogeneity, intratumor heterogeneity, even within patient, each patient you can find low region of IL-6 expression or high IL-6 expression. So IL-6 is an influential cytokine, and we looked at that more deeply through Hourglass. Now, I don't want to expect you to see this, just want to show you that you can rapidly generate these heat maps and box plots to compare quantitatively correlation of IL-6 in relation to many other markers. So we did our analysis in two different ways. We analyzed IL-6 expression based on patient stratification or on sample stratification. Remember, we had more than 600 cores of TMA, of pancreatic cancers on our TMAs. Now, when we compared this cross side by side, I want to show you a very interesting pattern. We found that IL-6 expression normally with patient stratification correlated with myeloid cell influx, but not with lymphoid cell influx. But when we looked at core by core, or the regional correlation, we now begin to see that IL-6 high expression correlates with myeloid as well as lymphoid cell influx. Now, if you look at this, you divide the data now for patient cohorts between males and females, we found that now, in this case, we had very nice correlation of IL-6 high regions with lymphoid cell influx, where the T cells were actually very much in close proximity to the IL-6 expression. On the other hand, in females patients, we saw no such correlation. So really, through this analysis, we have identified a sex disparity in PDAC where IL-6 expression seems to be more significant in relation to immune cell influxes for males as opposed to females. So Hourglass is an open access tool and is very easy to use for coders and non-coders, and it's on GitHub free and can be, comes with an instruction manual. So if there's interest in this, it would be, it can be of use. So the last thing I want to show you is that a big need in the PDAC, in pancreatic cancer field, is the need for specific tumor subtype specific biomarkers. Now, PDACs are designated as basal or classical cancers that have been defined transcriptionally. Since we had the LCM data, match proteomes and transcriptomes, we had deep tissue phenotyping in our hands. We decided to look for what could be markers of these two tumor subtypes. So when we compared the top 30 gene differentially expressed, both at the RNA and the protein level, we found that Claudin 18 and annexin A8 popped up. Annexin A8 correlated with basal and Claudin 18 correlated with classical PDACs. This bared out in both the transcriptional data as well as the proteomic data. You can see in the green arrows annexin being highly expressed in basal cancers, whereas Claudin 18 being high in the classical. We interrogated for these two molecules in the single cell data that are available and published, and we found that they are expressed in different cell clusters. So looking at these by now immunohistochemistry, here are examples of Claudin 8. You can see it's very nicely expressed in the basal PDACs. And on the other hand, Claudin 18 is nicely expressed in the classical PDACs. And now you can also see the correlation of these markers with the other known markers. GATA6 is a known marker for classical PDACs that we have previously identified in our group. And now Claudin 18 seems to even be a better marker than GATA6. So, and now we can also interrogate the relationship of these immunostains with other features and other biology within these pancreatic cancer subtypes. So in summary here, I want to show you that looking at these two markers can provide you additional insight into the subtype-specific tissue biology of pancreatic cancer. We identified annexin 8 as a faithful marker for the basalness of the pancreatic cancers, but we also think annexin 8 and Claudin 18 together make a nice complementary biomarker pair, because in pancreatic cancer both type of subtypes can coexist, and with these two markers we can actually see their mutual exclusive expression pattern within the PDAC TMAs. So in summary, I've shown that there are subtumor microenvironments. I think they come together through self-organization within tumors, and that self-organization is directed by cancer-associated fibroblasts. There are the TMEs, the tumor microenvironments, have distinct functions, and their co-occurrence is correlates to adverse outcome for the patients. We also think Hourglass can be a useful tool to analyze large multiparametric data, and it can help reveal some hidden biological patterns of interest. And lastly, we think annexin A8 and Claudin 18 can be useful clinical biomarkers for this cancer. I don't want to show you, but we have now employed a protein-protein interaction network approach to analyzing our data, looking for large hub proteins that have many interacting partners, and these hubs then operating within the tumor compartment or within the stroma compartment. And this is something we are pursuing currently. With that, this is the outcome. We are very much interested in clinical translation of our findings. So we work closely with the pancreatic PanCure team within Toronto, and we are also hoping to link up with other folks who are interested in clinical translation of this kind of data can be helpful in analyzing biomarkers of interest to the other groups. So this is my group in Toronto. We have a lot of fun. It's a great city, and we're looking for new postdocs to join us. But finally, I want to thank our big pancreatic cancer team. PanCure is led by Steve Gallinger and Jennifer Knox, who are performing many clinical trials on pancreatic cancer patients. Barbara Grunwald led this project. She's a real star, and she has her own program in Essen in Germany. Thomas Kisslinger was very central to our work. He is an expert in generating high-quality proteomics data, and Sandra Fisher is an amazing clinical pathologist. I hope I'll stop here and hope I've not gone over time. Happy to take any questions.
Thank you, Rama, for this wonderful talk. Dr. Manoj is this side. So this is the time for two quick questions.
Excellent talk. That was, I think, we need an hourglass for all cancer types because, it's an amazing piece of work. Each and everyone internationally is doing a lot of multi-omics and lot of combining with tissue arrays. So if all of that could be filtered out and we can have this kind of understanding at the molecular level, I think it's very well done and very well said. Actually, I don't have any question. This was a comment I really wanted to make. And I again thank you for this nice presentation.
Yeah, our class is very useful because it's rapid. It plots the data very fast. Otherwise, you go manually do it, and Hourglass allows you to do it iteratively. You get the data quickly, you can visualize it, and go back and ask more questions.
Yes, absolutely. Because the major challenge with going with multi-omics is actually make something useful out of it. And
absolutely.
Always want to aim for looking for good clinical markers, but you have such a huge parameters from patients to looking at each and everything. It actually makes sense. Otherwise it becomes only some segregated information that you get.
Absolutely. Before the person gets exhausted. Yes.
People like us who do not have too much of resources, such kind of computational programs and tools really play a very important role. And I'm interested in gynecological cancer. And the first thing I thought of, we need an hourglass actually. Yeah.
Please try and use it. And if you run into trouble, you can always contact us.
Yeah.
Any hurdles? Yeah.
So much. Thank you.
Any other question?
Yeah, amazing talk, ma'am. So I'm Dr. Priyanka. I wanted to know the integration you are offering in your tool. So it is integrating multiple studies together, or you are mainly focusing on
it's you can put your own data, right? You can put any data into this. It's really a computational toolkit. Basically, it has a lot of statistical methods. It has a lot of visualization protocols. We have our own data, but that's not part of the hourglass. But you can put any quantitative pathology data with patient clinical parameters, and it will plot. It's really you can populate it with any data, our data, your data, any other data. But you have to have your quantitative pathology, because when we do all of these markers, we score the signal very carefully, spatially within the cell. So we score these things very carefully, each of our markers, and that then produces a high quality correlations and data. But you can populate it with any data.
Surely, I'll try and let you know. Thank
yes, please do. Yes.
Rama, I have another question.
Yes, please.
Your data is very specific to PDAC only, the software, or?
No, the software is not specific to PDAC. It is designed around analysis of tissue microarrays. Any cancer.
Then how different it is from TCGA, GPIA, or any other tools?
So TCGA, those are actually cancer data. Our data are also actually available through, because all these, after the publication of the paper, all the data is deposited, right? Okay. So it's deposited that way, but the Hourglass is a computational tool that you can feed in your patient parameters, gynecology cancer, breast cancer, any cancer data. Within that, it's really a computational platform.
Okay. Thank you. Thank you very much.
Thanks very much.
Thank you so much, ma'am. There is a slight change in the program and I apologize for it. We shall be halting this session and we'll be starting with the GCC oration session. But before that, I would like to call on stage the chairperson of a previous session, Dr. Pallavi, to come and kindly felicitate Dr. Meera for her wonderful session. I would like Dr. Prakash and Dr. Manoj, for just as a token of appreciation, please give this gift from our side to Dr. Pallavi. A big round of applause, ladies and gentlemen. Thank you, ma'am. So now we initiate the GCC oration session. For that, I would like to call on stage Dr. Prasanna Venkatraman, who is President GCC South Asia Chapter and Deputy Director, ACTREC Mumbai, India, to kindly grace the dais to session the chair. To chair the session, I apologize.
Okay. So, I invite Dr. Amit to introduce Dr. Prasanna because, to introduce Dr. Prabhash because Dr. Prasanna is coming from the guest house. So we don't want to waste time, please. She will do the second part. So Amit, over to you.
Very good afternoon, everyone. It's an honor to introduce our oration speaker today, Dr. Kumar Prabhash. Dr. Kumar Prabhash is one of the leading medical oncologists here in India. He joined the Tata Memorial Center in 2004, and since then, he has been serving at different DMGs at the Tata Memorial Center, especially in the head and neck cancer oncology and the lung cancer oncology. Fantastic, thank you. His contributions as what is numerous. He's the president of the Indian Cancer ICON, the Indian Cancer of Oncology, and also he has been the recipient of several awards, which makes him a distinct and a renowned medical oncologist here in India. Is one of the most prolific researcher with over 200 publications, and at the same time he has run about more than 50 clinical trials here in India. So with that introduction, I would like to be honored to invite Dr. Kumar Prabhash with several JCOs coming around from India. Every second JCO perhaps might be coming around from Dr. Kumar Prabhash. So with that, please do welcome Dr. Kumar Prabhash, and we look forward to having the oration.
Good afternoon, everyone. At the outset, I will like to thank the organizers, especially Dr. Hitesh Prakash and Dr. Jyoti Kode for inviting me for this lecture. And thank you, Amit, dear friend and a dear collaborator, for introducing me. So what I'll do today is to talk about not, I say always say that the basic scientist, हमारे हिंदी में बोलते हैं, वो यक्ष क्वेश्चन आंसर करते हैं. Clinicians, I'm a clinician, वो यक्ष क्वेश्चन आंसर नहीं करते. So what we do, we learn from that yaks question answered by my dear friend and colleagues like Amit, and then try to see, can we have some clinical application? Can we modify some treatment which may end up benefiting the patient? And that's what I'll try to show today, what we have done in a limited way. When I'll start with some of the stories of failure. I won't share many because we know that many happens, but some, and we learn from it. When we do it, we say, hey, next time, please don't do it. So what we did first time, this was one of the first trial we wrote. Letrozole, a very well-known drug in breast cancer, had come that time. Initially, when I had joined as a faculty, ER/PR expression happens in lung cancer. So we say, hey, I have answer. So I wrote a trial. We had a funding, we had those details, but we didn't realize that regulation at that time for investigator-initiated study was not ready at how you implement it. In spite of more than once on my own money, going to Delhi and trying to see that I get a clearance from DCGI, that is Drug Control General of India, to have the trial running. So it never happened. So I had a learning. Be within your limits. You need to have an answer, a question. You need to have a good question, but questions should be within the limits and resource that you do it. Second, a good paper. In fact, Jyoti is one of the author and she was the corresponding author for this. This was in bone marrow transplant, and that time I used to do it. We had some science paper was there in animal study. We thought, hey, if can we replicate it in the human and then take it forward? We said, good. It went into annals. Today, the impact factor is something 50 odd. We were very happy. But once the publication happened, then we realized, what do we do with it? And then we realized there is no way I can move forward because I didn't have any way to have someone to develop something to work on CD26 where I have either a diagnostic value, prognostic value, or most important as a clinician, therapeutic value. So it didn't move forward. Good, I have a good impact factor publication, but learning was again, think about what is going to happen in future, what you're doing, the kind of clinical trial today. So that was second learning. Now, as I said, no more failures from my side. So I'll be showing you some of those clinical trials which we did subsequently, and then we see, can we have those answers which is useful for our patient? So one of the treatment what we give in head and neck cancer, you give radiotherapy and you give chemotherapy. Chemotherapy is cisplatin, which is one of those key treatment in head and neck cancer. He said, can you do some comparative trials to answer question which is relevant to our patient? So we give cisplatin. As I showed you here, cisplatin is standard treatment, multiple randomized trial is there. One of the challenges that if you do cisplatin, full dose, half of the patient don't complete the treatment. And there's a whole lot of complication. And that's the reason this 3-weekly schedule, which is there with radiotherapy, most of the time not used in India. So we said, can we develop a schedule which is useful for our patient? So what we did try to develop a schedule which is weekly cisplatin in a dose which is 30 milligram per meter square as compared to 100 milligram, and say, can we show that it is non-inferior? This remains today also the biggest randomized trial. There are 3 of them, one from India, one from Japan, another from India. The largest randomized trial to try to prove that weekly cisplatin is as good as 3 weekly, so you can easily give it. Unfortunately, we failed. So learning was that yes, we do have a trial done, but having said that, we could answer certain things, which is, we will show you what we did further. But at this moment, we had a learning, try to learn, give full doses platinum to the patient. When you do this study, I will also show some of the impact. We had a oral presentation in ASCO. This is almost Any guideline, if you want to read for chemoradiation for cisplatinum in the world, you will get the reference for this article. Important is that patient benefited, so that's why it became valuable. Then we wanted to know, can we do it better? That you had radiotherapy and chemotherapy. There are a group of patients who gets cured. We also learned not all of them get cured. And you have a good number of patients now also who doesn't get cured. We say, hey, then there is an opportunity. Can we add something or do something to improve outcome for the patient? So we planned the next study. And what was the next study? We know that there's a good EGFR expression in head and neck cancer. And we have an EGFR inhibitor antibody in India. So we tried to source it and we tried to combine that EGFR inhibitor with cisplatinum and with radiotherapy and compared that with radiotherapy and chemotherapy. This is around 536 patient randomized trial. Again, one of the largest randomized trial in head and neck cancer in this setting in adult patient where you require them. And what it showed that if you do it, it improves disease control, it improves progression-free survival, it improves disease-free survival and local regional control. When we published at the first time, subsequently, we last year presented in ASCO the long-term data and what it suggests that if you add cisplatinum and EGFR inhibitor to radiotherapy as compared to only cisplatinum and radiotherapy, outcome is better if you add EGFR inhibitor to it. So it adds life to the patient. And highlighting the impact, it was again oral presentation in ASCO. It was part of ASCO post. It is also part of all the Indian guidelines you have. And if you see the approval in China and Brazil and Korea, Cuba, it is part of this document is part of the approval for the same drug. It is not in Western world because it is a partly Cuban product and they are not marketed there. So highlighting something that is available, you have some basic for it. Again, I repeat, I didn't answer the Yak's question. Yak's question was by the basic scientists. We use that to see, can we use in the clinic and prove it that it benefits the patient. Now, this was in the cisplatinum eligible patient. In head and neck cancer, if you give radiotherapy and chemotherapy, 1/3 of the patients, they are not eligible for cisplatin. And we realized that there is no level 1 evidence or good evidence that any treatment works, means any systemic therapy beyond radiotherapy works. So what we did, we again planned a randomized trial, 356 patients, the only randomized trial which is positive for cisplatinum ineligible patients. Plus docetaxel in a smaller dose given weekly, and what it showed that it improves the local regional control, it improves the progression-free survival, and it also improves the survival. And I said, maybe not necessarily that can be true. You can see the third para. It is by editor from JCO. They wanted this line to be there. Editor name is there. That this was the first randomized trial in cisplatinum ineligible patient. If you add a treatment to the same, you do have some data regarding immunotherapy. You have some data regarding cetuximab, but none of them is positive trial. And that's why it is again part of all the guidelines what you have in the world. It had editorial and also it got mentioned in many other articles in many other journals. Now, at this moment, we are running a randomized, we have completed a randomized trial. I talked about it, cisplatinum. We have been worried about cisplatinum. We are trying to see how do we make it more acceptable? How do we have an alternative where you can have the treatment available to many more patients? And this is a 600 patient randomized trial. We wanted to replace cisplatinum because that's tough to give in the clinic. So we are trying to replace with this docetaxel. We have put in ASCO abstract, and anyone interested, if you go to ASCO or you want to follow it up, you will get this data in ASCO this time. Can we replace cisplatinum with docetaxel? Because that is far easier to give in our setup as compared to cisplatinum. We are also looking for in cisplatinum ineligible patient. Can we avoid docetaxel? Docetaxel has two important toxicity, dermatitis and mucositis, which is pretty high. And we are trying to replace with carboplatinum. And this trial is running at this moment. Hopefully, 2 years down the line, we will be having the result that can we replace docetaxel with carboplatinum, which is far easier to give in the clinic as compared to docetaxel for our patients. Now, this was for whatever we did in head and neck cancer patients when we give radiotherapy and trying to choose the best possible chemotherapy, what is available with us, and see which is easier for our patient to take and improve outcome. Apart from that, we have been working, and again, I work in head and neck cancer and lung cancer, as told by Dr. Amit. We were looking for what are the treatment options where you can't cure head and neck cancer patients, and what are the options available for them, and what we can do. These are the two standard treatment. If you go to NCCN guideline, and you will see it, cetuximab and immunotherapy-based treatment. Both treatment, we did our data analysis in our own hospital. Out of 100 patients who is eligible, 2 patients or 3 patients can take it. What does it mean? You have a treatment, but if only 97 or 95% patient can't take it, it means there is a need to develop treatment which our patients in this country can take it. So we were working on it, what we can do it to develop it. So this was the first pilot study. We have a concept called metronomic scheduling. What you do is you give 1/3 to 1/10 dose of chemotherapy, give it more frequently, and what it does it, one, it decreases the cost, it decreases the side effect of the patient, and also there are some evidence that it may be more effective. We say if that is the case, again I repeat, Yak's question was not answered by us, it was by our basic scientists who suggested that is possibility. We say, let us put in clinic and answer it. Does it really happen? This was the first pilot studies which suggested that they do have some activity. Because it suggested they do have some activity, we did a phase 2 randomized trial for 2 drugs, methotrexate, 15 milligram, usually it is given at 45 or 60 milligram per meter square, with celecoxib, and compared with cisplatin, which is usually used in this setting. The phase 2 trial suggested it controls the disease better, it improves the survival. This led to our phase 3 randomized trial comparing same drug, metronomic scheduling, which costs around 250 or 300 rupees, compared to cisplatin based therapy in first line setting, 430. Metronomic scheduling, which costs 250, 300 rupees, oral tablet, you give in OPD, don't have to come to daycare, don't require admission, you do it, and it is non-inferior to IV chemotherapy, and maybe superior with having better quality of life. We also realized while doing this that the response rate with metronomic scheduling was around 12% odd. Not high. We say, can we do something to improve the responses of these patients? So what we did, we added a third drug called erlotinib. Again, cheaper drug, the cost becomes 1,000 rupees odd, and we did a phase 1/phase 2 randomized trial. Again, people who are from pharmacology will realize rather than escalating schedule, we did de-escalating schedule, trying to see using the biological effective dose concept to see which dose is good enough. So we reduced the dose of methotrexate further from 15 milligram per meter square to 9 milligram per meter square, and suggested looks. This trial suggested that if we do this, erlotinib, methotrexate, and celecoxib in platinum refractory patient, if you give this treatment out of 100, 40 patient response. If you take the historical data out of 100, 15 patient respond, looks like there is a fair efficacy. Because we had this phase 1/phase 2 data, we published in JSU. What we did, we took the next step of doing a randomized trial. Made a group, 16 odd investigator got together. This was in last year ASCO oral presentation. What it did, it compared triple metronomic chemotherapy, methotrexate, celecoxib, and erlotinib to IV chemotherapy. And it appears if you do this, oral tablet, don't require any admission, don't require daycare admission. It is not only controls the disease better, it improves the life of the patient as far as the amount of life is concerned. So they had a survival benefit. We subsequently, what we did, we wanted to, this was in second line setting. We said, if this concept works there, can we take in the first line setting? So this was another trial at our another center, that is in Varanasi. We have a center at Varanasi. Our smart investigator, Dr. Akhil, we put a study there comparing in first line setting, if you use this concept, comparing IV chemotherapy versus IV chemotherapy and adding triple metronomic chemotherapy. And what it showed, this was again part of last year ASCO presentation, that it controls the disease better, and it also adds life to the patient in these group of patients. Suggesting that, yes, this metronomic concept with various combination of drug can be useful in first line setting and also in second line setting in our patients of head and neck cancer. There is no treatment option, I repeat, for poor performance status patients. So if you have a patients with PS2 and PS3 of head and neck cancer patient, as on date, there is no randomized trial data and no evidence that treatment works. So because this oral tablet, easy to give. So what we did, we said, take it to those poor performance status patient and see it works or not. What we did, best supportive care, that's a treatment today. And we say, can you give triple metronomic chemotherapy and see it works or not? And this was again part of last year ASCO presentation. And what it suggested that, yes, it does add life to the patient. And this is the first evidence in this setting that if we have a poor performance status patient in head and neck cancer in palliative setting, that is performance status 2 and 3, if you give them these tablets, it works for the patient. It may not work endlessly, but it works and it adds life to the patient. While, and again, highlighting the impact, it is part of up to date. This is a famous guideline, in Western world and part of our national guideline where it is available that one can use these various metronomic combination for care for your patients. But while working on these trials, we also realized, and I suggested that we don't get a plateau. The survival improves. The patient, the failure keeps happening, and subsequently, most of the patients, almost all of them, they die after a few years. You say, can we do something to have this plateau? Can we add a treatment which works? We had seen in immunotherapy that it happens, that you have a smaller proportion of patients, and yesterday there was a very good presentation that in many tumors, we have started seeing that if you give immunotherapy in stage 4 patient, a small number of patients, there's a plateau, and after a few years, they don't fail, and they keep surviving after many years. But we also know that immunotherapy is afforded by only 2 to 3% of our patients. So in that case, we say, if we use the full dose, most of the patient can't afford it. So we use the pharmacokinetics data to see, can we use lower dose? So what we did, we use 6% of the dose as compared to what FDA has approved. For nivolumab, the dose is 240 milligram. We use 20 milligram dose. So 20 milligram combined with triple metronomic chemotherapy. And this was a randomized trial. We had an editorial on it in JCO. And this was the data, what it suggested. Yesterday I had a presentation on immunotherapy, but it didn't happen. So I'm presenting it, abbreviated form, but people can read it if they want. It is in JCO, free article, that it improved response rate, it improved progression-free survival, and it also improved overall survival in this setting, suggesting that yes, if you give 6% the dose of the regular immunotherapy, it works in our patient. And cost-wise, there is it's no brainer. The cost came down by 1/10 of these patients. So if it costs 2 lakh rupees, now it costs 20,000 rupees to our patients. So earlier, the access to our patients where only 3% people could access it. And today, what we see that almost 60 to 70% of the patient can access this treatment in the clinic. And again, I repeat, this for head and neck cancer, this is the only evidence which is there. And for low-dose immunotherapy, this was the first evidence. And second evidence, which has come in last year, ESMO in lung cancer. So before that, this was the only evidence for low-dose immunotherapy in any setting, including head and neck cancer. Just self-promotion, as I keep saying, when we give oration, you keep saying what happened. So it got covered in NCI website. It got covered in Medscape. But is this the only way to reduce the cost and increase access or have immunotherapy for our patient? Not necessarily that is true. And we are trying more than one ways. Another way what we're trying is getting in collaboration with our local pharma companies. Origin is one company which has made oral immunotherapy. We have completed the randomized trial. This year, ASCO, it will be there. We have sent the abstract in case anyone interested. And this will be the first oral checkpoint inhibitor which has a phase 3 randomized trial which you can have in ASCO if you want to see the result. We are waiting for the final analysis, but that result will be there in ASCO this year. We are also looking for that, can we use low-dose immunotherapy alone? And this is a 500-patient randomized trial, which is completed. And again, this will be in ASCO this year, that you give only immunotherapy, low dose, 20 milligram, and compare with the physician choice of treatment, whatever they want to give in second line and beyond setting for around 6 odd tumors taken together and then see it works or not. Again, this will be in ASCO this year in May end or June first week. That doesn't mean some more failures. You can't keep talking only the successes. So when we use metronomic, we used in multiple settings. And these are some of the 3 settings which I wanted to convey where it didn't work. Highlighting that whenever you have modality, when you have a treatment, you need to prove tumor by tumor, situation by situation to know that it works or not. Highlighting, I showed you the places it worked. I'm also showing you the places it doesn't work. And so in this situation, we don't use it. Now, another aspect of our answering question in clinical trial is, can you have something unmet need in the clinic and which you take it and answer it? And this was an important issue for us. You get this kind of patients. You don't see this in Western world. Very few. Are almost a big number of patients they present in this situation. Most of them become unresectable. That means you give only palliative treatment. We say, can we do something to make them resectable and make them curable? What we did, we used a new adjuvant chemotherapy approach. I say, hey, give new adjuvant chemotherapy, make some of them resectable, and hopefully some of them will be curable. And we call them borderline resectable patient. This was the criteria we devised to say them which are the patients who are borderline resectable. And subsequently, we had the study which was done, and what it showed that if you do it, almost 40% patients, they undergo resection. And out of those 40% patients, 50% of them, they are long-term survivor. What it means, you start with 100 patients, 25% patients, they will be long-term survivor and they will survive beyond 10 years if you use this approach. Remember, if you don't use this approach, they won't survive beyond 8 to 10 months. We had various questions because there was a new concept, and borderline resectable concept in head and neck cancer. It is there in pancreatic, developed by our group in Tata Hospital, that you do have a concept of borderline resectable oral cavity cancer. So it comes out with many baggages that you need to answer many of those sub-questions. And these are the sub-questions which arose, and we answered each of them one by one to see that this concept holds true, that you do have borderline resectable oral cavity cancer. If you use new adjuvant approach, then 25% of the patient can be long-term survivor. Otherwise, majority of them would have died within 8 to 10 months. Showing long-term survival, this is a 10-year survival data, which we published recently, showing the same, that if you have this approach, then out of 100, 25% patients, they go beyond 10 years. We also did a randomized trial to de-escalate chemotherapy in borderline resectable patient. It suggested at this moment not possible. You need to stick to the standard treatment, that is DCF, pretty toxic. That's the reason we are looking for some other varieties of combination of chemotherapy to explore. And at this moment, it's the pilot study suggesting that you can have smaller dose chemotherapy and it works in our patient. But having said that, we are running a randomized trial, which will be over in a year or year and a half. And hopefully, Hridesh allows me to speak again, then I will be happy to present it. Can we, again, showing you the same data that we are running this study, and these are some initial studies data which we have at this moment, which we are putting in public domain. Again, this is the borderline concept which we did acceptable in our community. Yes, I'm showing you our ICMR guideline, our NCG guideline suggests that borderline concept is something which we practice today, and that is a part of routine care in India. Does the new adjuvant chemotherapy have, we have tried in many other places, and again, we tried in what we call skull-based tumors. And again, this is the NCCN guideline. You can see the reference which we have as a part of our work, which was retrospective analysis, and many times those clinical trial also becomes relevant in this setting. Showing some other trial that you can do retrospective analysis and you can get those reference in textbook. This is DVITA. Coming to some targeted therapy and local solution. We started some trial initially, and this was one of the trial, and we tried to compare EGFR inhibitor to chemotherapy. And why I wrote don't jump the line, because we were excited when the initial data came in the worldwide, and so we also put a trial. We realized that we don't have a lab to do this EGFR mutation analysis, and that's why I say don't jump the gun. So subsequently, we put a study. We put the study together with Amit, and then we had this lab fixed that you have EGFR data from our center, you have EGFR testing. This was initial paper. We'll come to this paper later on again. And we subsequently did a bigger one, data for EGFR mutation analysis, EGFR mutation rate in our population. And then subsequently, we completed the study I showed you earlier that Gefnib was better as compared to chemotherapy. But by that time, there were a whole lot of data in the public domain that targeted therapy is better than chemotherapy in EGFR mutation positive patient. But it also taught us, don't jump the gun. If you have lab part of it, meet your lab person, get things ready, and then take it forward. But subsequently, we learned our lesson and we did put a study subsequently. And that was combining chemotherapy plus TKI versus TKI. By the time you have a third generation TKI in the market. And third generation TKI that time used to cost 5 lakh rupees per month. Today it costs lakh rupees per month. So we had, can we have an alternative to our patients? So what we combined? Gefnib plus chemotherapy, and that costs around 5,000 rupees per month in our hospital. And it showed it adds life to the patient, and it also controls the disease better, and it outcome may be similar to what you can have with drug called osimertinib. That's the famous drug. Anyone can search for it, showing that yes, if we do a study in our population, we can have an alternative which any patient can take it. And what it means, 5,000 rupees per month, any Indian government or state government scheme, one can use this combination. And today, in EGFR mutation positive patient, this is the commonly used scheme and commonly used protocol in our population. This was oral presentation. This was top 30 abstract in ASCO. And also this is part of almost every guideline in the world as an option for the treatment for our patients. And showing that at this moment, I have shown 8 options. Now there are 10 of them. And as you can see, the first 3 are the inferior one. If you take the next 5 of them, maybe this combination which I showed you may be the most acceptable and most cost effective in our population. Now, a bit about bench to bedside and bedside to bench. Maybe that would have been more relevant for this audience, but my topic was clinical trial. And as Amit is here, I can use this podium to talk about it for 2 minutes. So we have worked together quite a bit, and many of them has gone to bench to website, and many times we had some brownie point also otherwise. If you see this NCCN guideline, in today's time, it suggests that you need to do molecular testing for squamous cell carcinoma patient. Take 2 years back, it was not recommending. And as I showed you this our work, we knew long back in this work that's 2012 or 13, that squamous cell carcinoma patient does have EGFR mutation, and we used to do it. In spite of, we had a whole lot of criticism, nationally and internationally. No, this is not correct. We said, no, we do see it. And again, I repeat, this is because we had this dialogue between lab and the clinician that, hey, we have seen it. We did check it before putting it in public domain. And that's why for last 10 years, we have been doing it in spite of guidelines internationally not suggesting to do it. And now international guidelines, as I can show you, so it has suggested that, yes, one needs to do it. So sometimes or many times it is important that you have to and fro from your lab and you can stick to it once your lab people say what they have seen is really true. Also showing the many of the work which is there is part of PhD thesis. And again, it's a very fruitful, and as I said yesterday also, again, repeating, it's a privilege to work with our scientists, because that you learn a whole lot of things with them, which you imbibe and then you put in the clinic, which helps our patient. Giving you one more example, and this is osimertinib. So not only we try to replace osimertinib with some other treatment, we say, can we modify osimertinib and make it cost effective? Again, work done by Dr. Amit Dutt in the lab, suggesting that if you do in animal studies and cell lines looks, the lower dose works. We say, hey, can we use this replicate in the clinic? And yes, we have done every third day dosing rather than everyday dosing, and it looks like it works. We are increasing the cohort. Once we have published it, the next cohort will be published subsequently. And what it does, it decreases the cost of a treatment by 1/3 in the clinic. Again, making it affordable for our patients. So in conclusion, developing research question is one of the important aspects of research. It is important for a question to add value in some aspect. That some aspect it added value to the patient whom I treat. It is important to be careful in scientific aspect of research question development. It is equally important to ensure that research question is developed with the resources available. Asking appropriate question leads to development of treatment, which is cost effective and most important, relevant for our patients. And that's what we try to do it whenever, whatever we have done. All the work which we have done, you don't know absolutely that is never can be one person's work. There's a whole lot of people, the PhD students of Dr. Dutt's lab, my lab, all the coordinators, all the resident who works pretty hard to make it happen. Some of my key collaborator, Dr. Vanita Narona, Dr. Amit Joshi, Dr. Vijay Patil, you've heard him, and Amit Dutt, absolutely all our translational work goes through him to see that we are able to implement. And we have some new colleagues, Dr. Nandini, Dr. Minit, Dr. Pratik, and my dear colleague, Dr. Anuradha. We have a lab there, and I saw many of the buses here, Beti Bachao, Beti Padhao. If you see here, you see all the females, all the girls, so we have imbibed there in the lab. And these are my mentors, my directors, and my ex-teacher. I absolutely indebted to them to teach me and make this happen. All my collaborators, many of them, and my family. Thank you so much. We'll be happy to take questions.
Dr. Hridesh, can I ask one question? AK Singh this side.
Go ahead, sir.
I think, let me tell you, a great presentation. It was a wonderful, body of knowledge. I really love the way you have tried various combinations of the drugs. One, and also you tried the reducing the dose. And I was incited that you are implicitly, are you not raising the issue of revisiting the optimal amount of drug to be used in various cases? Just your comments.
I do. I'm raising that question, no doubt about it. But I don't want the pharma company to listen, because I want them to come up with the same dose. So I have a chance to reduce it, because whatever dose they come up with, they will price the same way. So if tomorrow they reduce the dose to 20 milligram, they will again charge 2 lakh rupees. But don't listen, they bring with higher doses. That as a society and as our researcher give us the chance to develop treatment where our patients can afford it. So
because cost is one aspect. Otherwise, the chemical burden on the patient is also another very important aspect.
I totally agree. That's why I say I do question it. So
number one. Number two, you have shown results so fantastically that these combinations were really effective. Any of your recommendations, has it become practice, or are people making use of your, findings or recommendations?
So when I presented, I didn't present any data which is not part of recommendation. No. All the data I presented, they are part of national and international recommendation. And you can use my presentation again. I leave it to people. So every data I presented, I showed a reference for everyone that this is part of national and international guidelines. And it is
great. Thank you. I loved your presentation. Thank you.
Go ahead.
Really nice work and very impactful work, both here and in the U.S. where I'm from. So I think you point a really important point. In the immune checkpoint therapies, there was no dose response in the phase 1 trials. All right. Can you repeat? I said there was no dose response curves in the phase 1 trials. There were responses seen at the lowest doses at 20 milligrams.
I agree. I had the slide. I missed that.
Yeah. And so I think, this trial and some observational trials in Korea suggest absolutely that, especially in the antibodies, we're probably way above the minimum effective dose.
True. Some people predict 15 times the drug level. Yeah, so I agree with you that yes,
especially with these long half-life drugs that are in equilibrium and are affinity agents. I think is really nice. But I fear absolutely if we use that drug, the drug companies would raise the price to. Are you giving it subcutaneously or infusion?
Yeah. No, it's all IV. Okay. Subcutaneous, we don't have access at this moment. Oral we have. So oral we are planning to explore the first randomized trial. We'll be presenting in ASCO this year. There is an Indian company which makes oral. That we are planning. Subcutaneous at this moment we don't have access to.
Because I also simplify. A lot of the antibodies will be perfectly fine giving sub-Q as opposed to IV. But that's great. That also help.
Thank you.
So it's a wonderful talk. I have a very small question. That what led you to bring down the immunotherapy to 6% rather than the full? So, what was the basis that only 6% will be used and it might work or it may not work, but it eventually works?
So what we did, we went to all the, what he was mentioning the same, we went to all the phase 1 trials. So what phase 1 trial does, this gives you two information. One, that is primarily to see the side effects, but they also give you efficacy data and you could see the numbers. Does the efficacy changes? And looks like efficacy remains similar in almost all the doses. There's some variation. Second, there was a biological part of it, the receptor occupancy. So it appears that we use 0.3 milligram per kg of this drug. Then you do have receptor occupancy of around 80%. And that's what we usually think it is critical to have the immunotherapy effect. So we use that, as I said, Yak's question answered by some basic scientists to see that can we apply in the clinic. So these were two reasons we.
Thank you. Thank you so much.
Dr. Kumar, I mean, absolutely fantastic presentation. And of course, with so much of an societal impact of the work that what you have contributed, this truly demands for, I mean, the right presentation for an oration here at the MIT University. So, given that what you have presented and with so much of innovative solutions that what you have designed, developed, and also implemented, what has been a general receptivity? We do see that as what you have presented, that it has led to the redefinition and it has entered into the guidelines as well. So I have two specific questions. If you could share your thoughts of the general receptivity, whether it is a low dose immunotherapy or the combination of the chemotherapy along with the targeted therapy, or along with the radiation in different settings within India, and specifically across in the Western countries, how do they really envision this? And secondly, I also wanted you to take a few minutes to comment on, you are here in a basic research institute where you have the audience who are primarily, predominantly basic scientists. So as a clinician, what would you really advise them? Because it is absolutely indeed gratifying to see that something from a basic research scientist and people like you who could kind of like really bring it on to the clinics. So a comment to the scientist over here and the general receptivity of your work into the clinics, a bit more onto that.
So first part of it, there was a saying by, and this was by our ex-prime minister, and that doesn't mean directly for me, but it was very important. And he made a comment in parliament when he was a finance minister. He said, if the time for the idea has come, and it was not his saying, he said he referred someone else, then no one can stop it. So if I provide an unmet solution, for example, low dose immunotherapy, I'm not on any social media, but I got a whole lot of feedback on it. Whole lot of commentary we get from across the world that how it is useful. Because this was a relevant question, because it doesn't matter in Europe and US because insurance is there. But leave aside that, and everyone was affected. And they were also interested because they are also looking for how to cut the cost. So in Indian context, majority of the patient today who takes immunotherapy in head and neck cancer, they take this schedule. And that's primarily because others they can't afford. So I said, if the unmet solution is there for patient, people do take it and people do use it. Another part of the question, solution is that some of the time solution is, which is where there is no data there. And that remains relevant. For example, cisplatinum, which dose to give and schedule. This is an unmet need in the world. Everyone is a bit fed up with 3-weekly schedule. And that's the reason we changed the schedule of cisplatinum. And it was an oral presentation. We had an editorial on it. And we had a whole lot of references for it. Because everyone wanted to know. So a whole lot of work is there where there was a fairly good international recognition for it, that it provides a solution. Like cisplatin eligible patient. There's no randomized trial. This is the only one which is there. And we didn't write it. Editor sent it, hey, we want this to be included. And then if you see below, editor name is there who suggested it. Because this was an unmet need for people all around the world. So some places it is very relevant for us, but some places very relevant for many people around the world. So yes, different solution and you have a different impact. Second part of it, advice to the basic scientist. This is advice to both the scientist and I repeat, I say I'm privileged to have ACTRAC with us and absolutely privileged to have meeting Amit. And we used to have this Friday conversation every Friday. I meet many people there, but he was my person to vomit around what I learned in a week. And they say, "Ye kyun hota hai?" I don't know, but then he will give me 1 hour lecture, kyun hota hai? And then I'll imbibe something and do something about it. Very important, both sides. The clinician talking to the scientist and the scientist talking to a clinician. That is where you start getting. And after some time, he knows more drugs. So now Amit is a part of our molecular tumor board. Trust me, you can go back and see those advices. You will see advice where Amit, that this was the advice. My resident presents to me, Amit has advised this treatment for this patient. Because that conversation has been so much that he knows that what is required in this patient. That is the comfort zone which is needs to be required between clinician and the basic scientist and the translational scientist to be there to have many more solutions. We have been able to do little. Sure, many more conversation can lead to. They say a lot of things can happen on coffee. The saying is what? That's the right saying. So have coffee with each other. Thank you.
Are there more questions?
I would like to ask one online. Can you see me?
Is there the question was that can there be reduction in the cardiotoxicity for if you reduce the dose? So this was a small study, and we have a concern. I do agree. That's why we have never said when we have said that this reduces the toxicity. We have never made a claim because we didn't see much toxicity. That is true in that data, but that randomized trial was smaller one. This 500 patient is the next one, and there are 3-4 more lined up. That means these toxicity happens in small number of people. So unless I have a data for some 1,000 odd patients, my claim to say that reducing dose also leads to less toxicity may not be fair. So we are cognizant of that, but we are not making that claim. Hope it reduces toxicity. We are very keen that if the immune-related toxicity comes down, it can be easily given. Yeah.
So we have a question online from Dr. Rama Koka. Dr. Rama, can you please come in?
I also enjoyed your talk very much. I'm curious, in North America and Europe, there is also now a lot of emphasis about prioritizing prevention trials, primary prevention trials. Are you also doing that at Tata Memorial?
We do.
I'm sure you are doing, but I just wanted to hear your thoughts on that.
So that is very important, what was mentioned. So I am not part of it. I'm a bit of hardcore clinician. We have a group of people who does it. There are many work, but 3 of them are very important. One was in cervical cancer, where VIA rather than PAP was used. And that is an NCI grant, NCI-RO grant, which was there. That was presented in ASCO as a plenary, and that is a JNCI paper. And now it's adopted by Government of India. For doing PAP, do VIA. Second one is self-breast examination. This is by our ex-director, Dr. Rajan Badwe. Absolutely brilliant question to implement. That was rather than mammography, which is tough in India. He did self-breast examination as compared to none. And again, he showed that breast cancer mortality goes down. And third one, not in TMH, that was done by a group in Kerala. And he did for oral cavity cancer. The only randomized trial in screening ever done in the world was by him. Unfortunately, for primary endpoint for all cause mortality, it is a negative study. But oral cancer cavity mortality, it is a positive study. The group didn't allow him to take it further, so he had to de-identify. I had a good discussion with him, saying this is the way you do trial. But so there are,
Thank you.
Not as many as what Western world does, but there are.
No, I mean there are not that many here too. But I was very curious. Thank you. Yeah.
Thank you. Thank you. So with that, with the time, maybe I just kind of like invite the Deputy Director of Tata of ACTRAC, Dr. Prasanna Venkataraman. She is an astute protein chemist, a basic scientist, and this makes a perfect courtesy for her to introduce Dr. Kumar Prabhash Oration and take it from here. Thank you. Thank you, Dr. Prasanna and Dr. Kumar Prabhash.
Thanks, Amit. And it's kind of counterintuitive to introduce someone who has given such excellent lecture, and you already know who is. But this is something that we have to do, and it is my singular honor to reintroduce Dr. Kumar Prabhash, a distinguished medical oncologist specialized in head and neck and the lung cancer at the Tata Memorial Center, Mumbai, who has made significant contribution to oncology, particularly in these areas. His research has been widely recognized with over 13,400 citations, highlighting its impact on cancer treatment protocols, particularly in the Indian context. Dr. Prabhash's contributions have earned him several prestigious recognitions. He was an invited speaker at the American Society of Clinical Oncology 2015, World Conference on Lung Cancer in the year 2016, and delivered orations at major oncology conferences, including the Indian Society of Study of Lung Cancer in 2015 and the Mumbai Oral Oncology Society. His achievements have also been recognized through the Madam Curie Fellowship and the International Atomic Energy Agency Fellowship, both highly prestigious internationally. Dr. Prabhash has also completed several landmark randomized studies that have influenced clinical practice. His research comparing metronomic versus chemotherapy in head and neck cancer has reshaped palliative care approaches. Another trial confirmed oral TKIs as superior to chemotherapy in EGFR mutation-positive lung cancer patients. Additionally, his study on weekly versus 3-weekly cisplatin in head and neck cancer established 3-weekly administration as the preferred regimen. His non-randomized studies have also made a significant impact, including the introduction of EGFR mutation testing at Tata Memorial Hospital and the development of an NGS-based lung panel for molecular profiling. His work on HPV in oral cancer has been widely cited, further contributing to advancement in cancer diagnosis. Beyond treatment strategies, Dr. Prabhash has contributed to diagnostic advancements, particularly by developing cell-free DNA as a tool for monitoring NSLC, facilitating early detection of resistance and disease progression. He has also explored the accessibility of checkpoint inhibitors for thoracic and head and neck cancers in India, identifying key factors affecting their availability. Though through his pioneering research, clinical trials, and diagnostic advancement, Dr. Kumar Prabhash has significantly shaped oncology practice in India, improving cancer treatment outcomes, accessibility, and quality of life for patients. His contribution continued to drive progress in the fields of lung and head and neck cancer research. At ACTRAC, we are privileged to have him because any basic scientist who wants to collaborate with a clinical clinician, the first dial goes to Dr. Kumar Prabhash. It doesn't matter, he has these two fields of specialty, but we take his guidance for collaborations, and he has been a wonderful, wonderful clinician to interact with. With these, it's my privilege to invite Dr. Vivek Ragnekar and Sushanta to the stage to present him with the award. Before we do so, please come to the stage. I'll read out the citation, which is Oration Award on the behalf of the Global Cancer Consortium to Dr. Kumar Prabhash. So it says, Dear Professor Kumar Prabhash, heartiest congratulations for being selected as the first GCC Oration Awardee in 2025. The mission of Global Cancer Consortium is to foster global transdisciplinary collaborations in cancer education, research, treatment, and community outreach to overcome cancer. GCC activities promote globally empowered professional partnerships that enhance cancer care through research, education, and mentor training of the next generation of scientists and clinicians. This award is constituted by GCC and conferred to you by GCC South Asia chapter. It's a matter of pride that you have contributed to significantly advance the cancer immunotherapy sector in India, and this has gained international recognition. Congratulations once again for being the first in this series of distinguished awardees. Wishing you the best in taking cancer immunotherapy to even greater heights. Thank you very much, Dr. Kumar Prabhash, for all your contribution, and it is our honor to present this certificate.
I would also like to request everybody to felicitate Dr. Prabhas. Your first. Ma'am, 1 minute. You are supposed to be. Achha. Dr. Amit to Dr. Prabhas. I would like to call Dr. Simran Tandon, ma'am, to please come on stage and just as a token of appreciation, thank Dr. Amit and Dr. Venkat Raman. Ma'am, just a minute.
We thank all our eminent speakers, all the eminent scientists were present on the dais. Now we are starting our next session.
Mike.
Dr. Prabhash and Dr. Venkatramana. We forgot, sorry, it's our Dr. Prabhash. Dr. Prabhash. Dr. Prabhash. No. Yeah, please come over. We forgot to the main thing. The main thing was left. Yeah, that's it's a check of 40,000 rupees.
So I actually carried this through trusting someone to hold it in their bag because I might forget, and then we came through all the way here, and then I transferred it to my bag to be safe, and ultimately I forgot to take it out on that.
So, okay.
You're glad to get reimbursed.
So it was citation with a cash award of 40,000 rupees. So
Congratulations to sir and thanks a lot. And we are proceeding now. Actually, two speakers from the previous session were left. We will continue and combine with the present session. The last session was titled as Translational Cancer Research, and the present session is the Cancer Targeted Therapies. So two speakers, Dr. Sharmila Singh Gupta and Dr. Satyendra Kumar Singh, were left from the previous session. We will continue their talks in this session, and then we will proceed with the other talks of the cancer targeted therapies. I will request Dr. Shushant Roy or Chaudhary to be a chairperson for this session. Dr. Vivek M. Ragnekar is professor and Alfred Conan Endowed Chair at the College of Medicine, University of Kentucky. He also serves as Associate Director at Markey Cancer Center, which is an NCI designated comprehensive cancer center. He is one of the founding chair, in fact, he is the founding chair of the Global Cancer Consortium, and which started out in the 2020 with an idea to promote global cancer research, education, and outreach activities. He has over 30 years of research experience in cancer research. He has received the Vocational Excellence Award for Innovative Research from Rotary International. Our next chairperson is Dr. Shushant Roy Chaudhary, who has previously been a judge in our oral presentation session also. And he is the Chief of Basic Research at Saroj Gupta Cancer Center and Research Institute, Kolkata, a position he has held since 2015. He is a Jagdish Chandra Bose National Fellow and was previously the chief scientist at CSIR Indian Institute of Chemical Biology, Kolkata. Dr. Roy Chaudhary also served as a professor at Academy of Scientific and Innovative Research. He holds a PhD degree from the University of Calcutta. Dr. Roy Chaudhary has published more than 50 original research papers and also holds 2 patents. I will request both of them to start with the session, and I will hand over the list of all the eminent speakers to them. So we will be starting with our session.
Yes, good afternoon to all you, and welcome to this last session, which is a fusion of 2 sessions. So, yeah, so
Yeah, so we decided to be brief with the introductions. The first talk will be by Dr. Sharmila Sengupta. She's a professor at the Saroj Gupta Cancer Center and Research Institute in India.
Very good evening to everybody. And at the outset, I would like to thank the organizers, particularly Professor B.C. Das and Professor Hridesh Prakash for giving me this opportunity to present my work in front of in this very prestigious conference. As you know, what my topic suggests is that I'll be talking about some interesting insights that we have drawn from our integrative analysis of genomic and transcriptomic data on HPV-16 positive cervical cancers.
We know that cervical cancer is the fourth most common cancer worldwide, and it is known that majority of the cervical cancer cases recorded worldwide are contributed by the low and middle income countries. And even the majority of the deaths, about 94% of the deaths of cervical cancer are comes from countries like Sub-Saharan Africa, Central America, and Southeast Asia. So in Indian scenario shows that it is second to breast cancer, although the levels of incidence rates of cervical cancers are going down in India. But what is alarming about this disease is that it has a very, very high mortality rates because women come to the clinics with very advanced stages of cancer, and hence what is required is that we need to think about more advanced and precise therapy to combat this disease. Now, HPV infection is the major etiologic factor for cervical cancer, and almost 99.7% of cervical cancers are HPV positive, and it is the interaction between the viral HPV encoded oncoproteins and the host proteins that drive cervical cancer pathogenesis. And earlier, it was known that E6 and E7 were the major drivers through inactivation of P53 and PRV, but in recent times, more and more discoveries have revealed that the viral oncoproteins can interact with almost all of the major hallmarks of cancer. So since it has a viral etiology, initiates with viral infection. So the primary prevention is achieved through prophylactic vaccines, and there are a number of vaccines available. With one, the last one, Servovac, which is an Indian vaccine, which is has just rolled out in the markets, and secondary prevention, we all know, is nowadays mandatory to have HPV testing done along with co-testing with either VIA or pap smear testing, and to so on and so forth. Now, towards the treatment of cervical cancer and improved treatments and for improved palliative care, what needs to be done at the present moment here is increase the spread awareness, and also we need to understand more specifically the molecular alterations occurring in the disease pathogenesis, based on which more and more affordable therapies can be developed. So at the present moment, India does not have an organized vaccination program or a screening program, and which is very essential and probably will be rolled on very soon. So towards the improvement of diagnosis and prognosis of cervical cancers, what we know is that although HPV infection is essential for disease development, it is essential but not sufficient for disease development, depends on a lot of other factors related to the host. So among the host factors in this study, we have focused on elucidating the mutational landscape of primary cervical tissues collected from treatment-naive patients who are HPV positive, and to identify the driver mutations associated with disease, to identify potential diagnostic, prognostic, and actionable genomic markers. So we collected 50 tumor tissues along with paired blood and performed whole exome sequencing at 90x depth. And this is a depiction of the coverage. We got a very good coverage of 126x median coverage, and spanning a target region of about 39 MB, which covered exons from over 19,000 genes. So this is a depiction of the mutational landscape of cervical cancers, and the color codes show the different types of mutations recorded in our study. What we see is that we identified 6,468 somatic variants, of which non-synonymous variants were more prominent compared to the synonymous variations. And also we recorded the missense mutations, the blue marked ones, were more predominant, which was followed by the non-silent mutations. And then we went on to identify the deleterious variations by using different kinds of mutation prediction algorithms, and we considered those as deleterious when they were when they showed up by the use of at least two of these softwares, algorithms. And then we went on to identify the functional impact of the mutations and the enrichment analysis using David. We identified that the mutated genes were mostly, they were part of cancer-related pathways as depicted in the plots over there. We see that both at the level of biological processes as well as tech pathways, they involved the cancer-related pathways majorly. And then we wanted to see the correlations between the somatic mutations and various kinds of clinical parameters like clinical stage, late versus early stage, node involvement versus no involvement of node. And the nodes were of two categories: pelvic lymph node involvement and parametrium lymph node involvement. And we found that the proportion of the mutated genes associated with processes leading to cancer progression appear to increase with increase in severity of the clinical traits. And this is a depiction of the landscape of driver mutations in our patient cohort. What we observe from here, that the red bar shows that PIK3CA mutations showed up as the most recurrently mutated gene, and it was found to be present at 42.8% of the cancers actually showed up with PIK3CA mutations. And this was followed by a few other gene mutations and a few other genes like KMT2C and KMT2D, EPFAT1, etc., which were found to be mutated at levels greater than 10% in the patient tumors. And we also recorded that about 14.2% of the patients did not show mutations in any of these significantly mutated genes. And I need to mention here that the significantly mutated genes were curated from publicly available database, reported in case of a number of other cancers, also including cervical cancer. So this is the profile of the driver genes in our patient cohort. So we then went on to compare our data with those recorded in case of cervical cancers in the TCGA database as well as the pan-cancer database. And we found that the proportion of PIK3CA mutations was significantly higher in our cohort compared to the TCGA or the pan-cancer atlas. And the mutations were all recorded in the cancer hotspot region, and majorly concentrated in the helical domain. And therefore, PIK3 mutations appear to be key drivers of Indian HPV16 positive cervical cancer pathogens. And then we use the OncoKB database, which hosts the FDA-approved drugs proposed for combating PIK3CA mutations, targeting PIK3CA mutations in other cancers, including a number of solid cancers, excluding colorectal cancer, and mostly reported in case of breast cancers at various levels of evidence, where by the level of evidence, we mean level 1 indicates genes which are associated with FDA-approved drugs representing the strongest clinical evidence, and level 4 indicates genes which are where the actionability is based on compelling evidence with less robust clinical data compared to the level 1. So we see that the mutations that are observed in our cohort are targetable by several FDA-approved drugs, which gives us more confidence that such mutations can also be targeted in our population as off-label drugs. So we then went on to see whether these mutations were associated with clinical parameters, and we failed to identify any of the clinical parameters like the stage and lymph node involvement to be associated with PIK3CA mutations. Neither the two subgroups of patients, PIK3 mutant and PIK3 wild type, revealed any difference in age in their mean age. And likewise, there was no difference at the level of overall survival of the patients harboring PIK3CA mutations and those which were wild type. The similar observation we also recorded in case of HPV-16 viral load, where there was no difference between the two subgroups. However, when we categorized the tumors on the basis of high viral load and low viral load, we found that PIK3 mutant tumors were characterized by low viral load as opposed to the PIK3 wild type tumors. However, when we estimated the tumor mutation burden, we found that PIK3 mutant tumors had a significantly higher tumor mutation burden compared to the PIK3 wild type tumors. So a substantial number, these observations are interesting because we all know that TMB, high TMB is often considered for giving the patients immunotherapy, but we still do not know whether this will hold true in case of our samples because we do not have any data related to this. So we then compared this, we did a similar analysis we extracted the HPV-16 positive CSCX, TCGA CSC cohort. There were about 103 samples, and we used this to validate our findings on the clinical and viral data, and we found that there was no difference between, except for the frequency of PIK3CA mutations, which was significantly higher in our Indian cohort. We failed to identify any difference with respect to the other parameters. So which gives us confidence that our findings are sort of in the right direction. So we also had our RNA-seq data available in our lab, which has already been put in the public database and will be made available upon request. And these are also, these data are also published in the various publications that we had in the last couple of years. And using this data set, we were able to identify 17 PIK3CA mutant cervical cancers, which had RNA-seq data, and 12 PIK3CA wild-type tumors. So comparison between these groups, we compared between these two groups to identify the differential gene expression pattern in the PIK3 mutant tumors. And we found that a set of genes were upregulated and a set of genes were downregulated compared to the wild types. And majority of these mutations were associated with deregulated expression of genes involved in oncogenic functions, such as regulation of cellular proliferation, migration, ECM organization, invasion, and metastasis. Next, we all know that the tumor microenvironment is very important because it gives you an idea about infiltration in the tumor microenvironment is often correlated with patient response to immunotherapy. Therefore, we went on to check the tumor microenvironment. In this case, we used our RNA-seq data and we did a deconvolution analysis. Using the CyberSort tool, and which gives you the proportions of infiltrating immune cells, 22 types of infiltrating immune cells. Thereby, in case of the PIK3 wild-type tumors compared to the HPV negative normal samples, tissues, we showed that the wild-type tumors had a significantly enhanced proliferation of infiltrating immune cells in the tumor milieu, which in contrast, we recorded that a similar analysis considering HPV-16 positive cervical cancer patients with respect to the HPV negative normal patients, we found that there was hardly any difference in the rather that there was a rather we see that there's an immune suppression compared to the immune milieu is suppressed with respect to immune infiltration, and there was a significantly higher proportion of Tregs present in the tumor microenvironment of the mutant tumor subtypes. So now such findings are interesting because in case of PIK3 wild type, we see a suppressed tumor immune infiltration of the tumor milieu, and in contrast to the wild types which have an activated tumor milieu. So with this, we also did this is just a representation of a heat map comparing the normal, the green bar shows the normal samples, the blue bar shows the wild type samples, and the pink bar shows the mutant subtypes, where we clearly see what we observed in the previous two figures. So such findings are interesting because there is a lot of heterogeneity among the two subtypes appear to be clearly distinct with respect to their tumor immune microenvironment. So with this, I come to the conclusion of this small piece of work that we have done. We have been able to characterize the mutational landscape of HPV-16 positive cervical cancers. Our data also provides valuable insights into the molecular distinctiveness of cervical cancers harboring PIK3CA based on their PIK3CA mutation status. Sorry. And finally, we provide a strong translational insight towards building a rationale for the implementation of synergistic therapies, which could be using PIK3 inhibitors, as well as the FDA-approved drugs that we have shown in the previous slide, and as well as immunotherapy for the treatment of HPV-16 positive cervical cancer patients. Since we had already validated the clinical findings in a large data set on the TCGA, we have the confidence that it is time that we go for, in collaboration with the clinicians, if we could start some clinical trials to treat HPV-16 positive patients with distinct therapies instead of the same one therapy across all patients. The patients might benefit out of that, would have better outcomes. So with this, I end my talk. I would like to acknowledge the hard work done by my student Abhishekta mainly, and Avarna, another student. She has also contributed to some extent in this work. And I would like to acknowledge some of my colleagues from my previous institute, the National Institute of Biomedical Genomics, Dr. Nidhan Biswas, who helped in the analysis of the sequence data. And I would like to acknowledge Professor Arindam Maitra, who provided his guidance with the technology, and Professor Partha Majumdar, who is the National Science Chair and founder director of NIBMG, who coordinated a large project called the Systems Medicine Cluster, under which I led the cervical cancer part of the project, and he provided immense support in the study design and statistical analysis of the data. And last, I would like to acknowledge my collaborators from the Tata Medical Center, Kolkata, and all women who participated in providing us samples and data. And lastly, I thank you all for your patient hearing. Thanks.
Thank you. Open for questions now.
Really nice work. I noticed that the PI3 kinase mutation spectrum is mostly the helical domain mutations that are seen. That's been reported also in cervical cancer and TCGA, and it's thought to be due to the underlying apobec mutagenesis pattern. All right, that's mutation signature SPS 3 and 13. And now,
Mutation, mutation signatures were essentially the same.
Okay, so it's apopec mutagenesis that probably
Yes.
caused that, and that's why they're probably associated with slightly higher mutation burden than the ones that are PI3 kinase mutant. So that's very nice to see that coordinate as well.
Thank you.
Other
Yes.
question?
Very nice talk, ma'am. Ma'am, I had a question that you showed there is a very similarity in the mutational burden of PIX3CA in the TCGA consortium and in the Indian dataset. So whether this has been tested for other genes, other driver genes also?
No, we have not tested those for other driver genes. There are, no, because essentially what we see from our data that PIK3CA mutations had very few co-mutations along with of the driver genes along with the PIK3 mutations were recorded in our study.
Yeah.
So we did not go for analyzing that part of the data.
Okay, okay. So we can, this data is accessible to others for further analysis?
Huh?
Is this data accessible to public domain?
Yeah, the data has been put in the public domain, but it'll be open access will be given upon request.
Okay.
Because we are still in the process of publication. And this part of the work has not been published yet, but it is under review.
Okay, great. Thank you.
I was wondering, is anything known about PIK3A mutations and their influence on the immune response?
Yes.
Is there a protein that's secreted?
No,
changes
what is known in the literature is that PIK3 mutated tumors have been reported to have a suppressed immune microenvironment. However, administering PIK3 inhibitors have been shown to reverse the suppression.
Yes, but I was wondering if there is anything secreted by these tumors.
I don't have any idea. I have not looked into it so far. It would be worthwhile to check that.
No other questions? Thank you.
Thank you.
Yeah, so
I will request our chairperson to felicitate our speakers, Dr. Sharmila Singh Gupta.
okay, so may I now invite Professor Satyendra Kumar Singh. Professor Singh is an additional professor in the stem cell culture lab at the Center for Advanced Research, King George's Medical University, Lucknow. Dr. Singh, please.
Thank you for the introduction, sir. First, I would like to thank organizers to inviting me and being a opportunity to put some of my work here in this conference. Actually, I am a stem cell biologist, and you will see most of my work related to the flow cytometry. And I'm coming from King George's Medical University, it's a north part of India's tertiary care center, and we are every day, probably more than 8,000 patients come to our OPD, and we have more than 4,400 beds for them. So we have really good patient size to study and see to study. So here I am working on oral cancer because in this cancer, if you see all the stages you can study very well, like from pre-malignant, like leukopenia, ectropecia, lichen planus to you can see very easily. So even this is the cancer that patient can feel very early, though most of the patients come very late in the hospital, and then 5-year mortality rate is less than 50%. So this is it means that the burden and therapy is not that good. So, and biggest thing is that it is very difficult to predict the cancer, whether this cancer, what is the chances of recurrence or metastasis even after surgery. So what I did, I usually take patient sample in the lab and I make primary cell lines. And in this primary cell lines, I have grown those cells and I studied the stemness because it's a part of one project that I have already completed where I look for stemness by using site population, by flow cytometry where you see the functionally the stem cell, and by sporide assay and other things. So I'm using pointer. So I'm basically more interested in the study of metastasis. In metastasis, there are a few models like scratch assay, transwell migration assay, or invasion assay. So by using those assay, we have seen that CD133 positive cells are having more stemness, and then further, if you go, that CD133 positive and 44 positive cells are having most of the stem cell activity. So during this experiment, I came to a very interesting experiment that we see here. That when I have established a serum-free condition where I'm inducing the metastasis in 24 hours in primary culture. So if you see this experiment, like 24 hours time point, the CD44 low cells are low, but in 24 hours, the maximum number of CD44 low cells are here. Sorry, I'm not very good at this point here. So, and then for 48 hours, it is going back. So it means that when cell density is low, and then they are having more metastatic kind of phenotype, and eventually they become primary kind of thing. So I thought whether this is a cell proliferation based thing or it's just surface marker expression change happens here. So I used mitomycin C that inhibits the cell proliferation, and this is at only 48-hour time point. Only 48-hour time point was delayed. However, after 26 hours, the phenotype was same. So this is the cartoon that's showing that primary tumor, especially in oral cancer, distant metastasis is very rare. Mostly it happens like in local, lymph node metastasis, or recurrence is the most chances. So in this assay that I have developed, in this very clearly you can see that epithelial markers like CD326 or T24 or 166 alkane, the expression is either going down, or especially like CD326, this gene, it is known, it is linked with bad prognosis. So even metastasis CD136 expression is high. Here, when I'm going for metastatic mesenchymal markers, so mesenchymal markers like vimentin, ancatharine, and twist, they are really significantly upregulated in my in vitro culture in 24-hour time point compared to confluent culture. So this is very clearly reflecting that our model is working. And also to confirm that we use CD44 variants, because most of the CD44 variants, they differentially express in metastasis, and by RT-PCR also we have confirmed that these genes are also overexpressing in our model. So that also confirms at expression level that metastasis is happening in those systems at given time point. So what I did, I just screened around 65 FITC-TAC antibodies in this model. I did two different stages. And what I found that several genes were significantly upregulated. And all the work that I have done here with primary cells that are derived in the lab, not with stem cell line. So you can see very clearly CD49D, 62P, 62P, and CD41. They are really significantly up in metastasis. Some of them are already known, and other genes are not. So what we have done that we looked for CD25, that is very interesting, mostly expressed on the T cells. And what we see, the CD25 expression is also very high in case of metastasis. In 24 hours, the expression is going up. So next question was, what is the kinetics? So when you see very clearly, the CD24 expression is going up by 16th time point, and then eventually slowly it is going down. So it is also interesting to study how this plasticity is coming, because it is natural. Even in patient also, when during surgery, when stem cells migrate, cancer stem cells migrate to distant organ, not all of them give tumor, and then when they give tumor to distant organ, they again MET happens. So the plasticity there, EMT and MET is a process that happens all the time. So what we did, we just used a couple of inhibitors of CD55 or downstream targets like PI3 kinase and MAP kinase we targeted there. And what we see that when I'm using those inhibitors, I can see very clearly the CD25 expression is going down. And along with that, when we look for and then, yeah, this is also cyclosporine and 3-methyladenine that are also lowering the CD25. And sorry, here. And not only CD25, by using these inhibitors, I am also able to lower down the vimentin. That is also a marker of metastasis. It clearly suggests that I can also inhibit the metastasis by those markers. So by those drug combinations. So I have used several combinations, but I'm not showing all the data. And this is a functional data. You can see that in scratch assay in 0 hour time point, and then control there. It's a 72 hours time point. And then 3-MA and cyclosporine A is compared. This is the patient data. So what I did in this project was, I took primary tumor as well as frank metastatic tumor that was the cervical lymph node positive. And then I just give to pathologist. And so first I confirm that whether tissue is clearly metastatic or not. So that I use twist and vimentin, but CD25 was also upregulated in my oral tissue in metastatic. So that's something that is not known, and we found this. And then we look further at it's not T cell that those are residing in tumor coming. So like we specifically zoomed it and then confirmed that these are the mesenchymal cell, those are CD25, not T cell. The second concat model was ready. So second thing what we did, we just collected those two states, primary and metastatic, and we did RNA sequencing. And surprisingly, in RNA sequencing, around 700 genes popped up. And if you take any gene in the list and just Google it, you'll find involved in metastasis. But of course, if you see pathway analysis, not all the genes are coming up, because when you do pathway analysis, only the genes those are having significant number of it, they include only in the pathway. So like if there are 2 or 3 paper related to any gene, you will not see in the metastasis pathway. That's why probably not all the genes pathway is not showing very clearly the metastatic gene. Yeah. So this is just that most of these are related to the stem cell related pathway, DNA repair, and all of malignancy. They were up. And this is RT-PCR validation that we, couple of genes were just we checked by RT-PCR, like ITGO integrated for the top post, like probably like 300-400 fold up in RNA-seq. Here also we see at least 5-6 fold in RT-PCR validation. So a lot of genes showing significant upregulation. And then another gene that is UNKL, if it's very rare, it's like ADP ubiquitin ligase. This is also not known much about in metastasis. And we designed primer against to screen, because it has a couple of price variants, probably 8 or 9. But we successfully designed primer and quantitated this 4-5 splice variant because some of them were very redundant, it was not easy to design the primer. And so when the left panel is SRC9 cells, the oral cancer cell line, we just validated. The UNKL CP is a common primer. We designed in such a way that all the transcripts have this result. So UNKL CP significantly up in SRC9, where the other splice variant are also up, but select 204 is really clearly coming up with compared to others. 205 is not in cell line. However, in primary cells, if you see that clearly all the splice variants are up. And probably we have seen 6-7 cell lines, at least here in this experiment. And sorry. So I don't have summary slide here, just because I gave presentation a little early. So in this model, what is clearly that we can predict the propensity of a primate tumor to get converted to the metastasis. Now, in this model, we can use, like I have plate that has like CD markers, 242 CD markers. So in the primary versus metastatic stage, the total 500 or more than 500 tubes. And then probably I will just screen those markers there. And also I'm just, this RNA-seq data that we have, we would like to check in OPMDS, pre-malignant patient samples, whether we see any kind of prediction. Can we predict that this pre-malignant region get converted into the cancer later on? Because there is no way to predict them, especially in oral cancer. So that's the thing. And I would like to thank my student, Tajinder Singh Saluja. He is now assistant professor in my university. So he started his stem cell work, but later on the Vardharman Kumar, he completed few things. Still project is ongoing. And Professor Vijay Kumar, Department of Surgical Oncology, he is our collaborator for patient sample. Professor Riddhi Jaiswal, she is the pathologist and she just gives our opinion and analyzes our pathological slides. And for funding, I would like to include DHR, Ayush, and CHP for them funding. And thank you for the opportunity. If you have any questions.
Thank you, Dr. Singh. So now it's open for discussion. Any questions? Yeah, please.
Were they completely untreated samples? That
yes, usually we take knife. We don't take
most of the time the clinician says that we have not started the treatment, but we don't know what treatment they were taking before coming. So that is normally a big problem with the when we say untreated samples or the
adjuvant therapy. Our burden is very high in that, especially in North India. So we usually get samples those are like without any without any neoadjuvant therapy or any other thing.
So is there any further question? If not, thank you, Dr. Singh. So
Thanks a lot, Dr. Singh. Now I will request our chairperson to felicitate our guest speaker. Thank you.
Our next speaker is Dr. Daman Saluja. Dr. Saluja is Distinguished Professor at the Medical Biotechnology Lab, Dr. B.R. Ambedkar Center for Biomedical Research at the University of Delhi, North Campus. Dr. Saluja.
At the onset, I must thank the organizers, especially Professor B.C. Das, for inviting me here to show some of our recent data. In the past couple of years, we have been mainly the in vitro system using cell lines and the computational bioinformatics using the TCGA and geodata set. As you have seen very elegantly put by Dr. Rama, how these can be integrated. So we also try to do that integration. So everybody is here is well versed with cancer, so I need not overemphasize this. But it is sufficient to say that colorectal cancer was not a problem in India for a very long time. But more recently, more and more samples, more and more patients are showing up in the colorectal cancer in India too. Globally, it is a big problem. And according to Sears 2022 database, 36% of colorectal cancers are diagnosed in the later stages. And when at the distal sites, the cancer will show up. And therefore, there is poor prognosis and therapy response. We all are well aware of the genetic instability in these cancers. The fine balance between the oncogenes and tumor suppressor proteins is lost. With the result, there is an apparent cell cycle progression and defective apoptosis, which leads to the oncogenic growth and, of course, other parameters that are there in the induction of the angiogenesis and other stuff. So we use, as I mentioned in the beginning, we try to use the integrative approach to understand the cancer management and cure. So I think the major challenge in colon carcinoma is worldwide is early diagnosis. Identification of reliable biomarkers can really help. Then accurate prognosis as well as targeted drug therapy if we can do. A new area that has come up is differential therapy, and I will see if I have time, we can talk about it. Okay. So in this, we try to put together the clinical science, system biology, bioinformatics, and various other omics techniques, as well as machine learning and AI tools to answer and to substantiate our data. As we know that these days, a lot of data is available in the public domain, not only for SNP, but also structural data, RNA-seq data, microarray data, proteomics, and other EST tag data. So using all these and then trying to, work with our machine learning tools, we tried to answer some of the questions that if we can identify some good biomarkers for colon carcinoma. And we don't know, it is just this how AI and machine learning has really helped in early diagnosis. Can we do something in case of colon carcinoma? So we mainly worked in colon carcinoma, but also validated some of the results in other cancers using geodata set, Alkan, cytoscape, TCGA, and protein atlas. So what we did here, what I'm showing here is the three GC data sets that we took along with our own transcriptomic data, which we had carried out in the lab, and try to find out the common upregulated and downregulated genes. As you can see here, there are 84 upregulated genes that can be seen here, the common 84 upregulated genes. And similarly, over there, 200 downregulated genes were found. And we took data sets that were P53, had low P53, P73 expression, which normally is as we know, or more than 50% of the cancers have mutations in P53. So we purposely took that, and our transcriptomic data, which was in vitro data, we had P53 knocked down, not only P53, but also the other homolog, a family member of P53, P73, which has been established earlier by many others, and as well as our lab, that it has an important role to play during metastasis. So we try to find out the using all these volcano plots. We try to see the differential expression of these and identify some of the hub genes. The top, so these 284 genes, like 84 in the upregulated and downregulated genes, when we had put into the volcano plot, we tried to see the most significant genes that were getting upregulated or downregulated, and the top 20 out of those were taken as the hub genes or the main genes that we wanted to do. And then we did some PPI network analysis to understand their connectivity, and as you can see, they showed very higher degree of connectivity in this. And those routine using the other parameters, we did Kaplan-Meier graphs of these, and most of these genes, as you can see here, most of these genes establish their importance in the prognostic evaluation by segregating in high survival probability and the low survival probability groups based on their difference in the expression levels. And this is most of the part of this thesis, this paper, this data has been published recently in scientific reports. So you can see more details there. So we also compare them individually, these hub genes in the tumor and non-tumoric cells. This is the data is just represented for the three different key genes. And so when we got encouraged by these hub genes, so what we decided to look into the pan cancer. So we took 4 different tissue geodata sets and tried to find out the common genes. So we wanted to find out whether these hub genes are present in other cancers as well. Can these be important biomarkers for pan cancer? So we carried out this, and using almost a similar strategy, we went ahead and also tried to do our machine learning and other algorithm. We tried to put it so as to see whether our prediction is correct or not. So initially what we did, after taking out these hub genes, and whatever genes were, new genes came or different genes came as a common parameter in the volcano plot, and significant genes, as we did it for the other data set to find out the hub genes. We did in vitro real-time PCR to check whether they were getting upregulated or not, and how many of them really fell into the cell lines. Can we use these cell lines as our model system, where the P53, P73 was knocked down? And so we took, for that, we took colorectal cell lines, we took, so there were 4 tissues that we had taken. So we took the cancer cell lines for all the 4 different tissues, lung carcinoma, breast cancer cell lines, and others. And this is those genes were then also checked from the protein atlas data available on the website, just to confirm that whether, since we did not do proteomics and it was out of our domain, and as somebody pointed out at that time, that it is not possible for each lab to have so much expertise and this thing. So we carried out, use the protein atlas database. So we found there was a lot of similarity between, So the genes that we were referring at the RNA level and validated them, they were also getting validated at the protein level from the TCGA dataset or protein atlas dataset. So some of these key genes, we also tried to look whether they can be serve as good drug target. So this is a software available online, GDSC and CTR and RP data set. And as you can see, many of them were they served as good protein data drug target, and which can be used for designing the specific drugs or for the patients. So for that, another student started working on two of these hub genes, and the strategy that was used. Fortunately, the way we picked up these genes were instead of doing homology modeling, if the gene structure is not known, we took two hub genes whose crystal structure was already available in the PDB form, and we generated the pharmacophore and screened the chemical library, natural compound library, drug library, and cancer library. So there are different libraries that we tried to look into. And then we narrow down using the strategy on you can use any of the Discovery Studios tools or shell engine. So this is the kind of this thing. So you can make the pharmacophore, then do the screening, identify the compounds that are falling in the category, and then you can go ahead and use this. So this is the channel you can see. So after the pharmacophore mapping and fit value filter, we looked into the drug likeliness filter using Lipinski rule of 5, Weber, ADM, and TopCat. And then we identified the number of every time the number of molecules keeps on decreasing with these filters. So molecular docking was done, and then later on we carried out MD simulation. So if MD simulation gives you the correct energy, binding energies and all that, so you can call some lead molecules and then look into that. So after MD simulation, we try to find out, this is the way you find out the binding free energy, which gives you a good idea of whether the gene is really, the drug and the protein are genuinely going to interact or not. So as you can see here, so these are the two, that is the positive for this target. BIVR was a positive molecule, which was already known as an inhibitor. We docked that also, and Retitrexate, which is a known anti-cancer drug, also came up with the repurposing of the drug. So that data I have put here. So you can see there is a good similarity between the binding energies, free energy of this. So these are just to show you how these different drugs are docking on to the 3D structures where they are binding. So we then carried out an in vitro study to see that using the various, you can get the kits are available, whether it is a kinase or any other one protein. For many of these proteins, the kits are available, so you can see the effect of the drug on the in vitro activity. And here it is one where you can see that IC50 value is of retitrexate is quite close to BIVR 1532. We are trying to put a schematic work flow of machine learning model which can be utilized as a target inhibitor prediction. This work is under process, and this is the general strategy that we are using. And once it is very soon, maybe in a couple of months, 1 or 2 months, we will be ready to put it on the web server, and it will be accessible to everybody for use. We also tried to do some the differentiation therapy we tried to look into, but that work is still little preliminary, but we have some good markers. And as he has shown many of the marker proteins for for oral carcinoma, and this we did it for colorectal carcinoma. So there are certain proteins which I was finding quite similar. So in conclusions, we identified 284 differentially expressed genes among transcriptomic data using colorectal cancer cell lines and 3 geodata sets. And our these 20 hub genes that we took, they showed many of these survival outcomes, correlation. And out of these 11 out of 20, these 11 out of these 20 genes were associated with DNA replication, repair pathway, while 5 genes were associated with cell cycle progression and proliferation. So we also studied there was a good survival outcome for many of these patients, at least in CRC and with other also. So we tried to validate this data using AI and machine learning tools so that we can predict the good staging in CRC. And I have not talked about escalating induced differentiation therapy, so I will leave that. And so novel drugs were identified using the hub genes as target proteins using the drug discovery tools and machine learning. So this is the currently my team. Diprit has done the one standing next to me. I can't. This is not working very well. Yeah. So she has done most of the drug discovery experiment, and the one on the corner, Zia has done pan cancer study, and this Chanchal Bareja has done colorectal cancer data. Most of this data is already in press. Some of it is under review. And thank you very much. I also should thank my collaborators, Professor Madhu Chopra, who is expert in protein drug docking and drug pharmacophore development. And with her, we are doing this machine learning also. So, and Professor Naveen Kumar and his student Kanti Devedi, they help us in learning machine learning tools and as well as AI to validate our data in this. Dr. Apurva Obeja was the one who started this P53, P73 metastatic data in colorectal cancer cell line and carried out some preliminary transcriptomic work. Thank you for your attention. Any questions? I will be happy to answer.
Thank you. Questions? I can, if I may, I can start with one question. So does the molecular modeling program allow you to predict what would be the concentration of the drug that is likely to work?
We did for two of the markers we have started, and there we were able to find out IC50 in the cell lines. But drug discovery is a long road. It is, you need to do preclinical trials for retitrexil because it is already a known drug. It is repurposing of the drug. We can think of discussing it as a combinatorial drug therapy can be given, but not for any new molecule, because then you need to do preclinical trials and then clinical trials and toxicology study. It is not possible to really say. So that is why we use the word lead molecules. We normally don't say drug. So with the other target that we are using, it is a protein which affects the cell cycle and cell proliferation. So there we are getting some lead molecules, but it is far away from being called a drug. But this is the first step.
Other questions? If none.
The MD simulation time, how long you run the MD simulation?
We did for 100 nanoseconds.
100 nanosecond.
Yes.
But is that enough time to stabilize the complex?
So, oh yes. So I have not shown the data because of paucity of time. You do get, you must do it till at least, we did it for initially for 50 nanoseconds and the graph was quite stable. But then we went ahead and carried out for 100 nanoseconds. And frankly, it has to be, we were using BRAF facility in Pune for carrying out because protein molecular weight will determine how many days it will take because we don't have super computers. They have supercomputers, so we are able to do it in, for some proteins it is couple of hours depending upon the molecular weight.
Yes,
For larger
that's my
proteins,
concern.
can be for some
Because,
several days.
because
So-
one of the reviewer just raised the question how 100 nanosecond, 150 nanosecond is not enough. You should run up to 1000 nanosecond for the simulations.
But initially there are hundreds of papers with only 10 nanosecond, but you know now they are asking more and more nanosecond.
Right, right.
But the graphs show I can. So one of the papers is already published. I will give you the reference.
Okay.
There also we have done 100 nanoseconds, and you can see the graphs are very smooth.
Okay.
So you, if you are seeing there is no fluctuation, then be little sure about it. And then this MD, PBS and these are very important. These also give you a good idea about. We have also done SAR, structure activity relationship also we have done for these lead molecules. So there also, so I think multiple things strengthen the data.
Right.
So that helps in convincing the reviewers also.
Thank you.
For the benefit of those who are not familiar with the computer modeling, I had a quick question if you might be willing to address that. So the short time, is it reflective of the affinity of the drug for the target? Since you're seeing it in such a short duration.
Yes. So what happens is when you are trying to do drug and protein docking, then for some time it can dock even to a non-specific site. But then the half-life of that complex will be short. So it will fall off. So you will get like peaks in your MD simulation. So if I do it for very short time, I may miss those and it might come like, you know, little tethered sequence, which nobody worries about. But if you start getting spikes in between, then you know something is seriously wrong. So if you do it for longer time and you still do not see spikes after the initial phase, in the beginning, 10 to 15 nanosecond, you might see it because drug will bind non-specifically also to the protein. But if it is binding to the specific site, then that interaction will remain stable. And that stability will help in bringing the graph very smooth. So you do look into 4 parameters actually in the MD simulation. And all the 4 graphs should come normal, like should be stable. So then you are sure that this is now binding to a stable site.
Thank you.
Thank you.
Thank you so much, ma'am. I would like to call the session chairs to kindly felicitate Dr. Daman. A round of applause, audience.
Okay, so may I now invite Professor Gauri Shankar Shah Professor Shah is fellow of the National Academy of Science India, Nanyang Academy of Science Singapore, West Bengal Academy of Science Technology. Is a distinguished Indian biologist renowned for his extensive research in the field of cancer biology and tumor immunology. He is currently emeritus scientist, ICMR emeritus scientist at Bose Institute.
Thank you very much for inviting me to present my latest work. So before I start, I would like to state that some of the data I'm showing are unpublished, and I'm going to patent that. So the title of the talk is Immunotherapy and Beyond. Before I start, I would like to acknowledge the people who really are the instrumental in doing the research work and collaboration. First, I would like to thank Professor Tanya Das from Bose Institute, my long-time collaborator, my clinical partner, Diptendra Sarkar, my overseas collaborator, Jim Finke, and the founder, DST, DBT, ICMR, CSR, CCRH, and National Institute of Health. So, why I started working in cancer? If you look at the mortality rate in different cancers, you will find where is the pointer? Yeah, you will find despite the discovery of lots of chemotherapy and the new treatment procedure, the mortality rate in cancer didn't change much till 2010. Only recently, due to the discovery of immunotherapy, that mortality rate changed by 25%. So what is this immunotherapy? This is for the mixed audience, those who are not from the same field. So this is the, so for example, if we develop some tumor, at a certain point, when the tumor mass is visible, we go to the clinician and the clinician gives us the therapy. That may be a first degree of chemotherapy. And most of the patient, they again the tumor relapse. When they go to the holiday, they go the tumor relapse and then go for the second degree of chemotherapy or even the third degree of chemotherapy. At the end of the certain time, most of the patient die. With the hope of discovery of this immunotherapy, we thought maybe the immunotherapy will be able to help these people and cure cancer. So, with the hope that chemotherapy will cure the cancer. So, there are different modes of chemotherapy. I'll basically concentrate on the last part, which is the immune checkpoint inhibitor therapy. As you know, this Hojo and Allison, they discovered this anti-CTLA4 or anti-PD1, PD-L1 antibody that revolutionized the tumor, the immunotherapy process. But if you look at this immunotherapy, this is not the new subject. If you look at the Indian mythology, you will find into 3,000 years back, immunotherapy was applied. At that time, they used the adaptive transfer of immune cell to the patient, and that was forgotten by the people. So, throughout the world, most of the immunotherapy, that checkpoint therapy, are concentrated on basically anti-PD1 or PD-L1, along with the combination of anti-CTLA4 therapy. So what is the really scenario? If you don't give any therapy, the patient will die. 50% of the patient will die within 5 months to 6 months to 1 year. And if you apply the chemotherapy, the patient, the survival rate change nearly 8% up to 5 years. If you add on the genomically targeted or precision therapy, some of the patient, nearly 10% of the patients survive up to 10 years. And if you go for the immunotherapy, you see, the scenario has completely changed. Nearly 25 to 30% of the patients, they do survive up to 10 years. So I was not interested in finding in this part. I was interested in the other part. Why this 75% or 70 to 75% patient, they don't respond to the immunotherapy. I was trying to find out why they don't respond to immunotherapy. As you know, this is the staining of a tumor mass, and you don't believe that the nearly 30% of the tumor mass are only tumor cells, and the rest, 65 to 70% are the stromal cells. That includes the fibroblast endothelial cell and lots of immune cell, predominantly the T cell. Nearly 60% of the total immune cells are T cells. So what the cells are doing? As you know, this is the very nice proposed model given by the Bob Schreiber, that when we have any transformed cell in our body, we have a very strong immune system, and this immune system can eliminate this transformed cell. And some of these mutations are so smart, they escape this immune system. So we have three states. One is the elimination, and one is the equilibrium. And the last one is the escape state. There our body change our immune system so that the tumor overpower our immune system and they escape the immune evasion. So they go for immune evasion. So I was interested to understand what is going on in this escape state. So we found that there are different mechanisms by which the tumor escape our immune system, and we published number of papers on that. So we hypothesize that what is the reason for failure of immunotherapy? For example, this is a tumor cell, and we apply chemotherapeutic drug or the genomically targeted chemotherapy. Most of the cancer cells they die. But a very few or small proportion of this cancer cells, they escape this therapy. These are called surviving cells or cancer stem cells. And these are the reason for the relapse of the tumor. With the hope that if we use our immune system, or if we can protect our immune system, we'll be able to eliminate by different mode of therapy, immunotherapy, we'll be able to protect this immune system, and they will target these drug surviving cells, and they will stop their growth, and we can stop the relapse of the tumor. So that is the hypothesis. But what is really happening in the system, that we discovered that this immune cell, tumor cell, before they die, they secrete lots of factors, and that dampens our immune system and make them immunogenic to tolerogenic system. And this tolerogenic immune system, they are type 2 system cell. They cannot target this surviving cell. And even when we do the immunotherapy, we are protecting this tolerogenic cell. Those cannot target the immune cell, the tumor cell, but they also help the tumor to grow faster. So if we can rejuvenate the immune system before immunotherapy, maybe this immunotherapy will be successful, and they will be able to target these drug surviving cells, and we can stop the relapse of the tumor. So we first try to find out what is the factor, how this immune cell, immunologic cell, they are becoming the tolerogenic cells. That is a pro-tumor immune cell. So for that purpose, we did the single cell genomics of this tumor microenvironment and find out that there are lots of different immune signature that are changing in normal versus malignant cell. And very interestingly, they have different signature like CD8. They have different CD8 cluster and CD4 T cell cluster. One of the important cluster is the extreme right T regulatory. Can I use our marker? the pointer. Okay, fine. Yeah, if you look at this cluster, there is a one cluster of T cell which is called T regulatory cell. We found that the expression of this T regulatory cell is very high in tumor microenvironment. So we tried to identify that cells, and we found that it's a IL-10 producing T regulatory cell that is predominantly expressed in tumor microenvironment, and their number is nearly 60% of the total T cell number becomes the T regulatory. So these T regulatory cells plays a detrimental role in tumor condition. And very interestingly, these T cells are quite different than the peripheral T regulatory cells. They express lots of higher amount of these different cluster proteins. So they are quite different T cells. And very interestingly, these T cells, they suppress they are very immunosuppressive because they suppress almost all the immune compartment, they cause the T cell and a T cell depletion. They block the maturation of the dendritic cell. Even they produce decrease the co-stimulation. Not only that, they help the tumor to grow and they make the tumor more aggressive because they produce lots of factors that are required to make the cells tumor more aggressive. So we found that in high-grade tumor, these T regulatory cell numbers are huge than the low-grade tumor, and they have, if you look at, if they have the low T regulatory cell, they have a better prognosis, and even the distance metastasis-free survival. If they have high T reg, they have a poor prognosis. So what we found that in this immune evasion process, when there is low T regulatory cell, our immune system can target this tumor and they can eliminate the tumor. But when these T regulatory cells are higher, you see, the tumor overpower our immune system, and so at that time the tumor can grow. So if you look at the chemotherapy versus immunotherapy, there is very interesting fact that there are two clusters. One cluster is the non-responder patient cluster, and one is the responder patient cluster. And one very interesting thing is that if you give a patient to immunotherapy, and if this immunotherapy will not work, this patient will die earlier than even the chemotherapy drug-treated patient. So you see, the half-life of this patient becomes nearly 6 months to 1 year. If you give this patient immunotherapy, and if they don't respond to this immunotherapy, that is most devastating. So we try to find out what is happening to this patient. It is responder patient or non-responder patient. So for that, we analyze our single cell data and found out that there is two clusters of T regulatory cell. One is the resting T regulatory cell and one is the suppressive T regulatory cell. What they are doing? So we analyzed these T regulatory cells, and very interestingly, we found that there is always a plasticity between these T regulatory cells, whether they are resting T cells or activated T cells or resting T reg or activated T reg, effector T reg or the exhausted T reg. When these T reg cells, they do their work, they express high level of PD-1 and they become exhausted. So what is happening? So this cluster, the exhausted T reg cells, if in a patient they have high amount of this exhausted T reg cell, and when we apply the anti-PD-1 or anti-PD-L1 therapy, these exhausted T reg cells, they don't die. And they become more aggressive. That's why they help the tumor to grow. So we try to analyze this data. So what we found that in responder group, we have a high PD-1 non-responder group, we have a high PD1, low RA45 positive. That means they are activated Treg cells and they express high level of PD1. So this non-responder group express this T regulatory cells, and the responder group low or medium PD1 positive T regulatory cells, as you see. So our aim is to stop the development of this high PD1 positive T regulatory cell or T regulatory. So how we can, develop this T regulatory cell, stop the development of this T regulatory cell. That is the challenge. So, the T regulatory cell, they express one specific transcription factor called FOXP3 transcription factor, and this expression calls them the regulatory cell. So our aim was to stop the development of this T regulatory cell. Can we stop them by by inhibiting their transcription? We can do that. We can use multiple number of drugs to stop the development of this T regulatory cell. We'll be able to stop the development of this T regulatory cell, but the patient will die because of the multi-drug effect. So we were trying to find out in a different approach. We did the genomic analysis and we tried to find out the coding and non-coding RNAs that are specifically expressed in this T regulatory cell.
Professor Sai, you have 2 minutes time. 2 minutes.
Very interestingly, we found that one specific microRNA, I didn't give the name because I'm applying for the patent, is particularly downregulated in this T regulatory cell, not in other T cells. So this is a microRNA, and they have a sequence homology throughout the species. And we found that this T regulatory cell is inversely proportional to the this microRNA is inversely proportional to the T regulatory cell generation, and this is specifically only expressed in T regulatory cells. So we did the interactomic analysis and we found that this microRNA can target on either FOXP3 or the interactomics of FOXP3, which are required for the development and function of this T regulatory cell. So we confirmed that. Then we cloned this microRNA in a lentivirus system for rodent experiment and in an adeno-associated virus for human clinical trial. We found that, yes, you see, only single treatment of this, single dose of this microRNA, for 1 week, this tumor volume goes down to nearly 50%. And on all the T regulatory cell in all the tumor, the immune compartment is compromised. We did in the melanoma model, and we also used one multi-drug resistance adenocarcinoma model, which cannot be targeted either by chemotherapy or radiotherapy or any way. You see, here also this tumor goes down dramatically, and very interestingly, you see, the angiogenesis is also down-regulated because this T regulatory cell helps the angiogenesis, tumor angiogenesis. So we use this microRNA along with the chemotherapeutic drug, and we found that the mice, generally these mice die within a couple of months. But if you use this microRNA along with this carbazine, along with chemotherapeutic drug, this patient survive even up to 125 weeks, 125 months. I'm sorry, and very interestingly, they can rejuvenate our immune system. All the TH2 goes down, TC goes up, TAM goes down, and T.
If you please wrap up.
Along with
please wrap up.
Yeah. I think I will stop over here. And if you combine also with the immunotherapy, that gives better efficacy. So I will stop over here. Thank you.
Thank you, Professor Shah. So it's now open for
The short query that is you are telling that is a this particular mRNA actually regulating microRNA. Sorry, it is a FOXP3. So it is direct.
It targets FOXP3 and their interactomics because microRNA they target number of proteins particular pathway. So this microRNA only targets the FOXP3 and their associated protein, which are required for the development and function of T regulatory cells.
Okay, right. Thank you.
So what could be the cause of downregulation? It is that miRNA is mutated.
No, miRNA binds to the UTR of the interactomics and degrade the mRNA.
Yes,
of
I
this
got
FOXP3 and their associated protein like ICOS, Helios, NFAT, TAT3.
Maybe, sir, I'm mistaken. My question is, why this? What is the cause of downregulation of that miRNA in the cancer?
Generally, yeah, that's very interesting.
That's the epigenetic modifications or some mutations?
No, actual FOXP3 with the tumor, induced tumor secret loss of TGF beta and IL-2 that stimulate the development of the T regulatory cells. As soon as the FOXP3 is synthesized, it replaces this microRNA expression. It replaces. So it's something like auto-regulation of this microRNA in T regulatory cells.
Okay, so I think thank you, Professor Shah. I think we are for sake of time we have to move on. So,
Thank you so much, Sid. I would request the session chairs to felicitate Sir. There's a small announcement. This session shall be followed by a small social evening which involves Indian traditional cultural program, which shall further be followed by dinner hosted at Wall Street in the university campus.
So our next speaker is Dr. Neha Arya. Dr. Arya is Associate Professor at the AIMS in Bhopal.
Everyone. Considering this is the penultimate talk, I would like to, I'll try to, be as quick as I can. And at the outset, I would like to thank the organizers of the workshop, especially Dr. Hriday Prakash and GCC. So the title of my talk is Breast Cancer Tumor Microenvironment Crosstalk, a perspective using bioengineered 3D ex vivo tumor models. So I'll just walk you through the work that we've been doing in this direction for the past few years. And I think this is well known that breast cancer is the leading cause of cancer-related deaths in the world as well as in India. So, and along with which approximately 90% of the breast cancer-associated deaths is due to metastasis. So therefore, there is a need to develop, novel treatment strategies and, come up with newer drugs. And of course, there's a long road to the new medicine. It takes quite a while to develop one drug. And from the chemist for preclinical studies and clinical trials, only one comes as a FDA-approved drug. And not to forget the costs that are involved in during this entire process of drug discovery. So, therefore, there's a need to develop and understand, factors that are around the of better or alternate treatment strategies. So there are various parts or various components of the tumor microenvironment, which includes the cancer-associated fibroblasts, macrophages, the immune cells, and as well as the the ECM, the biophysical factors, and the stiffness, the topography of the ECM, and how all of these they combine together, and there is always in a solid tumor the presence of oxygen, nutrient gradient, gradients of soluble factors, and all of this along with the heterotypic homotypic interactions of these cells with the stromal population causes cell changes in cell phenotype and drug response. So when we talk of utilizing various preclinical models in the during drug discovery and drug development, now, there has always been, various models are available. A lot of people work in the direction of growing cells on flat 2D tissue culture polystyrene and try to utilize and understand the IC50 values. Some people are utilizing mouse models, and some, like me, are, using 3D models to develop, to understand the interaction of the cancer population with the stromal cells and also use them for as a screening tool. And then, so if you see, and of course there's human trials. So, but as you see in this particular, arrow on the right side, so as we move up the ladder, there is highest correlation of human-human, which of course is not possible all the time. So thereby people are, trying to utilize 3D models for, for cancer research, and various type of 3D models like using scaffold-based, spheroids, organoids, and so on. So I'll be talking about, with this introduction, I'll be talking about various 3D models that we've developed in our lab. And my main focus will be today to discuss about the role of CAFs, the cancer-associated fibroblast, adipocytes in breast cancer metastasis, how we've used them. I'll just show you some of the data, as well as trying to understand the role of, the extracellular matrix topography and stiffness that influences, breast cancer metastasis. So I'll just walk you through these few of these components. So in one of the work which was done by my PhD student, we have isolated CAFs from breast cancer patients, and we've optimized this protocol, and we've tried to, culture these CAFs, co-culture these CAFs with breast cancer spheroids, which we developed using a very simple strategy of, aggregation using methyl cellulose, which is a hydrophilic biomaterial. It does not allow cells surface interaction, but ensures, forced aggregation to form 3D spheroids. And then we've co-cultured these along with CAFs, and we've tried to understand the role of various, bona fide target genes involved in hypoxia, TGF-beta, and HEJOC signaling, which play a major role in breast cancer metastasis. We've tried to see how they influence EMT and whether we could use them, as the inhibitors of them could be used for in combination with chemotherapeutic agents. So we isolated CAFs from the patients, and we've characterized them for various markers like the fibroblast-specific protein, vimentin alpha-SMA, and also seen that there were upregulation of these markers not just by immunofluorescence, but by RT-PCR and Western blotting as well. Then we, at the same time, we developed a 3D model based out of breast cancer cells, and we showed that these models have they show higher expression of various EMT markers, stemness markers, the transcription factors associated with EMT, as well as upregulation of reactive oxygen species. These constitute to the hallmark of a 3D model. So whenever we're developing 3D models in the lab, this is a very, routine experiments we do. And once we've developed this model, we co-cultured them with CAFs, and we saw that there was upregulation of various EMT markers when these breast cancer cells were co-cultured with CAFs, and which was not just shown by our experiments, but also corroborated with the various databases that are available. To our surprise, we did not see much change or probably downregulation in the stemness markers, but there was upregulation of the EMT markers, invasion as well as, which could be probably contributed to the MMPs that are secreted by the cancer-associated fibroblasts. So with this, we showed that, yes, presence of CAFs influences the migratory and invasive properties of breast cancer cells. And then we also saw expression of some bona fide target genes of various pathways like hypoxia, Hedgehog signaling, and TGF-beta signaling. We saw that there's upregulation of few bona fide target genes. And when we gave, when we treated this co-culture model with inhibitors of these bona fide target genes, along with standard chemotherapeutic drugs like tamoxifen, the cancer cells were actually sensitized to the tamoxifen, which means that the concentration at which these cancer cells, were dying, the concentrations were, along with the inhibitors, we saw more decrease in, cell viability as compared to the ones in which they were treated only with tamoxifen or the inhibitors. So we concluded from this work, of course, this is a part of the PhD work, which we concluded that modulation of these key signaling pathways can be used as an alternative treatment strategy for management of CAFs-mediated breast cancer metastasis. In yet another work, we're trying to understand the role of chemical, mechanical, and topographical cues which are involved in breast cancer metastasis. By chemical cues, I mean that in 70% of the cases, breast cancer metastasizes to bone. So we've tried to develop bone-like environment, and we've tried to see how these cancer cells are behaving in such environments. We have also, in some of our work, have shown that in the presence of materials of different stiffness, there's a change in the behavior of cancer cells. And in yet another work, we've shown that how the topography of the ECM that has influenced metastasis. So I'll be discussing about the first the chemical and the topographical cues in the further slides. So when we talk of the role of bone, microenvironment in breast to bone metastasis, we utilized collagen. We isolated the collagen from Achilles tendon, and we mineralized these, and we developed hydroxyapatite-like surfaces, which basically means that bone consists of collagen along with the interspersed hydroxyapatite. So we've developed those materials in the lab. And we've actually characterized them with various techniques like XRD, FTIR, and even through SEM, we showed that there was presence of these, if you see in the SEM images on the right side, there's presence of, these nodule-like structures which constitute to hydroxyapatite, which is also seen in the EDAX data in the bottom, which talks about the presence of calcium and phosphorus in the surfaces on the right side as compared to the left side. And when we expose these breast cancer cells to these surfaces, ideally we should, expect that giving a bone-like environment, maybe the breast cancer cells should show more metastasis. But to our surprise, we saw decreased, cell elongation. So on collagen surfaces, cells were more elongated as compared to the mineralized collagen. And there was also down expression or down regulation of various EMT markers when the cells were exposed to hydroxyapatite-rich collagen surfaces, probably suggesting that there are role of others, probably other factors in the skeletal ecosystem, maybe the osteoblasts and, the chemokines secreted by them. So we moved ahead and we developed surfaces, based out of silk scaffolds. Silk is it's a protein, and you can easily generate 3D, scaffolds out of them. And we again developed mineralized surfaces, and we showed that when these mineralized surfaces were along with a co-culture model based on breast cancer cells and bone-like cells, we used MD63 in this case, we saw upregulation of EMT markers. And through the databases, we saw that there is CXCR4, CXCL12 crosstalk that is happening. So CXCR4 is a receptor that is overexpressed in breast cancer cells, and CXCL12 is a signaling molecule, a chemokine secreted by osteoblasts. So when we culture the cells, co-culture the cells, we saw that, and when we exposed them to exogenous CXCL12, we saw up got rid of the CXCL12 through this inhibitor. We saw downregulation of the EMT markers, and as can also be seen through this study on the bottom side, which talks about the increased number of migratory cells in the co-culture model when exposed to CXCL12 as compared to the ones treated with inhibitor. thereby suggesting that the CXCR4, CXCL12 axis is important and it promotes the homing of breast cancer cells to the bone environment. And if you're able to block this axis, it could probably be, utilized for understanding or developing alternate strategies for management of breast cancer. So this is a very, very interesting, part of my talk, which actually talks about how breast cancer cells behave on substrates of controlled topography. So normally in the mammary tumor, the collagen fibers are arranged in form of a wool. Okay, it's like interspersed collagen matrix, which is the ECM. However, when the breast cancer it's undergoing metastasis, then these collagen fibers, they actually arrange themselves as aligned materials, aligned collagen fibers, and they act as invasion highways. So they allow the cancer cells to move easily to secondary sites, and this is what we tried to mimic. So we developed substrates that were wool-like. I mean, they were just random nanofibers. We developed substrates that were aligned in nature using electrospinning, and we grew cancer cells on them, and we saw that there is these aligned substrates actually act as contact guidance. So they allow the cancer cells to align themselves, which could also be seen through the phyloidin, which labels the F-actin staining, and we can see how beautifully these breast cancer cells align themselves on these substrates. So we showed the upregulation of EMT markers, the transcription factors, stemness markers, as well as increased migration and invasion of breast cancer cells when they were cultured on substrates that were aligned in nature. And we also saw increased amount of these tumor spheres when these cells were cultured on aligned substrates. We trypsinized them, and then we exposed them to tumor sphere assay. So we saw if you see here, we saw a bigger chunk of these materials these cells forming tumor spheres. So thereby concluding that the breast cancer cells showed significantly increased expression of the EMT-inducing markers, invasion, as well as migratory properties on aligned substrates. And then we actually thought that how these aligned substrates are acting at the level of the, in the cells. So we probably, we thought that maybe look at, maybe it's interleukin 8 that is kind of influencing. So we saw through the Wnt signaling pathway, since that is kind of upregulated in breast cancer. So we, we performed simple PCR, and we saw upregulation of IL-8 in cells that were grown on aligned substrates as compared to random substrates. And of course, when we downregulated IL-8, we saw of course a decrease in the expression as well, and a decrease in EMT markers, stemness markers, as well as some bona fide target genes associated with key signaling pathways like hedgehog signaling. And so this, we concluded that Wnt and IL-8 axis could actually be used as a potential target for regulating metastatic breast cancer. So it's going to be 2 more minutes. Okay. So in yet another study, we are trying to understand the role of obesity in breast cancer metastasis. So we've developed, adipocytes that are lean, which are obese in nature. We've characterized them with various markers of obesity. And then we've tried to culture these, cells on substrates of controlled topography. And we've seen in various experiments that both obesity as well as, presence of aligned substrates actually increases the EMT markers. So to conclude, we now are actually moving towards utilizing these 3D models and integrating them with multi-omics. And then maybe, we can come out with better therapeutic or alternative strategies for drug discovery and personalized medicine. And the take-home message is that the tumor microenvironment plays an important role in breast cancer metastasis. And if we are able to harness this crosstalk of the tumor microenvironment and breast cancer cells, we can actually, look at alternative treatment strategies. And we've shown this not just by using the co-culture of cancer-associated fibroblasts with breast cancer cells, with, the cells that are, with obese adipocytes, even by culturing cells with on various substrates of controlled topography, stiffness, as well as, exposing these breast cancer cells to the bone microenvironment. So this is basically what we've been doing since past few years. And with this, I would like to acknowledge the organizers of the GCC conference, my collaborators, various funding agencies that have been, being generous enough to support our research work, and the students who've been involved in this work. So thank you, and I'll be happy to answer questions if any.
Thank you. Questions? Yeah, there's one.
Yeah, very interesting talk. I just have a query. You were talking about your aligned nanofibers. How do they correlate to what is happening in a patient, especially if you're looking at personalized? I mean, how would you kind of judge and then align the treatment to a better prognosis?
So basically, I mean, this is a very important marker at the alignment of extracellular matrix in the body. So although it has not been used in the clinics very often, but there are papers, which support that one should actually look at this aspect as well. So when we talk of personalized medicine, maybe we could, try to do some scans in which we can look at the alignment, and if there is any PCM, and then maybe also give some alignment modulators, that could prevent these cells to move to a distant site. But then that would depend upon actually looking at whether, alignment of collagen is there in the breast cancer or not.
Thank you.
I have a quick question. So in the co-culture studies that you've done with the adipocytes, do you see any fatty acids being transferred to the breast cancer cells? Have you tried staining those cells with oil red O, for example?
I think that's a very good question, sir, but we've just started working in this direction, and we'll probably be looking at it in the, in the coming few months, and maybe I could present that in the next conference.
Can I ask a question, Ram Khoka here? Yes. It's really very nice talk. I think you covered such a lot of ground with so many important aspects of the microenvironment. One question for me is, when you have testing cancer cell lines, have you tried multiple cancer cell lines? And I don't mean just in numbers, I mean representing different kind of breast cancer subtypes, triple negatives versus the PR positive, just to see that these factors work, differently on these, or they have imposed similar characteristics.
So at this point in time, we've tested a few of our work on, with the CAFs on MD, MB231 and MCF7, and then we've moved to patient samples. So I didn't see much point in, looking at many cancer cell lines, but rather, develop these organoids or spheroids based out of breast cancer, subtypes that are there in the Indian population. So that's the direction now we're moving into, rather than, testing on other cell lines, like apart from MDMB.
Right. I think that's a really wise choice. Very nice.
Thank you.
Thank you, ma'am. The session chairs are requested to felicitate Dr. Neha.
So we have now come to the last talk of the day. Dr. Nilanjana Basu. Dr. Basu is a clinician scientist currently serving as an associate professor at the Amity University of Indian Systems of Medicine. Dr. Basu, please.
Thank you so much, sir. So I have more constraint of time. I'm told to finish before 10 minutes. So I'll keep my talk very short and crisp.
So this is my thesis work, and the thesis was done in Amity Institute of Molecular Medicine and Stem Cell Research under the able guidance of my guide is sitting here, Dr. Professor Simran Tandon and Professor B.C. Das sir. So other mentors were Dr. Chandandeep Tandon and Dr. Manoj Garg. So this is, before I start the presentation, so we talk about integration. So integration in medicine doesn't mean only in therapeutic aspect. Integration also means science and medicine should come together. So for me, I am a clinician scientist. As I mentioned, I am a practicing homeopathic physician, but I came into science just to know how homeopathic medicines work. So that was the main question, why and how it works. So the title, as you can see, the anti-cancer impact of arsenicum album, that is a homeopathic medicine on hormone-dependent breast cancer cells. So for people who are from not from India, or maybe somebody who don't know about Ayush, Ayush is a system. It is a part of ministry in India where we have all the type of traditional system of medicine. So these is Ayurveda, yoga. So Ayush, AYUSH, and H is homeopathy. Though homeopathy was started in the West, that is Germany, but somehow India got the privilege to nurture it. So this is Dr. Samuel Hahnemann, who was the discoverer of homeopathy. He was a German physician. So potentization, that is the dilution which is there in homeopathy, has created the most controversial area, but it has also, despite the controversy, we have gained popularity in treatment in many diseases, including cancers. So now it is legally practiced in 70 countries. And if you see the market size in India, currently it is 5.12 billion USD. So basically, it is not the idea to just use as an alternative medicine in especially cancers. So it is our idea to use it as a complementary or alongside medicine with the conventional treatment, so that we can be of some help. So I'll come to that. So the potentization thing, it is actually the potentization, that is the dilution in homeopathic medicine, does not reduce the quantity of the medicine. It is basically apparently diluted. This slide I have specially produced because this work has been done by Dr. Jayesh Belare from IIT Mumbai, nanotechnology. So he has proved that it is just an apparent dilution. With this succussion, if you see, we succus the medicine like this, which cause nanoparticles to levitate up to the air liquid interface, and then that is diluted, taken up, and it is serially diluted every time. So basically, the nanoparticles are getting carried forward in every dilution. So this is a very important slide. So now I come down to arsenic. So arsenic trioxide has been used in medicine for several years. So I didn't go to the details, but yes, it has been approved by FDI for acute promyelocytic leukemia in 2000. So it is basically arsenic trioxide is a poison. But somehow in Chile, there was a study to see whether the patient, because there was a huge arsenic toxicity, so the people there wanted to see how many mortality were there because of arsenic poisoning. But very surprisingly, it was found that the breast cancer mortality was very less in those cases, in that place of Chile, where arsenic trioxide was highly poisoned in water. So this is one aspect that shows the importance of arsenicum album, that is our medicine, according to the homeopathic principle, that is minimum dose stimulates and maximum destroys. So we believe in dilution. So these are the effects which you will see that we have done. So the basic problem currently, which everybody talks about, is relapses in cancer, the metastasis, the drug resistances, and the collateral effects to the normal cells. So, and it's expensive, obviously. So is homeopathy a possible solution? So is it safe? First thing people say it's
The critics say, is it placebo? Definitely that has to be proved that it's not placebo. So this cell line model will show that this is not a placebo effect. You will see the results over here. And then whether it is safe or not. If it is not a placebo, it should not be cytotoxic to the normal cells. So we'll show that. And what are the effects on the cancer cells? And what are the possible mechanism involved. So we use arsenicum album, which is we call in homeopathy, in 6C potency. That is 10 to the power minus 12 dilution. It is beyond Avogadro number if you see. So it was procured from the manufacturing company. And all these medicines are usually made in 90% alcohol. So that is the solvent control. So to negate the effect of alcohol, we have used the solvent control for 90% volume by volume. So this is the first experiment. If you see that, take out the pointer. Okay, so you can see where it's this. This is the MCF10A, that is normal epithelial cells, cell line, and here you can see that is being treated with arsenic. So SC is solvent control, that is 90% ethanol, which has no effect. So that has been standardized in our lab, and you can see this effect, cytotoxicity effect on the MCF7 cell line, hormone-dependent breast cancer, by the effect of arsenic, by dosing with arsenicum album 6C potency. So it has no effect on or it has a protective effect rather in case of normal epithelial cell. So basically it is not cytotoxic to the normal cell. So it has a differential cytotoxic effect. Then we wanted to see whether this cell line, arsenic album, what type of, how the cell death is produced. So mode of cell death. So for that we had found out that it has caused apoptosis. So if you can see this graph, it's very much visible, and along with that microscopically the cellular changes, if you can appreciate here, the flattening cells, if you compare with the solvent control. So that proves that it has produced some apoptosis. So by gene expression analysis, we had seen the BAX BCL2 ratio has been increased, which shows that it has induced some apoptosis. And again, the DET receptors might have been induced this caspase 8 upregulation. So maybe both intrinsic and extrinsic. So we had done it till here. We have to go further to show what is the exact pathway. So now this is the part of solvent control where it migrated totally, and this is the scratch assay, which shows that it is helping somewhere in limiting the migration. So that we had done with the epithelial mesenchymal transition. So E-cadherin got upregulated, and you can see the N-cadherin and vimentin getting downregulated. So basically it is reversing somewhere, and it is having some effect on the epithelial mesenchymal transition. So then we come to the cell cycle. So here it has a G2M and a sub-zero arrest, probably because of DNA damage. And again, it is again proved by the cell cycle genes like P51 and cyclin D1. So it's P51 upregulation and downregulation of cyclin. So we wanted to see what is the mode of how the DNA is damaged. So Ross generation assay was done. So we stained the cells, and a flow cytometry result, you can see that it could generate high amount of Ross compared to the solvent control. So this is my last slide. So this is how probably it is working. So this is just a preliminary study because no study has been done before this. So this is a preliminary study that how it can basically affect. So basically it is producing ROS, which is upregulating caspase down, and the BAX BCLT ratio gets disturbed, caspase 3 activated, and apoptosis. And cell cycle arrest is there, epithelial mesenchymal transition has been inhibited, and there is no adverse effect on the normal cells, that is MCF10A. So these are the conclusions which I've already mentioned in my previous slide. Thank you so much for the patient listening.
Thank you.
And I only one line, so I'm very interested actually to specially participate in this conference, because everybody knows that homeopathy has, especially after COVID, did induce something in the immune boosters. Okay, it has been used as an immune booster, especially arsenicum album. So it's my privilege to be in this conference. And now, after I completed my PhD, I am doing my research. So I got a 50 lakh grants from my industry to continue my PhD work further. So I'm open to collaborate, especially with immunology, because tumor immunology is very important for homeopathy, what I understand. Thank you so much.
Okay, thank you, Dr. Basu. I think, is there any pressing question?
There might be many, many, many questions.
So we'll discuss later, maybe, because a lot, people are waiting. So let's have the felicitation.
Thank you, Dr. Basu. I would request the session chairs to kindly felicitate Dr. Nilanjana Basu. I would also like to call Dr. Subhajit and Dr. Sudeep to kindly come on stage and thank our session chairs with a small token of appreciation. A round of applause, ladies and gentlemen.
10 minutes break was given them for cultural session. I'm leaving.
Thank you so much, sir. With this, we come to the conclusion of today's session. I would like to tell everybody that the cultural session will start just in 10 minutes.
जिसको डांस देखना होगा
एक बार समझा दो
celebration. Without further ado, let's begin with our first performance of the evening. I call upon a gifted singer whose voice has a magic to transport us to the world of melody and devotion. Ladies and gentlemen, let us welcome Sakshi with a huge round of applause.
Ready?
Doom doom dana doom doom dana dana na 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 doom doom dana doom doom dana dana na dana na dana na dana na doom doom dana doom doom dana doom doom dana dana na 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 doom doom dana doom doom dana dana na dana na dana na dana na doom लट उलझी सुलझा जा बालम लट उलझी सुलझा पार लट उलझी सुलझा जा बालम लट उलझी सुलझा पालम लट उलझी सुलझा जा बाला माथे की बिंदिया आ, माथे की अपने जा जा बलम लट उलझी सुलझा जा बाला गरे नि सा पनी सा नि सा पनी प गरे ग सा रे नि सा ग मा नि सा ग मा प प प प प म प ग म प नि ध ब म प ध नि ध ब म ग म प नि ब म प नि म प ग म सा ग नि प ग म ग रे सा ग म ग रे सा म ग रे सा म ग रे सा म ग रे लट उलझी सुलझा जा बाला dum dum dana dum dana dum dum dana dana na 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 dum dana dum dum dana dana na dana na dana na dana na dum dum dana dum dum dana dum dum dana dana na 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 dum dum dana dum dum dana dana na dana na dana na dana na dum जा जा रे अपने मंदिर 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 सुन पावे तेरे साथ नदिया सुन पावे तेरे साथ नदिया जा जा रे अपने मंदिर जा जा रे अपने मंदिर कहत सदा रंग तुमको चाहत कहत सदा रंग तुमको चाहत तुम क्यों मुझसे छड़ती हो जा जा रे अपने मंदिर जा जा रे अपने मंदिर मन मोहिनी मोरे मन भावे मन मोहिनी मोरे मन भावे मन मोहिनी मन मोहिनी मन मोहिनी. Thank you. Thank you so much.
Thank you, Sakshi, for such a symphonic performance. Up next, we bring you a vibrant trio of performances showcasing the traditions of different states. Bihu, a folk dance of Assam, is a celebration of harvest, love, and joy. It truly captures the spirit and festivity in the Assamese way. This will be followed by Haryanvi dance, which reflects the rustic charm and vibrant folk traditions of Haryana. And then we move to the colorful land of Gujarat, where rhythm and joy come together in the form of Gujarati Garba. Let's welcome our dancers with a round of applause.
বগলী পৰিছে এই পিঠিত সমনীয়া এই শালিকি পৰিলে শিল এই পখিলা পৰিব ফুল বুলি ভাবি আমাৰে নাচনীৰ গান আমি অসমীয়া বিহুতে যে বলিয়া বিহু বিহু লাগিলে গাত ফুলে ফুলে পখিলাৰ জাত চেংনাং পুলিটিয়া লগালে মাত চেংনাং নাহৰটো ফুলিল অগৰটো ফুলিল কপৌ ফুলিল তোৰা খোপাত চেংনাং ফুলে ফুলে পখিলাৰ জাত চেংনাং পুলিটিয়া লগালে মাত চেংনাং নাহৰটো ফুলিল অগৰটো ফুলিল কপৌ ফুলিল তোৰা খোপাত হাই কংচি হাই চেংচি ৰং হাই কিতাম কিতাম হাই কংচি হাই কংচি ৰং হাই কিতাম কিতাম ये बुले बिहुआ सक सकी धिमकिती धिम दाओ दाओ ये बुले बिहुआ सक सकी धिमकिती धिम दाओ दाओ धिमकिती ढोले बाओ ओए ती तोल पे पाबा ओए धिमकिती ढोले बाओ ती तोल पे पाबा ओ डाঙৰ মা সৰু মা ৰুণু মা জুনু মায়ো সবে মিলি বিহুকে গা সবে মিলি বিহুকে গা জিলমিল কুমুৰাৰ পাতে ঐ লাহৰি জিলমিল কুমুৰাৰ পাত বিহুনো চাচলেৰে কাষে চাপি চাপি মাৰিলি চকুৰে কাঠ হৈ কাঠ বন জুই জ্বলিছে গাত হৈ গাত শুনি তোৰ মতৰ মাত হৈ মাত চেক চেকি পৰুৱাই কামোৰ এটা দিলে যেন গাত চেক চেকি পৰুৱাই কামোৰ এটা দিলে যেন গাত চেক চেকি পৰুৱাই কামোৰ এটা দিলে যেন গাত
ਵੇ ਚੁੰਨੀ ਮੇਰੀ ਰੰਗ ਦੇ ਲਾਰੀਆ ਮੇਰੇ ਯਾਰ ਦੀ ਗੱਡੀ ਦੇ ਨਾਲ ਦੀ
अरे डटे बाजेगा रे आना बाजेगा ना जूत बाजेगा अरे डटे सौरभ भाई अपना चलन दे
कमर पे चोटी लटका के नैन नजीले मटका के कमर पे चोटी लटका के नैन नजीले मटका के छोरे ने बिगाड़गी छोरी चाड़े पाड़गी छोरे ने बिगाड़गी छोरी चाड़े पाड़गी।
अरे रंगीला का त्योहार है डोला इतने में काम ना चल रहे और एक बार पुराना भी आने दे
जानते
કિનારે તો ખાલી પડે નાની નાની બગલી ને નાના એવા સપનાની રેત વાળી ડગલી ને તોફાનો તરાપ મારે હાલે સાવ આપી જાય તોય jani mata nam nahi hape evo karbo kalasi evo hard no pravasi evo karbo kalasi evo hard no pravasi godilo 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 godilo
પોતાના જ દરિયામાં પોતાની જ ડૂબકીથી જાતનું અમૂલ મોતી લો
પતિ જે મજામાં ખાલી વાવટા ધજામાં એવો હાડ નો પ્રવાસી ગોતીલો
એવું કોણ છે ખલાસી બને
ઓકે ભૈયા
એવું કોણ છે પ્રવાસી બને
હાય હાય હૈયા
એવું કોણ છે ખલાસી બને
લઈ જા નૈયા
તમે ગોતી લો એવું કોણ છે ખલાસી બને
ઓકે ભૈયા
એવું કોણ છે પ્રવાસી બને
હાય હાય હૈયા
એવું કોણ છે ખલાસી બને
લઈ જા નૈયા
તમે ગોતી લો
ઢોલીડા ઢોલ રે વગાડ મારે હિચ લેવી છે
ઢોલીડા ઢોલ રે વગાડ મારે હિચ લેવી છે
એ હિચ લેવી છે ને મારે ગરબે ગમવું છે એ હિચ લેવી છે ને મારે ગરબે ગમવું છે ઢોલીડા
ઢોલીડા ઢોલ રે વગાડ મારે હિચ લેવી છે ઢોલીડા ઢોલ રે વગાડ મારે હિચ લેવી છે
धिन तड़ाक आजा उड़ के सराट पैरों से बीड़ी जरा खोल नगाड़ संग ढोल बाजे हाय धाय धम धम धाय नगाड़ संग ढोल बाजे हाय धाय धाय धम धाय ये धिन तड़ाक आजा उड़ के सराट पैरों से बीड़ी जरा खोल नगाड़ संग ढोल बाजे हाय धाय धम धम धाय नगाड़ संग ढोल बाजे हाय धाय धाय धम धाय
बाजे रे बाजे रे बाजे रे ढोली तारो ढोल बाजे ढोल बाजे ढोल बाजे ढोल के धम धम बाजे ढोल
रे ढोली तारो ढोल बाजे ढोल बाजे ढोल बाजे ढोल
ढम ढम बाजे ढोल
धम धम ढोल बाजे बाजे रे ढोल बाजे धम 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 ढोल बाजे बाजे रे ढोल बाजे धम धम ढोल बाजे बाजे रे ढोल बाजे धम धम
What an electrifying performance by all the dancers. Let's now move towards folk to finesse, energetic beats to the elegance of ancient classical dance, Kathak, where dancers use graceful movements, expressive hand gestures known as mudras, and captivating facial expressions to convey the tales of love and devotion. Please put your hands together for our classical dancers.
सकल बना भूल रही सरसों सकल बना भूल रही सरसों सकल बना अम्बुआ फूटे टेसु फूले अम्बुआ फूटे टेसु फूले गौरी करत श्रृंगार मालनिया गढ़ वाले आई कर सो सकल बना भूल रही सरसों सकल बना भूल रही सरसों
We hope you are enjoying this zestful diversity of India, keeping the spirit of the celebration alive. Let's put our hands together and welcome the incredibly talented and melodious Priscilla for her Western solo singing performance.
From the beginning, hello, hello. Monitor is not working. Monitor.
Thank you, Priscilla, for such a melodic treat. Up next, we bring you the performances from yet another culturally opulent region of Andhra Pradesh, known for its dynamic dance forms. Following that, we shall continue our exploration of the Southern Indian culture through mesmerizing South Indian folk dance performance. Post that, get ready for an explosion of energy as we take you to the land of dhol beats and bhangra moves, Punjab. Please give it up for our dancers.
കാലികൾ മേച്ചു നടന്നു കണ്ണൻ നല്ല കാർനിറം പൂണ്ടു കളിച്ചു കണ്ണൻ കാലികൾ മേച്ചു നടന്നു കണ്ണൻ നല്ല കാർനിറം പൂണ്ടു കളിച്ചു കണ്ണൻ മണ്ഡപമുണ്ടാക്കി വച്ചു കണ്ണൻ മറ്റു കെട്ടിട്ട് കള്ളം പറഞ്ഞു കണ്ണൻ
రాజమండ్రి రాగమంజరి మాయమ్మ పేరు తలబనోళ్ళు లేరు మేస్తిరి కళాకారుల ఫ్యామిలీ మరి నే గజ్జ కడితే నిద్రపోదు నిండు రాత్రి
సొగులాడి స్వప్న సుందరి నీ మడత సూపు మా పటేల మల్లె పందిరి రచ్చరాజ పుండె ఊపిరి నీ వంక చూస్తే గుంటలోన డీరి డిరిడిరి తూనీగా నడుములోన పూట పెట్టి తుపాకి పెంచి ఆమె తింగలి చిట్టి పగడాతి నట్ట మడత పెట్టి
ఆ కుర్చీని మడత పెట్టి
அப்படி போட 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 அஸ்தி போட கண்ணாலே இப்படி போட 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 இட்டு போட கையாலே
உன்னோட ஊருக்குத உப்பு மூட்டை ஏறிக்கிற உன்னோட கண்ணபதி கண்ணா மூட்டி ஆட வர இந்த நட போதுமா இன்னும் கொஞ்சம் வேணுமா இந்த நட போதுமா இன்னும் கொஞ்சம் வேணுமா
கடந்து வீரி வர பார்த்தோம் உலகத்தின் முதல் மொழி உதிர തമിഴ് വീണാതെ
வெளியில சொல்லிட மாட்டீங்களே. நான் ஒரு தடவை சொன்னா 100 தடவை சொன்ன மாதிரி.
शौक सारे पूरे ठोक ठोक करदा मैनू सारे कहतों रोक टोक करदा गल्लां नाल सुपने दिखाउणा ए पिछों आख दिना मैं तां जोक करदा सुनने सुनने लगदे आ पैर वे तुरिया ना जावे मोरा मगरा गड्डी दे पवाउंदा रहिंदा रिम वे मेरे भी पवा दे कदे झांजरा गड्डी दे पवाउंदा रहिंदा रिम वे मेरे भी पवा दे कदे झांजरा आशकी इश्क कमाम दे गए लगियां दे बोल पुगा 12 साल चराइयां मच्छियां है मच्छियां लइयां कन्न विच मुंदरा पा
What an exhilarating performance. Now we turn to the most revered and ancient classical dance form, Bharatnatyam. Originating from the temples of Tamil Nadu, it is a dance form that embodies the essence of storytelling, devotion, and unmatched grace. The dance form comprises of precise movements, formal intuitive gestures, and expressive body language, which has delighted the audience for generations. Let's welcome our classical dancers with a round of applause.
கணீரோ நீர்காண் சோழ வெற்றி வாழ் ஒன்றே காணீரோ அழகிய பூவே செல்லதியோ மலரிடு போ சகே வீரா ராஜ வீர சூரா தீர சூர வீரா சோழ வீர சீரா ஞானம் வாழ வாராய் வாகை சூட கொடுவோர் பகை போர் நடுகள் சேர்க்கும் வீர மாறா காதல் மாற பூவோர் ஏங்கும் வீர பாவோர் போற்றும் வீர துறை வாழரை தாங்க பருதோள் புவி தாங்க பழவாயமையாட வருவாய் களம் ஏற ஆயிரம் வேளம் போல போர்க்களம் சேரும் சோழ வேந்தா ராஜராஜ வாராய் வாகை சூட வீரா ராஜ வீர சூரா தீர சூர
விரலியர் கானம் பாட கணிகைய நடனமாட பாவையர் புலவை போட பரிதேர் சகடமாட தலைமேல் கதிரை போல விளங்கிடும் மருமதேவ பழையணி பெருமை சாற்ற புலவர்கள் தமிழும் வீரும் கடமேல் புயலை போல கலங்கள் விரைந்து பாய மன்னலை சீராட்ட தென்புலம் மேகு வீர
வீரா ராஜ வீர சூரா தீர
Thank you.
What an enchanting performance by our dancers. अब बारी है अल्फाजों की जादूगिरी की। शायरी सिर्फ शब्दों का खेल नहीं, एक एहसास है। इसी के साथ जोरदार तालियों से हम स्वागत करते हैं डॉक्टर नावेद का, जो हमें अपनी शायरी से जज्बातों की दुनिया में लेकर जाएंगे।
वेरी गुड इवनिंग टू वन एंड ऑल। शायद एंड में जो सबसे मुश्किल काम है मुझे सौंप दिया गया है, क्योंकि एचपी से मैं कह रहा था कि थोड़ी तबीयत नासाज है, आवाज से भी लग रहा होगा, लेकिन परमिशन नहीं मिली और छाया मैम का आदेश है तो फिर थोड़ा बहुत तो कुछ सुनाना पड़ेगा। पर मुझे लग रहा है कि ऑडियंस शायद ज्यादा शायरी सुनने वाली लग नहीं रही मुझे, लेकिन पहले शेर मुझे थोड़ा आइडिया हो जाएगा कि सुन पाएगी कि नहीं सुन पाएगी। मैं फिर उसी हिसाब से शेर को मॉडिफाई करूंगा कि महफिल में चल रही थी हमारे कत्ल की तैयारी, कि महफिल में चल रही थी हमारे कत्ल की तैयारी। हम पहुंचे तो लोग बोले बड़ी लंबी उम्र है तुम्हारी। तो देखिए, पलट जैसे हम जाते हैं तो एक अहंकार का भी फैक्टर होता है कि कई बार हम बड़ा एरोगेंट हो जाते हैं, पर एक शायर ने एरोगेंस और एलिगेंस दोनों को मिला के एक शेर है, थोड़ा मजेदार शेर है, उम्मीद है आपको पसंद आएगा, कि वो दर्द देंगे सिसकियां देंगे, हम है कागज वो कैंचियां देंगे। वो दर्द देंगे सिसकियां देंगे, हम है कागज वो कैंचियां देंगे। जुगनुओं ने शराब पी ली है, अब वो सूरज को गालियां देंगे। शेर और मुझे याद आया कि जगह नहीं थी पर बना के बैठा हूं, जगह नहीं थी पर बना के बैठा हूं। मैं इस जगह से किसी को उठा के बैठा हूं और सवाल करने की हिम्मत नहीं रही, तो जवाब पे तकिया लगा के बैठा हूं। एक निदा फाजली साहब की नज्म है, सफर में धूप तो होगी, थोड़ा मैं एक दो शेर उससे सुनाता हूं कि सफर में धूप तो होगी, जो चल सको तो चलो। सभी हैं भीड़ में, जो तुम भी भीड़ से निकल सको तो चलो। बने बनाए हैं सांचे, जो ढल सको तो चलो। हर एक सफर को है महफूज रास्तों की तलाश, हर एक सफर को है महफूज रास्तों की तलाश। रिवायतों अगर बदल सको तो चलो। और इसका आखिरी शेर है कि यहाँ कोई किसी को रास्ता नहीं देता, यहाँ कोई किसी को रास्ता नहीं देता। मुझे गिरा के अगर तुम संभल सको तो चलो। निदा फाजली साहब के लिए ये एक मिनट के लिए अगर रोक सकें तो प्लीज लेट मी फिनिश 1 मिनट और। अब दो शेर हैं, चूंकि अर्चना मैम हमारी सीनियर फैकल्टी बैठी हैं और उनको पता है कि मैं एक सीजनल शायर हूं, जब फ्रेशर पार्टी फेयरवेल पार्टी होती है तो याद कर लिया जाता है। तो दो शेर स्टूडेंट वाले शेर हैं एचपी। तो पहला तहजीब हाफी का कि ये दुख अलग है कि मैं उससे दूर हो रहा हूं, और ये गम जुदा है कि वो खुद मुझको दूर कर रहा है। ये दुख अलग है कि मैं उससे दूर हो रहा हूं, ये गम जुदा है कि वो खुद मुझको दूर कर रहा है। तेरे बिछड़ने पे लिख रहा हूं मैं ताजा गजलें, ये तेरा गम है जो मुझे मशहूर कर रहा है। और आखिर में एक, चूंकि एचपी साइंस वर्ड बड़ा यूज करते हैं, तो एक शेर पे खत्म करूंगा कि हम भी मजबूर थे हालातों पे और उसको भी उसके खुदा ने रोक लिया। हम भी मजबूर थे हालातों पे और उसको भी उसके खुदा ने रोक लिया। हम करने वाले थे बेवफाई, फिर हमें न्यूटन के तीसरे लॉ ने रोक लिया। थैंक यू वेरी मच।
शुक्रिया डॉक्टर नावेद। Hello. As every journey must find its destination, we now come to the conclusion of this exciting evening. And what better way to end it with the universal language, music? Please join the final performance of the evening, a soulful group song that encapsulates the spirit of togetherness.
Check, check,
Check, mic check.
check, check, check.
Check.
Check, check. Bass,
check, check.
bass थोड़ा हाँ तुम चेक करो
Check.
बेस कम
Check,
चेक कर
check.
थोड़ा और कम चेक
Check.
Check.
गिटार गिटार की वॉल्यूम बढ़ा
3, 2, 1, start.
Rivers of Babylon, where we sat down. And we were tired. Rivers of Babylon, where we sat down. Yeah, we went when we remember time. Stop, if you're a star, if you're a star. There's your love, pick up the path. I don't care to go on and change the world. The sky is full of stars. I think that's all.
That makes me feel that kills me, makes me feel alive.
Said no more panic, don't lose your feet. Baby, I've been sleep. Dreaming about the things that we baby, I've been praying hard. Said no more panic, don't lose your feet. God is love.
Thank you so much.
Thank you all for being a part of this captivating evening. Let us all put our hands together one more time for all the performers who made this event unforgettable. And to our esteemed guests whose kind presence made this evening truly special. Thank you.
So, guys, how are you feeling now? Really? Science is out? Life is back? Very good. Hunger is in? Right? Serotonin is high? Serotonin is high? Adrenaline gone? Let's go for the dinner. So then let's go to the dinner to satisfy hypothalamus. So this way we close the second day with a pleasant remark. So all will go to the Wall Street for the dinner, and I'm very much thankful to our beloved Chaya madam. Without her, this would not be possible. You actually gave the final color to the conference. Thank you very much. Okay, pack up.